Hi, this is Shivaraman from Johns Hopkins University. Now, over the course of this lecture, I'm going to talk a little bit about the most current concepts in the CT evaluation of acute pancreatitis. Now, we're going to begin with a very brief discussion of background, including the pathophysiology and some of the most common causes of acute pancreatitis. But we are going to concentrate most in this lecture on making the diagnosis of pancreatitis on a CT scan, identifying significant complications that I think you as a radiologist should be able to identify, utilizing the most recent classification schemes and nomenclature systems in your own dictations, and then finally, how you can use your dictation to really affect how the patient is treated and intervened upon. Now, as all of you know, acute pancreatitis is incredibly common. There are somewhere in the order of 300,000 cases per year in the United States, and it is certainly one of the most common causes of abdominal pain in the ER setting. Now, to make the diagnosis of acute pancreatitis, you really have to have two of three features: a good clinical history of abdominal pain, a markedly elevated amylase or lipase level, or a characteristic CT scan. Now, notice that I said two of the three, not all three. So it is possible, albeit not that common, to be able to make the diagnosis based on a clinical history and a characteristic CT scan, even if your amylase or lipase levels are normal or perhaps just minimally elevated. Now, if you look at any textbook, there are literally dozens of different causes of acute pancreatitis. But that being said, regardless of where you practice, whether it's Hopkins or elsewhere, the vast majority of cases, probably in the order of 90 to 95% of cases, are attributable to one of two causes: alcohol abuse or biliary stones. And the other causes you may or may not see in your practice depending on where exactly you practice. So drug reactions, ERCP, hypotension, hyperlipidemia, hereditary pancreatitis, the list goes on and will really depend exactly on where you practice. Now, it is worth noting that acute pancreatitis is, for the most part, very well tolerated. The vast majority of patients are in the hospital just a few days. They're going to be treated conservatively. They're made NPO. They don't have any major complications. And most people are going to go home after a couple of days without any major sequelae. But that being said, it is worth noting that there is a small segment of patients with acute pancreatitis, most of whom have acute necrotizing pancreatitis, who have far worse clinical outcomes. And we've all seen these patients, right? They spend weeks in the ICU, months in the hospital, multi-organ failure, major complications, and many of these patients actually end up passing away. But that being said, it is worth remembering that the vast majority of patients are actually going to do quite well. Now, all too often when I'm working with a resident or fellow, people ask me, well, this patient has an elevated lipase level. Why are we wasting our time with a CT scan? What's the point? This is fundamentally a clinical diagnosis. And as far as I'm concerned, that's not true. As far as I'm concerned, CT does have a major role to play, both in terms of diagnosis, but also in terms of risk stratification and guiding treatment. First of all, it is important to remember, in the vast majority of cases, at least in my practice, we make the diagnosis of pancreatitis on a CT scan, and subsequently it's confirmed biochemically using a lipase level by the ER staff. So I think in most cases we make the diagnosis because CT is, after all, the most important screening tool in patients with nonspecific abdominal pain. Secondly, even once you make the diagnosis of pancreatitis, it is critical to figure out what the underlying cause of that pancreatitis is, and CT can play an important role there. Is this a case of gallstone pancreatitis, or one of those unusual cases where there's an underlying tumor, or maybe even a rare case of autoimmune pancreatitis? Just as importantly, once you've made the diagnosis, it is important to risk stratify the patient. Is this someone who's likely to have a good outcome, has a pretty benign CT scan, and can probably go home in a couple of days? Or is this someone who has major complications, is probably going to have a poor outcome, and probably needs to go to the ICU? So risk stratification can be very important in terms of deciding how exactly to deal with the patient, especially when they first come into the ER. Of course, you have to have that CT on admission to make sure there's no major complications. And if there are complications, CT is critical to help guide intervention. As I mentioned, one of the reasons why I think CT is so important is risk stratification. It is really important when the patient first presents to figure out whether this is a patient who's likely to have a good outcome or a poor outcome. Now, traditionally, if you go back in the past, risk stratification of pancreatitis was done using biochemical and clinical markers. And this is the classic formula, right? Ranson's criteria, a number of different biochemical factors put into a formula that allow you to predict a patient's outcome. Now, I think today it is less and less common to see our internist colleagues utilize the Ranson's criteria, and instead CT has really taken over as the primary risk stratification tool. Now, the original classification system or risk stratification system for pancreatitis on CT was the Balthazar system, first devised in the mid-80s and then revised again in the early 90s. Now, the Balthazar system really does something that should be intuitive to us, and that is that it makes a direct correlation between the severity of the patient's pancreatitis and their CT scan. So, in other words, the worse your CT scan looks, the worse the patient is likely to do. And that may seem intuitive, may seem simple, but it is actually a very fundamental key point in terms of the importance of CT. Now, the Balthazar system is pretty simple. A through E. A is a normal-looking pancreas, so you can have mild biochemical pancreatitis with a normal-looking CT scan, all the way up to a horrible-looking pancreas with lots of collections, retroperitoneal gas, and that's the Balthazar E. And of course, the degree of pancreatic necrosis is going to play a role here in terms of what the patient's grade is. Now, the Balthazar system has largely been supplanted by the revised Atlanta classification, which isn't fundamentally that different, right? It takes into account a number of different CT imaging features, the degree of necrosis, the presence of complications, spits out a formula that's going to help you predict whether the patient is likely to have a good or a bad outcome. Now, you don't need to memorize the revised Atlanta classification because honestly, I don't know anyone who actually uses it in their dictation. But it is important to understand what kind of things it puts emphasis on, and specifically to understand its emphasis on the degree of pancreatic necrosis, a numerical emphasis. Notice that there's a great deal of importance in this system on the number 30%. So patients with more than 30% pancreatic necrosis are at especially higher risk of having a poor outcome. So it is important when you're looking at these CT scans and there is evidence of necrosis to judge whether it's greater than or less than 30%. Now, as I mentioned, I don't use the revised Atlanta classification. I use the Fishman grading system, which is honestly probably much more practical and what the clinician wants to hear. They really want to know, based on the CT scan, is this mild, moderate, bad, really bad? In other words, how well or how poorly is my patient likely to do? So it's not enough in your dictation to just say the patient has acute pancreatitis, period. That is not a useful dictation. What is useful is to say, well, this patient has horrible pancreatitis with a bunch of complications. They have this and this feature, this much necrosis, and allow the clinician to paint a picture so the clinician can get a sense for whether this patient is someone who needs to go to the ICU and needs to be watched very carefully, or alternatively, is this one of those run-of-the-mill cases of pancreatitis that can go to the floor and is likely to be out of the hospital in a couple of days. Now, how do we image these patients? Now, I'm a strong believer that anyone with suspected pancreatic pathology, and that includes pancreatitis or pancreatic masses, needs a dual-phase CT. So we're going to acquire arterial and venous phase images at roughly 30 to 35 and 60 to 70 seconds respectively. Now, we do not give these patients positive oral contrast, not only because it interferes with 3D post-processing, but also because it can create beam hardening and streak artifact, especially when pooled in the stomach, that might potentially obscure a subtle stone in the ampulla or even an underlying pancreatic mass. Instead, just give water. We give about 1 liter of water as a neutral agent. It distends the stomach, and it works perfectly well without creating all these other problems in terms of interpretation. Now, it goes without saying you really do need to give IV contrast. I hate looking at acute pancreatitis cases that are non-contrast. You're not going to be able to pick up necrosis, pseudoaneurysms, and a bunch of other complications. I really do think patients need an initial contrast study, and we give 120 cc's of non-ionic IV contrast at a brisk injection, typically about 3 to 5 cc's per second. Now, when you're talking about acute pancreatitis on a CT scan and making the diagnosis, I really do think you're better off looking at this as two separate, closely related diagnoses. One diagnosis is acute interstitial edematous pancreatitis, far more common, and relatively benign in terms of its clinical impact. And on the other hand, acute necrotizing pancreatitis, which is far less common and far more clinically severe and more likely to cause long-term issues. Now, interstitial edematous pancreatitis accounts for somewhere in the order of about 3/4 of all cases. These patients, by definition, have a normally enhancing pancreas, so there is no evidence of underlying necrosis. And so to make this diagnosis with confidence, you have to have an IV contrast scan, right? You can't tell whether or not the pancreas is enhancing normally if you don't give intravenous contrast. Now, it's important to remember, at the most mild end of the scale, you can have a normal-looking CT scan and have very mild edematous pancreatitis based on an elevated lipase. And this actually occurs more often than you think, probably in the order of about 25% of cases. But in most cases, you're going to see some findings suggesting edema. an enlarged, edematous-looking pancreas, loss of normal fatty lobulations, some peripancreatic fat stranding, inflammation, and free fluid. And typically that fluid will track along the anterior pararenal spaces, and you may even see some thickening of Gerota's fascia. Now here's a classic example of acute pancreatitis, right? You can see that the pancreas is enlarged, you're starting to lose some of those lobulations, and there's lots of peripancreatic free fluid and inflammation. Most importantly, you're going to track along and look at the entire pancreas, and you see that there's no areas of non-enhancement or severe hypoenhancement. So this is acute edematous interstitial pancreatitis. Here's another case. This is a patient who had a recent ERCP. Again, notice that the pancreas is big, it's edematous, it looks more packed in, there's loss of fatty lobulation, there's some peripancreatic edema and fluid. This is edematous pancreatitis. Note that the entire pancreas is enhancing normally. Now, it's not always the case that your pancreas is going to look big and edematous. There are cases, as in this instance, where the pancreas itself may look relatively normal in size, maintained fatty lobulations, but it's that subtle peripancreatic edema and stranding that gives away the diagnosis of edematous pancreatitis. Now, as I mentioned, edematous pancreatitis is very well tolerated. The vast majority of patients are not going to have any complications, and in most instances, as long as their initial staging CT scan did not show any complications, you do not need to routinely follow up these patients with another repeat CT, provided that their lipase trends down and they're clinically getting better. The only reason to do a follow-up scan in these patients is A, they had a complication that you need to follow up, like a fluid collection, or B, they're getting worse clinically and you're worried that they've developed pancreatic necrosis or some other complication. Now, I think it's important to remember that the pancreas is not the only organ in the anterior pararenal space. It shares that anatomic space with several other entities, including the duodenum, the ascending colon, and the descending colon. So it is theoretically possible, and in fact not that uncommon, that pancreatitis can be mimicked by other pathology, including duodenal ulcer disease, colitis, diverticulitis, so on and so forth. And these are obviously entities that are treated very differently, carry very different prognoses, and really it is important to make the clinical distinction. So here's an example. This is a patient who, just based on this image alone, I think all of us would probably consider the possibility that this is likely acute pancreatitis, right? There's fluid tracking along the right anterior pararenal space. There's fluid in the vicinity of what I think is the pancreatic head and duodenum, probably acute pancreatitis, right? Well, wrong. If you look more carefully, you look a couple of slices below and you use the coronal reformats, you realize that this fluid and edema is actually centered not around the pancreatic head, but rather is centered along the duodenal sweep. There's actually fluid and ectopic gas tracking from the duodenum. This is a perforated duodenal ulcer. And if you just kind of said this was acute pancreatitis without thinking a little hard, you potentially would have given this patient a completely incorrect treatment. Now, as I mentioned, there are two forms of pancreatitis. Necrotizing pancreatitis, the second form, is much less common, no more than about a quarter of all cases, but is certainly much more clinically severe and much more likely to cause major clinical morbidity and mortality. By definition, pancreatic necrosis implies that you have either diffuse or focal areas of either non-enhancement or severe hypoenhancement. So it goes without saying, really, to make this diagnosis, you have to have a contrast-enhanced study. As I mentioned earlier, there's nothing I hate more than reading a non-contrast study in a patient with known acute pancreatitis, because really you're not providing a lot of useful information. You're not going to be able to identify many complications, and you're certainly not going to be able to confidently identify pancreatic necrosis. As I mentioned earlier, the Atlanta classification, or revised Atlanta classification, puts a great deal of emphasis on the number 30%, right? Patients with more than 30% necrosis are at far higher risk of a poor outcome, so it is important in your dictation to give a numerical estimate. If you think there's necrosis, you want to say, is there 10, 30, 50, 70, 90? Now, you can't be entirely certain that that number is correct, but you want to at least give your best educated guess as to the percent of parenchymal necrosis, because that is going to directly impact how well or how poorly that patient is likely to do, and can really impact the clinician's decision on how exactly or how intensively the patient needs to be treated. Now, pancreatic necrosis results from thrombosis of the microvasculature feeding the pancreas. And that's because you have all these enzymes that are leaking out, these proteolytic enzymes that potentially are going to damage that microvasculature and cause thrombosis. So it's not surprising that thrombosis or microthrombosis can take some time to develop. And accordingly, it is very common that you could have a normally enhancing pancreas at presentation, but subsequently develop pancreatic necrosis a couple of days later. So there is nothing wrong with re-imaging patients who have what looks like edematous pancreatitis at presentation, but are clinically worsening, are not getting better, their lipase is not trending down, and it's very important to reimage these patients because you may see evidence of pancreatic necrosis on the follow-up. Typically that follow-up, if you do it at about 2 days, 2 to 4 days, that's when you're most likely to identify evidence of developing necrosis. Now this is of course a clinically significant diagnosis. Vast majority of patients will develop at least single organ failure, many will develop multi-organ failure, and the mortality rate somewhere in the order of 12 to 30%, really depends on how severe the necrotizing pancreatitis is. Now the CT imaging features are distinct from what we talked about earlier in edematous pancreatitis. These patients have areas of either non-enhancement or severe hypoenhancement, and typically there's a lot of inflammation. You're going to see usually what looks like a massive phlegmon surrounding the pancreas. You may have trouble finding normal pancreatic parenchyma, and you're going to see this ill-defined hypodensity, fluid, and inflammation replacing where you'd normally find pancreatic parenchyma. Now in this case, you can see that there's a big phlegmon in the retroperitoneum. There are certain areas of the pancreas that look like they're enhancing normally, but frankly, I can't find much of the tail segment, can't find much of the head segment. So this is a patient who probably has 30 to 50% parenchymal necrosis. Here's another example that looks very similar. Big phlegmon in the retroperitoneum, very little residual pancreas, a little bit of head I can still see, a little bit of tail, but the entire mid portion of the gland is gone. Classic necrotizing pancreatitis. Again, I would guess probably in the 30 to 50% range. Now, even though in most cases you will see a big phlegmon replacing the pancreas, there are instances where the pancreatic shape may be preserved and you may see ill-defined areas of liquefaction within what is a normally shaped pancreatic gland. Here's an example where I think it would be pretty easy to say that this is just edematous pancreatitis, right? I don't see a big phlegmon, there's no big fluid collection, but if you look carefully, there are some areas of liquefaction. There is ill-defined hypodensity within the gland, so this patient does in fact have quite significant parenchymal necrosis. Now, I do want to make a distinction between two terms that people confuse all the time. There's pancreatic necrosis, which really means you have parenchymal necrosis or non-enhancement and carries with it the implication that you're at significant risk for morbidity and mortality. And then there's extrapancreatic necrosis, which is quite distinct. This implies nothing about the pancreatic parenchyma itself, but rather is a term used to describe the leakage of pancreatic enzymes into the peripancreatic fat with subsequent peripancreatic fat necrosis. Now, this does carry a slightly worse prognosis, but really doesn't have a major impact in terms of patient morbidity and mortality. So why do you worry about it? Well, the main reason is that extrapancreatic necrosis, like other forms of fat necrosis, can look very nodular, can look mass-like, and can be very confusing on a CT scan. I've seen many cases where this has actually been confused for carcinomatosis or tumor spread, and it can look very much like that. You can get nodularity, thickening of the paracolic gutters, base of the mesentery, and if you don't really, if you've never seen this entity before, it's very easy to mistake it for something much more foreboding. So here's an example. This is a patient with acute pancreatitis. It was edematous pancreatitis. The pancreatic parenchyma itself was enhancing normally. And what about all this sheet-like tissue along the left anterior pararenal space extending downwards along the left paracolic gutter? Could be carcinomatosis if you told me the patient had pancreatic cancer, but they don't have pancreatic cancer. They just have pancreatitis. This is fat necrosis that went away on a follow-up scan. Here's another one. This patient, it was actually, this is a nice case that was sent to me by one of my ex-fellows who's now out in Oklahoma. And you can see that the pancreas is inflamed, edematous, enlarged. The patient had acute edematous pancreatitis. Unfortunately, it was a non-contrast scan. He was worried about this fullness in the pancreatic head, and what do you do about all this ill-defined induration and nodularity along the mesentery and the paracolic gutters? And so he asked me, do you think this potentially could be a pancreatic cancer with carcinomatosis? And I told him, yeah, it's possible. It's hard to exclude that without contrast, but I think this is most likely to represent extrapancreatic fat necrosis, and that's what it was. All of this resolved on follow-up. Now, once you've made the diagnosis of acute pancreatitis, and you've determined whether or not it's edematous pancreatitis or necrotizing pancreatitis, your job isn't done. You've just moved on to the second step. And the second step is to identify a number of common complications that I think are critical to be able to identify and that may have implications in terms of treatment. So let's start by talking about a couple of complications that are specific to patients with necrotizing pancreatitis, and that's infected necrosis and central gland necrosis. Then we'll move on and talk about fluid collections, and specifically the nomenclature suggested by the revised Atlantic classification, and how different types of fluid collections are treated very differently. And then finally, we'll talk about what I think is the most important complication, and that's vascular abnormalities, including venous thrombosis and arterial pseudoaneurysms. Now, when you have someone who has pancreatic necrosis, one of the complications you most worry about is infected necrosis. This is somewhere in the order of about a quarter to a third of patients with necrotizing pancreatitis, and it implies superinfection by bacteria of the necrotic pancreatic parenchyma. Now, these patients are at very, very high risk for a poor outcome. In fact, if you don't treat these patients appropriately, infected necrosis has a mortality of essentially 100%. Now, this usually occurs about 2 to 3 weeks after clinical onset, but I've seen it earlier, so the time course, as far as I'm concerned, doesn't help you that much in terms of formulating a diagnosis. Now, it is important to remember that these patients typically are not just treated with IV antibiotics or even putting in a surgical drain, but usually the presence of infected necrosis does imply that you need to go in, surgically debride the patient, and do a necrosectomy. Now, in many cases, you're not going to be able to make a specific diagnosis on a CT scan. You're going to see a big phlegmon, lots of inflammation, pancreatic necrosis, but in many cases it's going to be difficult to make the distinction between sterile necrosis and infected necrosis. And in those cases where the CT scan is not definitive, you may need to actually aspirate or biopsy the pancreatic parenchyma or the pancreatic bed and see if anything grows out, especially if there's a strong clinical concern that the patient is infected. On the other hand, there is one imaging feature that allows you to make the diagnosis with virtual certainty, and that's the presence of extraluminal gas in the pancreatic bed. In a patient who's never been biopsied, never been intervened upon, never had a drainage catheter, extraluminal gas equals infected necrosis. You don't get ectopic gas in the pancreatic bed in patients with sterile necrosis. So if you see extraluminal gas, you're going to call it infected necrosis, and that patient does in fact usually need surgical debridement. So here's an example. This patient has necrotizing pancreatitis. You don't see much of the pancreatic head, neck, and body. There's actually hemorrhagic transformation. But this patient has never been biopsied, never intervened upon. There is ectopic gas in the pancreatic bed. This is infected necrosis. And the patient went on to get a necrosectomy. Here's an even worse case. Not much of the pancreas left. There's actually a big air fluid level where you'd expect the pancreas to be. Classic infected necrosis. And again, this is a patient who went on to the operating room to get debrided. Now, another complication you need to be thinking about specifically in patients with necrotizing pancreatitis is central gland necrosis. And this has a number of different names: mid-gland necrosis, disconnected duct syndrome, and so on and so forth. And there's a few other terms you'll hear out there. And these are really fancy terms to describe something that's pretty simple, right? It implies that you have necrosis of the central portion of the gland along with its pancreatic duct, while the body and the tail are spared. The head and the tail are spared. And what happens in these situations is because the central portion of the gland is necrotic along with its duct, you get continual leakage of pancreatic enzymes both from the head and the tail into the central portion of the pancreatic bed, and you develop a big fluid collection. And so in essence, this happens because the pancreatic duct in the central portion of the gland is disrupted, and you end up forming a fluid collection where the pancreatic enzymes collect. Now, this is an important diagnosis to make because that fluid collection is not going to be adequately treated by putting in a percutaneous drain. If you do put in a percutaneous drain, the collection is really never going to go away, and really you're going to be kind of stuck. Instead, patients who have real central gland necrosis need to be treated with either a distal pancreatectomy or an internal drain, typically a cystgastrostomy. Now, in many cases, you're going to be able to imply the presence of central gland necrosis based on the CT, just based on the distribution of necrosis. So if I see the central gland completely gone, there's a fluid collection replacing it, but I still see what looks like an intact head and tail, I'm going to raise the possibility of central gland necrosis. And this is a diagnosis that in some cases you can make based on MRCP, but to be honest, ultimately, to prove the diagnosis, you need an ERCP. So here's an example of a case where I wasn't sure. There's a fluid collection replacing part of the pancreatic body, but I thought maybe there was still some pancreatic parenchyma remaining posteriorly. But I wasn't sure whether the duct was still intact or not because there was that big fluid collection replacing the central gland. So we recommended the patient that the possibility of central gland necrosis be considered. It was proven at ERCP, and they ended up putting in a cystgastrostomy. Here's another example. Again, you can see the tail is intact, the head is intact, but there's a big phlegmon replacing, or fluid collection replacing the central necrotic gland. This is central gland necrosis. So let's talk next about another category of complications, and that's fluid collections. Now, all too often, we tend to be pretty imprecise when describing pancreatitis-related fluid collections. Everything's a fluid collection, loculated collection, abscess. We use all these terms that really mean something very different to us than they do to our referring gastroenterology colleagues, especially our colleagues in surgery and gastroenterology who deal with a lot of acute pancreatitis. Different types of fluid collections in acute pancreatitis have different nomenclature or different names, and different types of collections carry very different implications in terms of how they're treated or intervened upon. Some collections can be followed conservatively, whereas others, you would argue, probably need to be drained. Now, in general, the nomenclature that you're going to be using, based on the revised Atlantic classification, will depend on whether you're dealing with a patient who has edematous pancreatitis or necrotizing pancreatitis, and the time course in which that fluid collection is developed. Now, in patients with edematous pancreatitis who develop a fluid collection in the first 4 weeks after clinical onset, the term you're going to be using is an acute peripancreatic fluid collection. And as that collection evolves over time, after 4 weeks, then you use the term pseudocyst. And remember, pseudocyst is a term we're all guilty of using way too often. I read reports and people call everything a pseudocyst. But technically, a pseudocyst is a collection that's been around at least 4 weeks in a patient with edematous pancreatitis. On the other hand, in a patient with necrotizing pancreatitis, a collection in the first 4 weeks that's ill-defined and not yet completely loculated is a post-necrotic fluid collection. And as that collection evolves and becomes loculated after 4 weeks, then the term you're going to use is walled-off necrosis. Now, in edematous pancreatitis, collections in the first 4 weeks, we're going to use the term acute peripancreatic fluid collection. These are collections that are simple in appearance. Remember, they're going to be composed purely of pancreatic enzymes. They're not loculated. They don't have an appreciable wall. They conform to the shape of the retroperitoneum. And because there's no necrosis, you shouldn't be seeing any evidence of internal hemorrhage. You shouldn't see internal blood products or other necrotic debris. These collections almost always go away on their own, and you only need to treat them if there's evidence of infection, which there almost never is. So these should be conservatively treated. There's no reason to put a needle into one of these collections in an asymptomatic patient. Now, these collections typically go away on their own, but in those cases where they don't go away on their own, they evolve into loculated collections, which after 4 weeks are termed pancreatic pseudocysts. Now, these are now well-defined loculated collections that have a clearly defined wall composed of fibrosis or granulation tissue, and no longer just conform to the shape of the retroperitoneum, but actually exert mass effect. Now, even pseudocysts, for the most part, do not often create clinical problems. At least half of these will resolve spontaneously, and only about a quarter will actually cause symptoms, pain or infection. Now, pancreatic pseudocysts can occur anywhere, but of course they occur in the most common places where you'd expect, given where the pancreas is located. So the right and left anterior pararenal spaces, the lesser sac, but honestly, pseudocysts can go almost anywhere. I've seen them track into the spleen, track up into the mediastinum, intraperitoneal, retroperitoneal, soft tissues. If you can think of a location and some way in which they could conceivably get there, a pseudocyst can get there. So here's a nice chart that really nicely illustrates the evolution of an acute peripancreatic fluid collection into a pseudocyst. Notice that initially the collection in the upper left is conforming to the shape of the retroperitoneum. It's non-loculated, but over time it becomes loculated with a well-defined enhancing wall and starts exerting mass effect on the stomach. And you can see in the last image on the bottom right, they've put in a cystgastrostomy. Now, the most common location is in the lesser sac, and usually not a problem, but they can grow quite large and can cause symptoms as a result of mass effect on the adjacent stomach or duodenum. And as I mentioned, they can go almost anywhere. Here's an example of pseudocyst actually tracking into the spleen. So if you see a fluid collection, you're not sure what it is, the patient has a history of acute pancreatitis, at least think about the possibility of a pseudocyst. Now, as I mentioned, pseudocysts should generally be managed conservatively. There is no reason that you should be putting a drainage catheter or a needle into a pseudocyst in a patient who's completely asymptomatic. If these are asymptomatic, they are merely incidental findings that do not need to be dealt with. The only reason you drain these or put a needle into it is if you think it's infected or if it's causing symptoms because of mass effect. So it's causing bowel obstruction, biliary obstruction, or just patient pain. Now, in those cases where you do think potentially that you need to put a drainage catheter into it because of symptoms, be very careful about putting a catheter in, especially when the pseudocyst is adjacent to the pancreas, because many of these will still communicate with the pancreatic duct. And if you put a percutaneous drain into one of these collections that still communicates with the duct, that drain is never going to come out. So patients that still have a communication between a pseudocyst and the main pancreatic duct need to have internal drainage, either endoscopically or surgically placed. So this is a very complex slide talking about the algorithm for dealing with pseudocysts. I think it's much more simple than this. Bottom line, don't do anything about asymptomatic pseudocysts. Only deal with pseudocysts that are symptomatic. If they are symptomatic and they're in close proximity to the pancreas, do an ERCP first to make sure there's no communication between the pseudocyst and the duct. And if there is communication, they probably need to be drained internally. If there's no communication, then they can be drained percutaneously by a radiologist. Now, if you're going to do this internally, internal drainage, because there's communication, it can be done either surgically or endoscopically, but almost all cases nowadays are done endoscopically, at least at Hopkins. So here's an example of a pseudocyst in the lesser sac. It was causing patient symptoms of gastric outlet obstruction because of its location. We appropriately recommended the patient get an ERCP first. There was, in fact, a communication with the duct, so the patient ended up getting an internal cyst gastrostomy. Don't get yourselves in trouble by trying to put a percutaneous drain in a collection where you're not entirely certain whether it communicates with the duct or not. Now, the nomenclature we're going to use in acute necrotizing pancreatitis is different. In the acute setting, typically in the first 4 weeks, we're going to use the term post-necrotic fluid collection. Now, these collections look very different than the acute peripancreatic fluid collections that we talked about in edematous pancreatitis. These patients have necrosis, so these collections look very heterogeneous, inhomogeneous with solid necrotic debris, hemorrhage, blood products, fluid levels, all kinds of stuff. So they look very, very heterogeneous. Often these are associated with ductal disruption, and there is some debate as to how best to treat these collections. There are some institutions where post-necrotic fluid collections, because they offer a great environment for superinfection and this development of infected necrosis. There are some institutions where they would argue that all of these collections need to be drained preemptively to prevent subsequent infection. But that's not true everywhere. There are some institutions where these collections are just treated conservatively. Here's an example. This patient had necrotizing pancreatitis about a week ago. Big fluid collection replacing much of the pancreas. Because of the time course, notice that and because of the lack of loculation, you're going to use the term post-necrotic fluid collection. Here's another post-necrotic collection that's actually intraparenchymal within the pancreatic head. Notice that it's inhomogeneous, has some internal hemorrhage. This is a post-necrotic fluid collection. Now, this is one of the reasons why, an example like this, why some institutions will preemptively drain these collections, because you can go on to develop infected necrosis. Notice that this patient has a post-necrotic fluid collection replacing much of the body and tail segments, and there's now multiple foci of internal gas. And remember what I said earlier. Ectopic gas in the absence of intervention implies that you do, in fact, have infected necrosis. Now, if for whatever reason you don't intervene on these collections early, they will eventually evolve into a discrete loculated collection that you're then going to term walled-off necrosis. Now, these collections have been around at least 4 weeks. They are a mature collection that now has a well-defined wall, and for the most part can be sterile or infected, but if infected, there's a significant risk of higher morbidity and mortality, probably a mortality rate double. So you do want to look for the presence of gas within these collections. Now, walled-off necrosis can sometimes, if you don't know the patient's history, can be difficult to distinguish from a pseudocyst just based on a CT scan. Some cases of walled-off necrosis will look relatively homogeneous and low density and simple in appearance on CT. And this is one of those situations where MR can be quite helpful. It can really illustrate on T2-weighted images nicely the internal heterogeneity within these collections, including the necrotic debris that may not be readily apparent on a CT scan. And that can have some impact if you choose to drain walled-off necrosis, as usually walled-off necrosis, unlike a pseudocyst, will require a large bore catheter, internal drainage, or necrosectomy. Here's an example of walled-off necrosis. Notice the pancreatic head and neck are gone. There's a slightly inhomogeneous collection replacing the pancreatic parenchyma. This has been around for a while. Notice that it's got a well-defined wall. This is walled-off necrosis. Here's another example. This is a collection that's been around for a while. Notice the inhomogeneity, the internal debris, maybe even internal blood products. Classic walled-off necrosis. So here's a nice chart from radiology a few years ago illustrating or discussing the treatment options for different forms of fluid collections. I think the key thing from a radiology perspective is to really understand that different collections have different names, and those names matter. It's not good enough to just say that it's a collection or to say that it's an abscess or call everything a pseudocyst, because different types of collections do in fact have very different treatments. And if you use the wrong term, at the very least, it may make you look bad in front of your referring clinicians. At the very worst, it may lead the patient to get the wrong treatment. Now, don't use the term pancreatic abscess. This is a term that's not included in the revised Atlantic classification. It's imprecise. You can all see that, see how it could potentially apply to any of the previously mentioned terms we discussed previously. This is not a good term to use. I don't use it in my dictations ever. So let's talk next about our last type of complication, and that's vascular. And these are really the complications that I fear the most as a radiologist. You do not want to miss a vascular complication because the next thing you know, the patient could have bled out from a pseudoaneurysm, or they could have bowel ischemia because of a venous thrombosis. So you really have to take the time, look carefully at the major vasculature, and make sure that there's nothing that you're missing. Now, this is one of the reasons why I really do believe patients need dual phase studies to look at pancreatitis, because many of these vascular complications, especially on the arterial side, can be really tough to see on the venous phase. You know, I actually saw a case a couple of years ago where the patient ended up bleeding out, had a huge bleed, came in from an outside hospital, and you look at this outside CT, it was a venous phase study, and I couldn't see anything. I wasn't sure why the patient was bleeding. But then we repeated the scan internally, did an arterial phase, and there was about a centimeter and a half pseudoaneurysm. It's easier than you think to miss pseudoaneurysms if you don't have good dual phase studies. So try to get both arterial and venous phase images as part of your protocols. Now let's start by talking about venous thrombosis, which is probably more common. Very common as a result of intimal injury to the vessel from adjacent inflammatory change, but can also occur as a result of mass effect and compression of the vein by surrounding phlegmon or fluid collection. It's not surprising, given its anatomic position, that the splenic vein is the most commonly thrombosed vessel, but the SMV and the portal vein can be affected as well, albeit less commonly. Now, always be clued into the presence of possible thrombosis anytime you see varices. If you see varices that you can't explain, you need to go back and look and see whether there's either thrombosis or severe mass effect on the veins that's causing narrowing. Here's an example of an SMV thrombosis. These are easier than you'd think to miss on the axial images, largely because if you're going really fast and scrolling through the axials, very easy to overlook a short segment thrombus, but very easy to identify in a case like this when you look at the coronals. Here's another example. Again, even if you didn't see the thrombosis, the presence of these large gastropaploic and omental collaterals means that you've got to have something wrong with your central mesenteric vasculature. As I mentioned, most cases are thought to result from direct impact of those proteolytic, those enzymes on the intima of the vasculature, but these can also develop over the course of a few days if you have constant compression and mass effect on the vein by surrounding fluid collections or phlegmons. Here's a patient where on this image you can see that the SMV is narrowed by the surrounding fluid collection. On a follow-up a couple of days later, the SMV was thrombosed. Now, pseudoaneurysms are critical diagnoses not to miss, right? If you miss a pseudoaneurysm and it ruptures, the mortality rate is essentially 90%. So as I mentioned, arterial phase imaging is key. It is not good enough to just get venous phase images, especially when the patient first presents with pancreatitis. And I would argue follow-ups you might be better off getting, at least in the acute setting, you might be better off getting follow-ups with dual phase imaging as well. Now, these occur because the pancreatic enzymes leaking out into the interstitium weaken the arterial wall, and you get formation of pseudoaneurysms. As with the venous side, it's the splenic artery that's the most commonly affected, but any vessel can be involved, and the second and third most common vessels are the GDA and the pancreatic duodenal arcade. But any vessel can be involved, so it is important to look at everything. I always, on every pancreatitis case, create MIP reformats, usually in the coronal plane, from my arterial phase images, and I spend a couple of minutes looking carefully to see if there's any kind of a pseudoaneurysm that I've missed. Now, this is where you want to catch it, right? This patient has a sub-centimeter pseudoaneurysm. There's a small amount of hematoma, so it's certainly on the verge of rupturing. This patient ended up going to angio, did fine, no problems. This is what you want to avoid. This is about a 2-centimeter pseudoaneurysm. It's ruptured. There's large hemoperitoneum, huge hematoma in the left anterior abdomen. This patient was hemodynamically unstable, ended up having a very rocky hospital course. Now, once you've identified complications and used your dictation to help guide treatment, your job still isn't done. Your last role as a radiologist is to look at those images and figure out, is there anything I can tell the clinician about why exactly this patient has pancreatitis? And the three entities you're going to be thinking about are gallstone pancreatitis, autoimmune pancreatitis, and an underlying malignancy. Now, as I mentioned, gallstones are one of the two most common causes of acute pancreatitis. And I will admit, gallstones are clearly not a strength of CT, but it is something that you can diagnose now and then. So if you see gallstones, that is something that you need to prominently talk about in your dictation, because gallstones are, after all, a very plausible explanation for why this patient would have pancreatitis. Now, much more difficult as a diagnosis is picking up those rare cases of autoimmune pancreatitis. Now, I've got to say, like during my training, I saw very few cases of this entity, maybe a couple. But now as an attending at Hopkins, and maybe it has to do with our patient mix here at Hopkins, but I've seen lots of these cases. I'd say that we see several of these every year, and we've saved several patients just in the course of the last 2 or 3 years that I know of that were thought to have either edematous pancreatitis or pancreatic cancer, and where we've been able to suggest autoimmune pancreatitis and the patient really has been treated appropriately, whereas they might not have without the imaging. Now, this really is a form of chronic pancreatitis, not acute pancreatitis. And accordingly, these patients do not present with the typical symptoms of abdominal pain as you would in the acute edematous setting, but rather with symptoms that are more akin to malignancy. So often they'll have weight loss, diabetes. Now, these patients, if you're able to suggest a diagnosis prospectively, can be treated with steroids, and often they respond quite vigorously. So within the course of a few days, their CT scan can get dramatically better. Now, in those cases where you're not sure, autoimmune pancreatitis, in some cases at least, will be associated with an elevated IgG4 level, and if it is, it's a diagnosis that's relatively easy to confirm biochemically. Now, autoimmune pancreatitis tends to be diffuse in most cases. So in most cases, you're going to see a diffusely enlarged pancreas, albeit with an absence of peripancreatic stranding, edema, or fluid. So unlike edematous pancreatitis, where typically a really big pancreas is going to have lots of surrounding inflammation, here you're going to see a really big pancreas with a conspicuous absence of surrounding inflammation. Now, if you're lucky, you're going to see this low attenuation capsule or rim around the margins of the pancreas, and that capsule, or halo, as some people call it, will actually show delayed enhancement if you acquire multi-phase imaging. Now, often these patients do have other signs of IgG4-related disease, and the most common of which is usually going to be IgG4-related cholangiopathy. So look for evidence of biliary dilatation, strictures of the distal CBD, and often the CBD will look thickened and abnormally hyperenhancing. Now, the pancreatic duct should typically be small or narrowed, and that narrowing of the pancreatic duct may be diffuse or segmental. Now, autoimmune pancreatitis is fundamentally an autoimmune process and is often related to other forms of autoimmune disease. So look for evidence of strange lesions in the kidneys, salivary gland enlargement, retroperitoneal fibrosis, unusual lung disease, mediastinal adenopathy, and so on and so forth. And all of those ancillary features may help you arrive at the correct diagnosis. Here's a classic example. Big pancreas, notice the conspicuous absence of surrounding edema and stranding. And to top it off, there's this subtle halo of hypodensity around the margins of the pancreas, classic edematous pancreatitis. Here's another example, big, boggy pancreas, and you'll hear the term sausage-like enlargement of the pancreas, which refers exactly to this morphology. Notice again that despite the signs of the pancreas, the loss of fatty lobulation, I don't see much in the way of surrounding edema and stranding, so this probably isn't edematous pancreatitis. And to make the diagnosis, note that you see that there's this rim of, or halo around the margin of the pancreas. This is classic autoimmune pancreatitis confirmed with an elevated IgG4. Now, as I mentioned, there's often going to be evidence of other IgG4-related sclerosing disease. In this case, this is one of the more common manifestations that I've seen in my own practice, these unusual lesions in the kidneys. They can be mass-like, they can be wedge-shaped, usually hypodense, and people don't exactly know what these are, whether they're infarcts, ischemia, focal inflammatory masses. Regardless of the cause, it's actually not that uncommon. So anytime you see these other manifestations, at least consider whether your pancreatic findings don't necessarily reflect acute pancreatitis or conventional pancreatitis, but rather autoimmune pancreatitis. Finally, let's talk a little bit about pancreatitis versus malignancy. And this is an easier distinction in theory than it is in practice, right? I think all of us are worried about missing pancreatic cancers, right? It's horrible prognosis. You have a pretty small window in many cases to actually catch the tumor when it's resectable and when the patient can still be treated. And you certainly don't want to call something acute pancreatitis when there's an underlying malignancy, and then they come back and they've got metastatic disease and they're no longer treatable. So you do always want to consider the possibility of an underlying malignancy, especially given that pancreatic cancer can actually cause pancreatitis and present with pancreatitis somewhere in the order of about 3 to 5% of all cases. Now, in many cases, it can be tough. Pancreatitis can be focal or mass-like and can look a lot like a cancer, and if you're not certain, you may just need to get a follow-up, maybe in a week or a few days after the inflammation is resolved, just to make sure that there's not an underlying mass. But that being said, I do think that there are some features that should at least that should start setting alarm bells in your mind that you might be dealing with an underlying mass. First of all, remember that a dilated pancreatic duct, especially an obstructed pancreatic duct or obstructed CBD, is pretty rare in acute pancreatitis. Yeah, you could see it in patients who have chronic pancreatitis, I guess, but realistically, if you see an obstructed duct, you're probably not just dealing with acute run-of-the-mill edematous pancreatitis, you're dealing with something more, and you really need to work that patient up further for an underlying occult lesion. Secondly, acute pancreatitis tends to infiltrate anteriorly into the mesentery, right? You're going to see stranding and edema go anteriorly out into the leaves of the mesentery, outwards into the pararenal spaces. That is very different than pancreatic cancer, which infiltrates posteriorly into the retroperitoneum. So if I see posterior infiltration, I'm going to worry about a tumor, and again, I'm going to work the patient up further. So here's a good example. This patient has pancreatitis, no doubt. The pancreas is enlarged, it's edematous, there's surrounding stranding and edema. But notice that the common duct is obstructed, there's a pancreatic duct stent, and if you look carefully, there's actually an obstructing mass at the level of the pancreatic head. So always at least consider the possibility there could be an underlying mass. So in summary, I really believe that it is critical when you're approaching a patient with acute pancreatitis on a CT scan that you take an algorithmic approach. There's a lot to look at, there's a lot to think about, there's a lot of different possible complications that you need to be on the lookout for. And if you don't have that algorithmic, reproducible approach, it's really easy to let things go that end up being clinically significant. As far as I'm concerned, when you're looking at these scans, your first goal is to make the diagnosis. Do they have pancreatitis or not? And then to figure out whether or not they have edematous pancreatitis or necrotizing pancreatitis. Once you've made the diagnosis, you want to then figure out what the severity of the process is. Is this a patient who's likely to have a good outcome, or on the other hand, a poor outcome that requires more intensive care in the hospital? You want to figure out, are there complications? Is there evidence of necrosis? Are there fluid collections? Are there major vascular complications that need to be treated urgently? And beyond that, you want to put together a dictation that really is going to help your clinicians in terms of guiding treatment. Use the right terminology, use the terminology recommended by the Revised Atlantic Classification, because the terms that you use in your dictation have very significant and specific implications as to how the patient should be treated. So that's all for now. Thanks again, and I'll see you guys later.
Hi, this is Dr. Karen Horton from Johns Hopkins. I'll be speaking to you about CT of cystic pancreatic masses. Due to the widespread use of CT and MRI, this has really facilitated the discovery of pancreatic cysts. Often, this will occur in asymptomatic patients, so we're finding incidental pancreatic cysts, and we're going to discuss that. And this certainly presents a challenge for both the radiologists and clinicians, and a challenge for the patients as far as how do they manage this and if it needs to be treated or not. So what is the frequency of pancreatic cysts? Well, it depends on what part of the literature you're looking at. So if you look at CT, those studies where they look at CT scans and see how often they find an incidental pancreatic cyst, it happens between 1% and 3%. Now, MR is going to be much more sensitive. So those studies, it could be between 14 and 20% of patients will have incidental pancreatic cysts. Now, often these are just a couple millimeters. And so but we still have to decide what we're going to do with those. About 10% of people over the age of 70 are now diagnosed with pancreatic cysts, so they're definitely more common as people age. And so as a busy radiologist, you're going to see this in your practice every day. So you're going to have to be comfortable diagnosing them and giving a differential and recommending follow-up. It used to be thought that pseudocysts were the most common incidentally detected pancreatic cysts, but this is in the old days. And now what we see as the most common incidentally detected pancreatic cyst is actually pancreatic cystic neoplasm. So things like serous cystadenomas, mucinous cystic neoplasms, and IPMN. And that accounts for most of the cysts that we find incidentally. Now, it's important as we go on the discussion to keep in mind that most incidentally detected pancreatic cysts are actually benign or at worst low-grade indolent tumors that may not require aggressive treatment. However, some incidentally detected cysts that you're going to see, especially the mucinous variety, so mucinous cystic neoplasms or even IPMNs, will have malignant potential, so we need to address that possibility. So do you resect or do you observe? It depends on the literature that you're looking at, and also it depends on the size of the cyst. So just to keep in mind that some people use 2.5 centimeters as the threshold. And so if it's less than that, they would suggest that you observe. If it's bigger than that, you may consider resecting. Other literature say basically 3 centimeters is the cutoff. So a significant percentage of lesions smaller than 3 centimeters can be followed. But some of those will actually still be mucinous and would have malignant potential. But since actual invasive cancer is uncommon in lesions less than 3 centimeters, even if you had a 2 centimeter mucinous cystic tumor, it may be okay to follow those until they reach the threshold of 3 centimeters, if they do. Other studies suggest that all mucinous tumors are premalignant and need to be treated aggressively. So it really depends on where you are and how comfortable your surgeons are at following things that could be potentially malignant. But size isn't all that matters, right? The patient matters as well. The age of the patient, are they symptomatic? All those things are going to be important if you consider resecting. And then are there any features about the cyst besides size that can help you decide whether or not you should resect regardless of the size? If there are mural nodules, and we'll discuss this, that's a worrisome feature, so you want to be more aggressive in your treatment of those. Do you have ductal dilatation? Okay, especially when the pancreatic duct gets very large, then you're starting to think of a main duct IPMN, and those definitely have a higher chance of having a malignancy. Is there enhancement of the wall of the duct or the wall of the cyst? Is there adenopathy? And let's not forget, is this truly incidental or is the patient symptomatic? If the patient's symptomatic, you might have a small lesion, but you may want to consider resecting it based on the symptoms. So that all goes into play. If you look at meta-analysis, where do they happen? So cysts greater than 2 centimeters in the head of the pancreas are ones that typically they would go to surgery. And when you look at the meta-analysis, they compared a whole group of people with cysts over 2 centimeters, and they said what was the best treatment. So they compared Whipple surgery, that's pancreaticoduodenectomy, yearly non-invasive radiographic surveillance, compared to surveillance with EUS, or compared to patients they do nothing. So in this meta-analysis, they looked at those 4 different pathways, what happened to the patients. Well, the survival was maximized if all the cysts were resected, regardless of size. So if you're simply looking at years of survival, then it makes sense to be more aggressive. But if you look at quality of life adjusted survival, so that's probably the most important to everybody, the do nothing approach, I mean, don't even follow them, just ignore them, had the best quality of life in patients under 75 who had a cyst less than 3 centimeters. So that's what we were discussing. Smaller cysts, you might not have to be so aggressive. Over 85 years old, non-invasive surveillance is the best. And initial surgery didn't maximize the quality of life in any age group of cyst size. So you want to kind of step back when you find these at first and not rush off to surgery. You really have to think, how old is the patient? What's their life expectancy anyway? Do you really want to do a Whipple surgery on a 95-year-old with a 3 centimeter lesion? So those are all important things to consider. The other thing I want to mention before we get into the specific cystic lesions is, what do you do about really small cysts? So if you have a cyst less than 1 centimeter, it's really tough to characterize those by imaging, meaning CT or even MR. EUS does a better job because obviously the ultrasound probe is right along the cyst. But using CT or MR, you have to be a little careful trying to characterize things that are so tiny that you're not getting an accurate Hounsfield unit measurement and you're not being able to see inside the cyst. Recommendation for follow-up, again, cannot be based on imaging alone. The patient's symptoms are important. So if a patient presents with weight loss or jaundice, diabetes, or anorexia, and you have small cysts, you want to be a little bit more aggressive in trying to characterize these cysts. You may want to go to a EUS in these patients to really see what's happening on the inside of the cyst. Okay, so how are we going to characterize those? We're going to look for septations or loculations. We're going to say, are there calcifications? And if there are, where are the calcifications? And those are important. Where is the mass itself? Sure, any mass can occur anywhere, but certain pathologies tend to occur in certain parts of the gland. Is the main duct involved? That's important to know. As we mentioned before, are there mural nodules? Is there enhancement? Is there ductal enlargement? Is it unilocular? Things that tend to be unilocular are small IPMNs, lymphoepithelial cysts, pseudocysts. Microcystic, they tend to be serous cystadenomas. Macrocystic, those tend to be your mucinous cystic tumors or your IPMN. And then once you get cysts with solid components, those are going to be your mucinous cystic tumors. They could be your IPMNs with associated cancer, or they could be your SPEN. Those are your solid and papillary epithelial neoplasms. EUS is actually very good to characterize, and the reason why EUS is maybe a little better sometimes, especially in the small cysts, is they can aspirate them, and they can look at the fluid. They can look at the CEA levels, amylase levels, those kind of things. Overlap does occur, but you'll be right most of the time as you start to characterize these if you have a system, and that's what I'm going to go over with you. Here's an article that discusses results of EUS and felt that these patients had CT, MR, EUS, and surgery, and that EUS with or without FNA was superior to CT and MR to accurately classify a cyst as malignant. So the fact that you can really get up close and see the internal architecture of the cyst as well as aspirate the fluid is critical. And I'm not going to go into the cyst analysis because it's really not part of radiology, but there are a lot of articles, and this one's from a couple years ago, that really started all the excitement, thinking that if you get the cyst fluid, then you can look for mutations in the DNA that you see in the cyst. And then based on that, you can kind of predict what are going to be malignant and what isn't. Okay, but let's really concentrate on what we can do as radiologists. So that's classifying these lesions. Okay, and we're going to talk about all the cystic tumors. We're going to talk about cystic neoplasms, like serous cystic neoplasms, the mucinous cystic neoplasms, IPMN, lymphoepithelial cysts, SPEN tumors, cystic endocrine neoplasms, and then sometimes ductal adenocarcinoma can have cystic change. It's really necrotic, not cystic, but sometimes they could look the same, so we'll discuss those. So we're going to characterize our lesions as serous, mucinous, or other, and that's what you should be doing when you're looking at a CT. Serous cystic neoplasms, the first one we're going to talk about. There you can see a pathology specimen. It has a very characteristic appearance at pathology and even on CT because it tends to be microcystic. So it's made of a lot of little cysts, and you can see that internal septations and that central scar, and that's very, very characteristic. So serous cystic neoplasms, also referred to as serous cystadenomas or serous cystadenocarcinomas. The carcinoma part is very, very uncommon. So serous cystic neoplasms comprise 16% of resected pancreatic cystic neoplasms. Most occur in women, so that's important to know, and women in the 7th decade. So these tend to occur in older women. They can occur anywhere along the pancreas. And at pathology and even on imaging, you can say, are they microcystic or macrocystic? So classically, they're microcystic, lots of little cysts. But sometimes they can look like big cysts, so they're macrocystic. And sometimes they can be unilocular, and those are the ones that are going to be tough for us. Because if it's a simple unilocular cyst, we're not often thinking of serous cystadenomas. So sometimes they get resected thinking they're mucinous cystic neoplasms. But there definitely is a variation in the pathology of these lesions, but you need to recognize what the classic appearance is. Almost all serous cystic neoplasms are benign cystadenomas. Like I mentioned, the cystadenocarcinomas are extremely rare. Okay? What the cystic neoplasms usually look like is honeycomb or sponge-like appearance, like I showed you in that pathology specimen. Calcification, that's a good differential for these patients with these lesions. You will see calcifications, it's typically central, not along the periphery. So if you see that scarring towards the center and you see a calcification in the center, that's a good indication it could be a serous cystic neoplasm. Lobulations are frequent. It usually will not obstruct the duct. Now, any mass that gets large enough can obstruct the duct because of mass effect, but usually, especially the smaller lesions, won't obstruct the duct. So you won't see ductal dilatation, and that's a differential that you can use between a serous cystic neoplasm and an IPMN. And also, it's important to remember that patients with von Hippel-Lindau get serous cystic neoplasms. Okay, so let's look at some cases. So here's an example. This is a man. Now remember, most of them are in women, but 61-year-old man who is asymptomatic, who has a cystic lesion discovered incidentally when we were imaging him for something else. And there's a perfect CT example of a serous cystadenoma. Okay, multilocular, central kind of scar, and a little data calcification in the center. So this is 4.4 centimeters. It was in the head. Again, the central scar, starburst calcification, classic for a serous cystadenoma. Doesn't necessarily have to be resected, but if the patient's symptomatic, or if it gets any larger, they're going to resect it, just because these can grow very large. And it's much easier to do a Whipple surgery, even if you know it's a benign lesion, when it's 4 centimeters, than trying to deal with this one is 15 centimeters. Okay, again, you see multilocular tumor with central calcification. Okay, this is that honeycomb appearance. Typical serous cystadenoma. Okay, here's another patient. This is a 61-year-old female. This is a mass in the tail of the pancreas. Again, I think this is much bigger than the other one. You can appreciate that it's made up of multiple lobules and little punctate calcifications, maybe not in the complete epicenter of the cystic lesion, but centrally you have a data calcification. This was 11 centimeters, fine septations and calcifications. Here's another patient, again, multilocular, cystic, right? Multiple little cysts, septations, very good CT appearance of microcystic serous cystadenoma. This one I could see is maybe a little tougher, right? It's incidental mass, so what other differential do we need to look at? Okay, there's no pancreatic duct obstruction, right? So it's unlikely going to be an adenocarcinoma. So now you're in, is this a mucinous cystic neoplasm, an IPMN, or a serous cystadenoma? I don't like it for IPMN because you don't see communication with the duct, right? So then you would go, it's either a mucinous cystic neoplasm or serous cystic tumor. And sometimes you can't tell and you're going to have it resected, but this one I think there's enough of small little locules that would make you favor a serous cystadenoma. This one I think is a little bit harder. So this is a mass in the tail of the pancreas. It's cystic. There's peripheral enhancement and maybe a little dot of peripheral calcification, but it's oligocystic. And so then you're kind of stuck. So if you showed me this case, there's no ductal dilatation, I would say I would favor that this is going to be a mucinous cystic neoplasm. And that's what we thought going into surgery, but it came back as an oligocystic serous cystadenoma. So not a lot of locules, right? It's either a unilocular or an oligocystic serous cystadenoma, but that's fine, okay? So it's much better than the alternative. If the patient had a mucinous cystic neoplasm, that's a little bit more aggressive tumor. So sometimes you're not going to be able to tell the difference. So then you would go and be the most conservative and say this could be a mucinous cystic tumor or an oligocystic serous cystadenoma, and assuming the patient is healthy and can undergo surgery, these patients you would want to resect. Okay, so we discussed the serous part. Now we need to discuss mucinous cystic tumors. So this gets a little bit more complicated because you have the parenchymal mucinous cystic tumors and the intraductal. So the parenchymal mucinous neoplasms are mucinous cystic tumors or mucinous cystic neoplasms. The intraductal are basically the IPMNs. They could be main duct, side branch, or a combination of the two. Okay, here's a pathology example. And you can see it looks very different than the serous cystadenomas. These tend to be larger cysts. They can be multilocular or unilocular, but they tend to be bigger, the size of the cysts, and more soft tissue component. So mucinous cystic neoplasm, so this is the parenchymal variety, can be benign or malignant, and they're graded at pathology depending on how much dysplasia they have or the presence of frank carcinoma. They represent 25% of all resected pancreatic cystic neoplasms, again more common in women, much more common in women, and more commonly in elderly women in the 5th or 7th decade, and more common in the distal pancreas. So you can see 95% are going to be in the pancreatic tail, right? So if you have one in the head, it still could be a mucinous cystic tumor, but that would be uncommon, especially in a man. It does not communicate with the pancreatic duct, so that helps you differentiate them between a mucinous cystic neoplasm and an IPMN. And they often have recognizable septations. Okay, typically they're oligocystic, so that's different than your serous tumors, and eccentric calcifications, and that again is different from your serous tumors. And then you're going to be looking very carefully. Mural nodularity, thickening, larger sizes of these tumors are more worrisome, increase the likelihood of malignancy. If you know it's an MCN, okay, so if they do endoscopic ultrasound and the lesion only measures 1.5 centimeters, then you have a problem. Some of the literature would say you should just go ahead and resect, and others, like I said, say would still be okay to follow it until it gets larger. Okay, and I think it all depends what you're going to do with your patient and what's the acceptable surgical risk. So your decision in a 40-year-old may be very different than your decision in a 95-year-old. Your decision for doing a Whipple would be different than your decision to do maybe a distal pancreatectomy or even laparoscopic surgery, which is a lot less aggressive. So let's look at some cases. So this is a 43-year-old female. It's a lesion in the tail, so that's where it should be. It looks unilocular, or maybe a little septation that I see here, and then a little bit of calcification, right? But nothing that looks at all like the serous cystic tumors, unless it's an oligoserous cystic tumor. Okay, this one was 3.5 centimeters. So based on size and everything, and it has suspicious features because it has that eccentric calcification and septations. Okay, now this one is another mucinous cystic neoplasm. Same thing, in the tail, eccentric calcification and a little septation. Surgical resection was performed and demonstrated mucinous cystic neoplasm without dysplasia. Here's another patient, looks very similar. It's a tail lesion in a female. And what you see, it's 3.6 centimeters, so size-wise we're already going to be a little bit concerned. No septations, no calcifications. 3D mapping shows it again and shows a little bit of soft tissue thickening where you see the arrow there posteriorly, so that's a little bit of a worrisome feature. We're worried about it anyway because it doesn't look like a classic serous cystadenoma. It's not involving the duct. We're not thinking it's an IPMN, so you're kind of stuck. You're in that category of it being a mucinous neoplasm, and that's what it was at pathology, and this one had mild dysplasia. 62-year-old female, incidental lesion, pancreatic tail. Again, it's following the rule. This is 3 centimeter. It had minimal mural thickening and a little tiny focus of calcification. Looks like the other two. We're not going to call this a serous cystadenoma. We're not going to call it an IPMN. It's not communicating with the duct. So then we're in the category of mucinous cystic neoplasm based on the size and the patient's age. Surgery was performed, and again, it came back as a 4 centimeter mucinous cystic neoplasm with low-grade dysplasia. Could you have followed this? You could have, but at some point you're worried that that low-grade dysplasia will turn into invasive cancer. And so that's the decision that you have to make, and you have a 62-year-old healthy female, it's probably worth the surgical risk to do the distal pancreatectomy. Okay, so we discussed the parenchymal mucinous neoplasms, which is basically mucinous cystic neoplasms. Now we need to discuss the intraductal. Okay, so we have the main duct, the side branch, and then the combined. So this is what they look like, especially the main duct one will look like when they do endoscopy. You see the mucin in the ducts, in the dilated ducts. Okay, so IPMNs are the most common intraductal neoplasm. Like the mucinous cystic neoplasms that we reviewed, they're graded pathologically based on the degree of dysplasia and whether or not there's any high-grade dysplasia or invasive cancer. These are the ones that we're diagnosing incidentally all the time, so definitely increasing incidence of these because we're seeing them more often. And often we see them when the patient is asymptomatic. Okay, but if the patient is symptomatic, then most commonly they're going to present with abdominal pain or weight loss. These are more frequent in men and more frequent in the head of the pancreas. So you can see this is very different from our mucinous cystic neoplasms, the parenchymal variety. Unlike the mucinous cystic neoplasms, the IPMN are associated with ductal dilatation, and the ductal dilatation could be the main duct or the side branches. And visualization of communication with the duct is really the key to the diagnosis and distinguishing these from the other cystic tumors. The intraductal papillary mucinous neoplasms can be multiple, or can be diffuse, or can be a single cyst. The treatment, again, is guided by the surgical risk and any associated features there might be. Is the main duct involved? That's a bad sign. Is there mural nodularity? Is there ductal dilatation greater than 1 centimeter? What's the size of the cyst itself? All those things will increase the chance that there's malignancy in the cyst. Main duct IPMNs have invasive cancer in 45%, and they have high-grade dysplasia in 20%. That's why if it's involving the main duct, you're going to be more aggressive. Side branch IPMNs with invasive cancer is much lower but still present, probably maybe 10 to 15% in some cases, depending on the size. So let me show you a couple of examples. So this is an intraductal papillary mucinous neoplasm. This is a main duct. 79-year-old man with prostate cancer, so we're following that up. You can see that's a huge duct. It measures like 1.5 centimeters, and you can see the little dilated side branches around the edge of the tumor. Okay, that's a classic CT appearance of a main duct IPMN. Okay, so you might say, why can't that be an adenocarcinoma with an obstructed duct? Because when you have an adenocarcinoma that obstructs the duct, you'll get atrophy of the pancreas, right? This is not an atrophic pancreas. The pancreas size itself is fine, just the duct is huge and the branches are also dilated. Okay, here's another classic main duct IPMN. The main duct is expanded. This one's, again, about 1.5 centimeters. You can follow it throughout its course. High chance of there being a cancer in these patients. Remember, up to 40% in some studies. And then you have to decide what you're going to resect, right? Because in this case, they did a total pancreatectomy. Because if the entire duct is involved, you can't take out part of the duct and leave the rest of the duct, because you're not going to be able to predict where the cancer will occur. Here's another patient. This one, very dilated duct, and this is an atrophic tail. Okay, so this one you're going to have to decide, is this a main duct IPMN or is this adenocarcinoma of the pancreas? And most of the IPMNs that you're going to see are going to be smaller and not necessarily main duct. So this is an example of the classic appearance. Remember, they're more common in the head. 3.4 centimeter multiseptated cystic lesion in the pancreatic head. So you say, well, why isn't that a serous cystadenoma? It's not a great appearance for that. It could be, though. But when you have a serous cystadenoma, they're more common in women, right? But also, they shouldn't obstruct the duct, or involve the duct, I should say. So you can see in this case, there is enlargement of the ductal system. So that would be typical of an IPMN. So in this case, they did a Whipple surgery and pathology, had a side branch IPMN with high-grade dysplasia. So that's one definitely that you want to be resecting. Here's another patient, 86-year-old asymptomatic man, discovered incidentally. Okay, here we have coronal MPR and volume rendered images, and you see it's pretty big. It's a 5 centimeter cystic lesion in the pancreatic tail. You can see that the duct is prominent. So already we're thinking, could this be an IPMN? And so they do a distal pancreatectomy, and it was IPMN with moderate dysplasia. This is the typical cases we see. In this case, there's a small lesion. Well, I guess not so small. When you do the 3D imaging, it was measuring up to 3.5 centimeters. It was a tubular lesion in the head or uncinate process. That's the most common place that you're going to see it. There it is. You can see it. And that arrowhead is showing you the dilated duct. So it's communicating with the duct. So now you're thinking it has to be an IPMN, not one of the other cystic tumors. Whipple surgery was performed based on the size and the presence of mural nodules on EUS. So we didn't see them on CT, but based on size, the patient went to surgery, and this was an IPMN with low-grade dysplasia without an invasive component, so that was good for the patient. Here's another one, and you can see that there's a cyst there kind of in the proximal pancreas, and you can definitely see that that's communicating with the duct. So you have a dilated duct in kind of the distal body and tail, and you can see it leading right into the cyst. Okay, that's a good example of IPMN. Here's another one. You can see a little cystic tumor, and you can see just a tiny duct. Now, sometimes MR is a little better showing the communication with those small side branches because it's more fluid sensitive. Okay, so we talked about the serous tumors, and we talked about the mucinous tumors, and now we have the category of others. So what's in the others that can look cystic? There's lymphoepithelial cysts, SPEN, cystic pancreatic endocrine neoplasms, and then the cystic or necrotic adenocarcinomas. So lymphoepithelial cysts, very interesting cysts. First described 1985. So obviously they didn't start happening in 1985. They were classified as something else before that. But in 1985 they characterized them as a separate cystic lesion. They're relatively rare lesions. The etiology is uncertain. They can be multilocular, bilocular, or unilocular. they can range in size from 2 to 13 centimeters. So they can be very large or small incidentally detected cysts. As I mentioned, the etiology is unknown. There's different hypotheses. One of the things they show in pathology is they have squamous cells. So they think it may be squamous metaplasia of the pancreatic ducts that then undergoes cystic transformation. Some people argue it could be ectopic pancreatic tissue within lymph nodes. Could be epithelial remnants within the peripancreatic lymph nodes, or it could be ectopic remnants of these brachial cleft cysts that are, misplaced or fuse abnormally with the pancreas or near the pancreas during embryology. So what is specific about them? Well, the pathology is pretty straightforward because these cysts are lined by squamous epithelium. Okay, very unlike the pathology of the other cystic lesions. And there's lymphoid tissue with germinal centers surrounding the epithelial lining. So that's why there's that theory of them starting in a lymph node. Okay? They contain a lot of debris and these cholesterol clefts. So apparently the pathology diagnosis is pretty straightforward. Cytology at EUS shows these anucleated squamous cells. So if you have a lesion, you think it could be a lymphoepithelial cyst. You don't necessarily have to resect it unless it's very large or the patient is symptomatic. And you could be certain of the diagnosis at EUS by doing the cytology when you see those squamous cells. So who gets these? Most commonly men, adult men, often incidentally, unless they're really big, then they might have symptoms based on mass effect. Primarily visualized as low attenuation or cystic lesions, so they look like cysts, and the key to this, they're very exophytic. Sometimes you can barely tell that they're touching the pancreas, they're that exophytic, so that's a little different than the other tumors I showed you. Often they're misdiagnosed as other things, like maybe a cyst coming from the spleen or the left kidney that just is next to the pancreatic tail. People may not appreciate that it's actually arising from the pancreatic tail. CT appearance can be variable and overlap with some of the other neoplasms, so sometimes you can't be sure. But the classic appearance would be a unilocular cyst or maybe a couple of locules with this thin wall or internal septations and being very exophytic. It has been reported sometimes to have solid components, so in that case, kind of all bets are off. If you're going to see a cystic lesion with mural nodules or solid components, you're going to suggest that it could be a mucinous neoplasm. Okay, so let's look at a couple examples. 47-year-old man with a history of alcohol abuse presenting with weight loss and epigastric pain. So this is the classic appearance. You see a cyst there, but it's just kind of sitting there, right? It's touching the tail of the pancreas. It almost looked like a kidney cyst, right? It's that exophytic. And that's the classic appearance, here you go again, of a lymphoepithelial cyst. It was resected. Pathology confirmed the diagnosis of lymphoepithelial cyst. The patient was symptomatic, remember. Another patient, 37-year-old, history of testicular cancer, who presented with an incidental mass. Okay? Now, sometimes testicular cancer can give you cystic metastasis or cystic lymph nodes. So these tend to be a little bit of an issue in this case. So you can see it looks very much like the other one. This one's in the head, though, and there's one here. And it looks like a kidney cyst, right? It just happens to be touching the pancreas. So there it is again in the axial and a sagittal image. And they do FNA, and they found the squamous cells, so we knew that it was a lymphoepithelial cyst. Another patient, 62-year-old man, incidentally discovered, again, just really looks like a kidney cyst, right? It's even touching the kidney, touching the pancreatic tail. No aggressive features. This is classic for a lymphoepithelial cyst. Another one, 73-year-old, incidental. This one is a little different, right? This one definitely has some internal septations. So this one, if you were showing me the case, I would not say it's a lymphoepithelial cyst. I would say that I would favor this being a mucinous cystic neoplasm because it looks complicated and it has those internal septations. We don't have ductal obstruction, so I'm not going to say it's an IPMN. Doesn't look like an adenocarcinoma. Doesn't look like a serous cystic tumor. So you're going to probably go with an MCN. In this case, you're going to be wrong, but it'd be good for the patient, right? So here again, so that was resected, and again, the pathology confirmed that it was squamous epithelium. So remember, lymphoepithelial cysts are benign lesion. There's no reports of malignant transformation, no reports of recurrence after surgical resection. And just to point out that these aren't really associated with other lymphoepithelial cysts that we think of, like in the head and neck, and those associated with HIV, for example. There's no relationship between the two. Okay, now the last few pearls of lymphoepithelial cysts, remember, rare, more common in middle-aged men, often appear as purely cystic, maybe a little bit of septation, very exophytic, and that's really the key. No pancreatic atrophy, no ductal obstruction. And 3D is important when we're trying to figure out the diagnosis in these, because you're trying to see, is this really a lymphoepithelial cyst? Is there anything suspicious about it that might suggest that it's a mucinous cystic neoplasm? Okay, now we're going to move on to the SPENs. So solid and papillary epithelial neoplasms. These are also known as solid pseudopapillary neoplasms or Hamoudi tumors. They represent less than 4% of resected cystic pancreatic lesions, so they're pretty uncommon. The key to this is the demographics. They're almost always in women and young women. So if you said to me, Dr. Horton, I have a case of this pancreatic mass in this 29-year-old, I almost don't need to look at it because I'm going to call it a solid and papillary epithelial neoplasm, okay, because that's by far the most common tumor in that age group. They can be very large at the time of diagnosis. They usually are presenting with mass effect symptoms, and treatment is resection because there is a malignant potential. Okay, this is a 43-year-old, so again, young woman, abdominal mass, and there it looks like a pretty aggressive lesion, right? It's pretty big, it's 7 centimeters, it's complex, it has calcification, but this looks very different than the serous cystadenomas, right? This is in the periphery, okay? No ductal dilatation. So based on the age, you're going to say SPEN. If it's not a SPEN, what's it going to be? It's going to be a mucinous cystic neoplasm, most likely. So they resected it, and again, it was a SPEN tumor. 39-year-old, vague abdominal pain. Here we have MPRs and volume rendering, and you see a 6.6 centimeter cystic mass in the pancreatic tail. Okay, there's some septation in there and a solid component. Okay, so if you showed me this, what would I say? Well, I would say mucinous cystic neoplasm. That would be my first diagnosis. Based on the age, it's going to be a SPEN or a mucinous cystic neoplasm. And when it was resected, it was a SPEN. This one looks aggressive. Again, a young female, solid components. These can look very, very complicated because they often bleed. So if you have a nasty, ugly-looking mass like this in a young woman, it's absolutely going to be a SPEN. It could be a mucinous cystic neoplasm, uncommon. It's not going to be the other tumors. Here's another one. The reason it looks like that is there's solid components and also hemorrhage, so you get this low density and high density. And here's another one. This is kind of in the proximal body. Looks complicated, right? It doesn't look like those oligocystic serous cystadenomas or even a mucinous cystic neoplasms. It's like perfect, but there's definitely internal complexity to it. Based on the age, you're going to go with SPEN or a mucinous cystic neoplasm. There's no duct, right? There's no reason to call it an IPMN. Okay, now we have to remember that pancreatic endocrine neoplasms, these are what we used to call islet cell tumors, can look cystic, so you don't want to be fooled by those. They represent 8% of resected pancreatic cystic neoplasms and about 10 to 15% of resected pancreatic endocrine neoplasms are going to be cystic. Most are discovered incidentally. Most are non-functioning, or non-hyperfunctioning, I should say. They're all function in a way because all pancreatic endocrine neoplasms produce hormones, but not at a high enough level to cause an endocrinopathy. They occur equally in men and women, generally diagnosed over the age of 60, and these can look complicated. So they're going to be cystic, but the key to these is often the hypervascular rim. They'll get really significant enhancement in the wall. So here's an example. So this is definitely a complicated cystic neoplasm, right? I don't like it for IPMN. I don't like it for serous cystadenoma. Could be a mucinous neoplasm, but the fact that you get that really hyper enhancement of the rim should put a cystic endocrine neoplasm at the top of your list. So this is pretty big. It was 7 centimeters in kind of pancreatic neck region, mural nodules, peripheral calcification, and hyper enhancement of the wall. So that's very, very characteristic. Here's another patient, 43-year-old, asymptomatic. She had MEN1. You have to be on the lookout for those. almost a 5 centimeter lesion, very complicated, right? You can see there's mural thickening, so that's a bad feature. You're going to be worried about a mucinous cystic neoplasm, but because of the degree of enhancement, you should suggest that it's going to be a cystic endocrine neoplasm more likely than a mucinous cystic neoplasm. Both of them are going to be resected, so pathology can sort it all out for you. And here's a little one in the tail. Okay, it's small. There's no ductal obstruction. There's definitely some complexity, especially of the wall. You have the thickening of the wall, the enhancement, and some internal solid components. And again, this was a cystic endocrine neoplasm. Okay, that brings us to the last category. Adenocarcinoma sometimes can look cystic, so you don't want to be fooled by that, but usually it's necrotic, it's not purely cystic. So here's just one example I put in for you. So this is a patient with adenocarcinoma, and you can see because of the necrotic center, it will look low density, and some people would say cystic, but on ultrasound, it's not going to be fluid density, right? It's going to be necrotic tissue. And you can see in this case, there's liver metastasis that also look low in density. Okay, so that's just to keep in mind that sometimes adenocarcinoma can have cystic necrotic change. Okay, in the last couple minutes, we're just going to address what do you do when you find an incidental cyst. Okay, so if it's less than 3 centimeters, no mural nodules, no duct issues, no ductal dilatation, the patient's asymptomatic, you could follow it up. I don't, in my report, suggest the interval of follow-up because I think people, the clinicians, the GI people, the surgeons have their own literature that they use to follow these. But I say what I think it is, and if it's an IPMN, it's less than 3 centimeters, they're going to be following them at a certain interval. Okay, so there are guidelines out there if you're interested, but I don't specifically say advise a follow-up in X number of months. There's ACR guidelines, which are a little different than the ones the surgeon used, so you can look at those. There's some controversy as how do you follow them? Are you following with CT or are you following with MR? With CT, it's excellent to follow these, but again, you might be worried about the radiation if you're following them at frequent intervals on young patients. So you can decide with your surgeons and your clinicians as an institution how you're going to be following these. One of the issues is there's no consensus on growth. So what does it mean to grow? What if it grows a few millimeters over a couple of months? Is that important or not? Right? Is it important? I don't know. It doesn't say if it grows at 3 millimeters in a year, that's an important growth rate. So following them in itself raises more questions. Okay, in the last couple minutes, I'm going to give you a quiz so you can think through what I've said and see if you're going to be right. Okay? So you just have to be calm and try to decide what you think it is. So quiz case number 1. This is about a centimeter cyst sitting in the pancreatic head, and it looks like it's communicating with that dilated duct. Right? So what are you going to say? You're going to say IPMN, right? Perfect location, perfect appearance, and it has communication with the duct. Okay? Number 2, huge mass. Lots of locules, internal septations, central calcification. This is huge, right? Maybe 15, 20 centimeters. Classic appearance of what? Serous cyst adenoma, right? Just because it's big, don't let it scare you. It's just huge. And this is why sometimes they'll resect them when they're small, even though they're benign, because they don't want them to get this big. Okay, this one, tail lesion, kind of complicated, right? Has some internal septation, some other kind of maybe soft tissue component coming off the tail. 2 things come to mind, and I want to know the age of the patient. 30-year-old female, it's going to be a SPEN. If you tell me it's a 60-year-old man, I'm going to tell you it's a mucinous cystic neoplasm. Here's one, cyst coming off the tail, very exophytic, unilocular, looks like a kidney cyst, but it happens to be touching the pancreas. That's going to be lymphoepithelial cyst, right? And here we have a cystic lesion off the tail with a pretty exophytic with a thin internal septation. Here you got to get into the demographics of it, but what this could be is it could be a lymphoepithelial cyst. You could do an EUS, and you could look and see if they have the squamous cells. If the patient's not symptomatic, you could follow it, right? You could see if there's mucin in it. There's no suspicious features. Or this could be a serous cyst adenoma, an oligocystic, and that's what it was in this case, an oligocystic serous cyst adenoma. So in conclusion, size is important. The size of the cyst may help you decide whether or not you're going to resect it or not. Characterizing the very small cysts is difficult for us in radiology, but EUS is a little bit better. All you can do is remember the demographics, remember what's most common and the classic CT appearance, and look for worrisome features that might change your differential. Is it communicating with the duct? IPMN, are there septations or nodules? Those are the aggressive features. And also the clinicians need to correlate it with the patient history and the symptoms, because that's really important to decide whether or not you're going to treat these lesions. Okay, so that concludes our discussion of cystic pancreatic lesions. Thank you.
Hi, this is Shiva P. Raman. I am an assistant professor of radiology at Johns Hopkins, and over the course of this lecture, I'm going to talk a little bit about the CT imaging of solid pancreatic masses. Now, we're going to begin with a very brief introduction, talking a little bit about protocol optimization, and specifically how we at Hopkins choose to image patients with a suspected pancreatic mass. But we're going to spend most of this lecture really going into two major types of pancreatic masses that I think come up most often in clinical practice. We'll start by talking about pancreatic adenocarcinoma, which I think is probably the most important and something you all should be familiar with in your day-to-day practices. And then we'll talk about pancreatic neuroendocrine tumors, the prototypical hypervascular pancreatic mass. Now, for each of these lesions, we're going to talk about staging, how you can help the surgeon determine what's resectable and what's not, as well as a few mimics that potentially could look a lot like an adenocarcinoma or a neuroendocrine tumor. Now, as far as I'm concerned, having proper CT technique is absolutely critical when you're imaging a pancreatic mass. Now, not only is it going to help you in terms of identifying the lesion, but if you don't have the right technique, you're not going to be able to tell what that mass is. Is it an adenocarcinoma? Is it a neuroendocrine tumor? And moreover, you're really going to have trouble telling whether you're dealing with a pancreatic or a peripancreatic lesion. But once you've identified the lesion and figured out what it is, having that proper technique is critical in terms of local regional staging, identifying distant metastatic disease, and providing your clinician that critical information as to whether or not a lesion is resectable or not. Now, our standard pancreatic protocol at Hopkins is a dual-phase study. So any suspected pancreatic pathology, not just a mass, but things like pancreatitis, are going to get a dual-phase study. So typically that entails an arterial phase at roughly 25 to 30 seconds, and then a venous phase at roughly 50 to 60 seconds. Now, note that we do not give these patients positive oral contrast. Not only will that interfere with your 3D post-processing, which we put a lot of emphasis on at Johns Hopkins, but you can also end up with streak artifact and beam hardening artifact that I've seen examples where that artifact can actually obscure lesions in the pancreas. Rather, patients with suspected pancreatic pathology are just going to get a neutral contrast agent, either water or volumen, typically about a liter of water or volumen, including some immediately prior to the injection. Now, it is critical that you give a brisk injection of IV contrast, at least 3 to 5 cc's per second, and we give Omnipaque or Visipaque, depending on the patient's renal function. Now, why exactly do you need two phases? Now, what's the point? Why not just do a single venous phase like we do for a lot of other things? And there's a couple of reasons for that. First of all, the arterial phase is critical in terms of differentiating vascular tumors, especially neuroendocrine tumors, from pancreatic adenocarcinoma, which tends to be hypodense and most conspicuous on the venous phase. It's also important in cases of neuroendocrine tumors in terms of identifying vascular metastases. Whether it's lymph node mets or liver metastases from a neuroendocrine tumor, they are going to be most evident on the arterial phase. Now, even though arterial phase imaging is most important for neuroendocrine tumors, it is worth noting that there are rare cases where adenocarcinomas will be more conspicuous on the arterial phase, and having both of those phases together increases your odds of catching a subtle tumor. On top of that, even once you've identified the lesion, vascular mapping techniques are going to help you determine vascular tumor involvement, and that's critical for adenocarcinoma, right? The distinction between a lesion with just subtle abutment of the SMA or full 360-degree encasement of the SMA is quite significant in terms of whether or not that patient is resectable. Now, the venous phase images, of course, for pancreatic adenocarcinoma are going to be the most important. The vast majority of adenocarcinomas will be most conspicuous on the venous phase, and identifying metastatic disease, especially to the liver, and local regional lymphadenopathy, again for pancreatic adenocarcinoma, is going to be best done using the venous phase. Now, on top of that, determining a tumor's resectability will always entail looking at the portal veins in the SMV, and that's best done on the venous phase images. And of course, you're not just looking at the pancreas, right? Anytime you're looking at a CT scan, you have to evaluate all of the different solid organs of the abdomen, and that for the most part is going to be best done using the venous phase. Now, you're going to hear many lectures talking about 3D post-processing, and I'm not going to recreate the wheel here, right? I'm not going to talk about each of these different 3D post-processing tools, but what I will say is that I think MIP imaging techniques, vascular mapping, VR, curved planar reformations, all of these have a very important role when you're dealing with pancreatic neoplasms, especially in terms of identifying subtle vascular involvement by tumor. And I'll show you some examples of that during the course of this lecture. Now, why don't we start by talking about what I consider the most important pancreatic neoplasm, and that's pancreatic adenocarcinoma. Now, this is something I see all the time, right? I work at probably the biggest pancreatic cancer referral center in the country. I see, dozens of these cases every week, and I will tell you, having a systematic, algorithmic approach to these cases is critical in terms of making sure you don't miss anything and that you're really picking up on those subtle abnormalities that your surgeon wants to know about. Now, pancreatic cancer is not that common, to be honest. I see a lot of it, but if you look at it overall in the country, there's about 28,000 cases each year, so it accounts for about 2% of all cancers. But that being said, it does account for 95% of all pancreatic exocrine malignancies, and it is the fourth leading cause of cancer mortality. Now, that brings up an important point, right? It's not that common, but it is one of the most leading causes of cancer mortality, and that's because of its very poor prognosis. There is a less than 5% survival at 5 years, and less than 20% of patients are candidates for curative surgery at the time of presentation. Now, for the most part, most pancreatic adenocarcinomas have typical features. These are hypodense tumors that are very poorly marginated. They tend to be infiltrative, and often they will infiltrate posteriorly into the retroperitoneum. These are not well-circumscribed lesions. Unlike the tumor we're going to talk about later, neuroendocrine tumors, it is going to be very difficult for an adenocarcinoma for you to draw discrete margins around the tumor, and in many cases it can be very difficult to actually measure the tumor discretely. Now, not only does this tumor infiltrate, it's often going to have a tendency to encase adjacent vasculature, and it will tend to involve the common bile duct and the pancreatic duct, obstructing both of those. Now, here's a relatively typical pancreatic adenocarcinoma. Notice that it's hypodense, it's poorly enhancing, it is relatively ill-defined and poorly marginated, and you can see that in the second image on the bottom right, it is obstructing the pancreatic duct with abrupt cutoff at the level of the mass. Now, in most cases, you're going to be able to see the lesion, but I will warn you, there are 5 to 10% of pancreatic cancers where you are not going to be able to find the lesion on CT. In these cases, the lesion is going to be essentially isoattenuating to the pancreatic parenchyma on both the arterial and venous phase. And in such instances, you are going to have to look for secondary signs of tumor, which is going to alert you to the presence of an occult tumor. Anytime you see a dilated pancreatic duct, especially where there's abrupt pancreatic ductal, abrupt cutoff of the pancreatic duct, anytime you see a dilated bile duct, anytime you see atrophic upstream pancreas, you have to be worried about the possibility of an underlying tumor. In particular, I never let a dilated pancreatic duct go, especially when it's segmental or when there's abrupt cutoff of the duct. Even if I don't see a tumor, that is a tumor until proven otherwise, and that patient needs another test, which is usually going to be an endoscopic ultrasound if you can't identify the mass on CT. Now, here's a relatively classic example, right? You see a hypodense mass, but notice the abrupt cutoff of the distal common bile duct at the level of the lesion. Even if you didn't see the mass, you would have to be worried about the possibility of an occult neoplasm based on the morphology of the duct. Here's another example. Now, in this case, it is very difficult to identify the lesion itself. In fact, I don't really see a primary pancreatic mass. But notice that the pancreatic duct is dilated and there is abrupt cutoff at the level of the pancreatic neck. It doesn't matter that I can't see the tumor. This is a tumor until proven otherwise. This patient needs to go on to get an endoscopic ultrasound, and in fact, they found that this patient had a sub-centimeter, very small pancreatic adenocarcinoma. Never let a dilated pancreatic duct go. That has to be further interrogated. Now, CT overall is an excellent modality for pancreatic cancer with sensitivities up to 96%, and certainly we've improved our ability to identify pancreatic cancer on CT largely because of improvements in scanner technology, thin collimation, better spatial and temporal resolution, and of course our increasing use of MPRs and 3D imaging. Now, when you're putting together a pancreatic protocol, ultimately you're trying to identify pancreatic tumors. And what does that mean? You're trying to maximize the difference in enhancement between the pancreatic tumor and the native pancreatic parenchyma. Now, in most cases, the portal venous phase is going to be the best phase for you to identify pancreatic cancer. But it is worth noting that even though we tend to mostly acquire two phases, the arterial and the venous phase, there actually isn't even, there's a third phase that you could theoretically acquire that gives you maximal pancreatic enhancement and in theory would give you your best odds of identifying a subtle pancreatic mass, and that's the so-called pancreatic phase. Now here's a really nice illustration from an article by Dreisen et al. In Emergency Radiology a couple of years ago, and you can see that the pancreas enhances maximally at roughly about 40 seconds after IV contrast. So just after our traditional arterial phase, but before the traditional venous phase. So if you really wanted to maximize your odds of identifying a pancreatic cancer, you probably would want to acquire that pancreatic phase. Now, we don't do that routinely in practice, largely because if you look at this article by Fletcher et al. In Radiology more than a decade ago, he found that there wasn't really much of a practical difference in terms of how many pancreatic cancers you're going to catch using a portal venous phase as opposed to this quote-unquote pancreatic phase. And for that reason, we don't want to scan the patient with 3 or 4 different phases in every case. For the most part, we just acquire 2 phases. We get an arterial phase and we get a venous phase, and we don't routinely acquire this pancreatic phase. Now, one of the things I see all the time when I'm working with residents is that they tend to try to talk about resectability in their dictation. And they say this is a resectable tumor, this is an unresectable tumor. And I would strongly advise you against using those terms in your dictation. Resectability really is going to be variable depending on where you work, your individual surgeon, patient factors, do you have a pancreatic cancer clinic, and a lot of other factors that I think are difficult for us as a radiologist to really figure out just based on the CT scan. In general, I think you want to report certain features that your surgeon is going to use in order to determine whether that patient is ultimately going to be resectable or not, but I don't personally use the term resectable or unresectable in my dictations. Now, that being said, determining resectability is absolutely critical, right? If you correctly determine a lesion to be resectable, the survival after surgery is typically going to be about 15 to 20% at 5 years. Now, that's still bad, but at least it gives the patient a chance. On the other hand, if a patient is incorrectly thought to be resectable, so let's say you present data that says the patient is resectable based on the CT scan, but they find that the patient is actually unresectable at surgery because there's an occult liver met or an occult peritoneal carcinomatosis, then they've basically undergone the Whipple procedure for no reason. Survival after a Whipple procedure in a case where the tumor is incorrectly thought to be resectable is no better than chemoradiation alone. So you really want to avoid doing Whipple procedures in patients who really, where it wasn't indicated. Now, when you're trying to figure out whether a patient is resectable, the first step is to figure out whether or not they have metastatic disease. Pancreatic cancer, by far the most common location for metastasis, is going to be the liver, and you really have to look at the liver very, very carefully in these patients to make sure you're not missing a subtle metastasis. Local regional nodes are commonly involved, but in general, big, bulky, obviously metastatic nodes are not that common, and oftentimes we have a lot of difficulty in terms of figuring out whether a node is metastatic or not. Carcinomatosis, again, very common, but we tend to miss it quite a bit. And I'd say lung is probably going to be the 4th most common site. Now, in general, I tell our residents and fellows, don't worry so much about metastatic lymphadenopathy. Local regional nodes, for the most part, will not affect the decision as to whether the patient goes to surgery or not. The only things you do need to worry about are whether there's distant lymphadenopathy, so well away from the pancreatic bed, or alternatively, local regional nodes that are extensive, big, bulky, centrally necrotic. Those kind of nodes can potentially affect a patient's resectability. Now, unfortunately, as with many other types of tumors, the sensitivity of CT for metastatic nodes is pretty low, right? We're ultimately going to be looking at size criteria which are inherently limited in terms of the sensitivity and specificity, but I wouldn't worry too much. Whether or not you call the nodes metastatic or not isn't going to matter. Most of the time, these nodes are going to be generally sampled and resected at surgery. Now, lymphadenopathy doesn't matter so much. Distant metastatic disease is critical. As I mentioned, distant metastatic disease automatically will make the patient unresectable. So if you have a liver metastasis, you have obvious signs of carcinomatosis, that patient is not going to go to the operating room. Now, the venous phase images are absolutely critical in terms of determining the presence of metastatic disease, especially to the liver. Remember, the portal venous phase gives you maximal enhancement of the liver and is going to be the best phase to identify these subtle hypodense liver mets. Now, you're not just looking for big, obvious 2 or 3 centimeter mets. You really need to look carefully for these subtle sub-centimeter lesions that could potentially represent metastatic disease. Now, even though the venous phase is going to be the best for identifying subtle liver mets, I do recommend that you look at the arterial phase as well. These small lesions often can be difficult to distinguish from a small cyst or a small hemangioma, but the presence of a perfusion anomaly or a THAD surrounding the liver lesion on the arterial phase can be a strong clue that you're dealing with something malignant rather than benign. Now, as with other malignancies that metastasize to the liver, CT is quite good for lesions that are over a centimeter with sensitivities well over 90%, but the sensitivity and specificity drops quite rapidly for lesions that are sub-centimeter. And unfortunately for sub-centimeter lesions, sometimes you're going to be stuck saying that it's too small to characterize, and you may need to just follow those lesions over time or get an MRI if there's a very strong clinical suspicion. Now, as much as we have problems with liver metastases, we have a lot of problems identifying carcinomatosis. Our sensitivity, if you look not just for pancreatic cancer, but for a number of malignancies, is the sensitivity is probably well under 50%, probably closer to about 25%. Unfortunately, even in cases where there are macroscopic tumor implants, they can blend in with adjacent anatomy, and I've seen plenty of cases where, in retrospect, you can identify the carcinomatosis, but it was very difficult to identify prospectively. Unfortunately, I'd say in terms of things that we don't catch on CT that lead to a patient being determined as being thought to be unresectable at surgery, I'd say missed carcinomatosis is probably going to be the most common, and this is something that you can't avoid. We're all going to miss carcinomatosis. Sometimes you're just not going to be able to see it on the CT scan. So here's a patient who has a big pancreatic cancer in the pancreatic head. Notice that there are multiple hypodense metastases throughout the liver. Clearly, this patient is unresectable. There's no question here of going to surgery. This patient is going to get chemotherapy and is going to have a dismal prognosis. Now, as I mentioned, carcinomatosis can be quite difficult, and you've got to be on the lookout for pretty subtle findings. Anytime I see ascites in a patient with pancreatic cancer, I'm going to spend extra time looking at the omentum and the mesentery. Ascites has to be taken as your number one clue that there's something going on in the peritoneum, and you need to look carefully for any stippling, any nodularity, any unexplained stranding or induration in the omentum that could reflect the presence of an underlying pancreatic adenocarcinoma. Now, once you've determined the presence or absence of metastatic disease, the next step is to identify the presence or absence of vascular involvement. Now, as I mentioned before, it can be very difficult determining whether a patient is resectable or unresectable from the perspective of a radiologist. And that's largely because now there's blurred margins between what truly is resectable and unresectable. Now, in the old days, if you had really any vascular involvement at all, you were pretty much determined to be unresectable, right? There's no question as to if you had subtle SMA involvement or subtle celiac artery involvement. Essentially, those patients were not going to the operating room. Now, on the other hand, over the course of the last decade, we've now seen this new category of so-called borderline resectable disease. So these are patients who have some degree of vascular involvement, in some cases pretty significant vascular involvement. And they're still potentially operative candidates, usually after a round of chemotherapy and radiation. Now, the definition of borderline resectable will vary a little bit from surgeon to surgeon, from institution to institution, but this slide really lists kind of the classic definition of borderline resectable. So you are potentially still a candidate for surgery if you have tumor that abuts less than 180 degrees of the SMA, if you have short segment encasement or abutment of the hepatic artery, or even if you have very significant SMV or portal vein involvement that's amenable to surgical reconstruction, often with some kind of a jump graft. Now, again, that gets into a level of complication that I don't think you should think about too much when you're actually dictating these cases. Your job as a radiologist is really to present the data and allow the surgeons, allow the oncologists to determine whether or not they want to take the patient to the operating room. But I will say the information that they need really hinges on five vessels. You need to report in every case what the tumor is doing, or the relationship of the tumor with the portal vein, the SMV, the portal SMV confluence, the celiac trunk, the hepatic artery, and the SMA. That's what the surgeon needs to know. They want to know, are those vessels involved, and if they are, to what degree? Now, when you're talking about the arteries, you want to report in terms of degrees of involvement. So you're trying to differentiate those tumors that have less than 180 degree involvement of the artery circumference from those that have over 180 degrees of an artery circumference. So in order to clear a vessel, you're looking for a preserved fat plane around the margin of the artery. Now, when you're reporting involvement of the portal vein in the SMV, I tend not to use that degree nomenclature like I do for the arteries. Now, for the portal vein SMV, you really want to give some kind of a verbal descriptor that the surgeon can use to determine whether or not venous reconstruction is technically feasible. Because as I mentioned earlier, venous involvement nowadays isn't quite as much of a barrier to surgical resection, because the surgeons can really do a lot of things in terms of dealing with the vessel, jump grafts and other reconstruction techniques. So venous involvement isn't quite as big a deal. Here's a good example of a patient who has significant venous involvement. You can see that there's about a 3 to 4 centimeter segment of the SMV that's quite narrowed all the way up to the portal SMV confluence. Here's another example. Again, you can see that there's a hypodense tumor in the pancreatic head and neck, and there is significant stenosis not only of the distal main portal vein and confluence, but the superior SMV as well. Give a verbal description and let the surgeon decide whether or not the patient is resectable. Now, arterial involvement, again, you want to be more exact. Here's a patient who has encasement of the celiac artery, so my dictation would say that there is 360 degree encasement of the celiac, and there is clearly some involvement of the hepatic artery as well. Here's another example. SMA, you can see that there's 360 degree encasement of the SMA over a relatively long segment. The vessel looks attenuated and narrowed. Now, even though we're operating on more and more patients nowadays, there's virtually no surgeon I know of who's going to operate on a patient with 360 degree SMA involvement like this. This is almost certainly going to be unresectable. Now, it's important to remember that the other vessels don't really matter so much, okay? So you're really concentrating on those 5 vessels that I talked about earlier, and smaller vessels like the GDA, well, that's not a big deal. Here's an example where the GDA is actually encased by tumor, but that doesn't matter. The GDA is going to come out as part of the surgery. This is not going to preclude the patient from getting resected. Now, how good is CT ultimately in terms of determining whether a pancreatic cancer is resectable or not? And the answer is that CT is actually quite good for establishing unresectability. So based on a CT scan, I can tell you with a very high degree of certainty that a patient should not go to the operating room. So the positive predictive value for unresectability may be as high as 100%. The problem is that what you're really trying to figure out is whether or not that patient is resectable. So you're trying to figure out and tell the surgeon, is that patient ultimately capable of undergoing an R0 resection? So in other words, a resection with negative surgical margins. The problem is that we still struggle with this, even with the latest generation of CT scanners. Somewhere between 60 to 91, only 60 to 91% of patients, or 60 to 91% of patients who are deemed to be resectable based on CT are ultimately found to be unresectable at surgery, and only a quarter of patients deemed to be resectable are found to be resectable at surgery. And what are we missing? We're missing small liver metastases, we're missing subtle vascular involvement, and we're missing tiny peritoneal implants. Now, I talked earlier about some of the typical features of pancreatic cancer. What are some features on a CT scan that should suggest the presence of a diagnosis other than pancreatic ductal adenocarcinoma? So in other words, what are some features that should suggest that you're dealing with a mimic of pancreatic cancer? First of all, as I mentioned earlier, pancreatic cancer will almost always obstruct the ducts. So if I see a tumor in the pancreatic head that is not obstructing the common duct or the pancreatic duct, I'm going to look at it with a little bit of cynicism, right? Am I dealing with something else that's potentially mimicking a pancreatic cancer? Similarly, if I see a big mass in the pancreatic head, but the upstream pancreas is not atrophic, again, that is a quite atypical feature and should make you think of another diagnosis. Remember, pancreatic cancer will tend to surround vessels and often will tend to encase and narrow those vessels. So if I see a big mass that's encasing the portal vein in the SMV, but there's really no narrowing, there's no occlusion or attenuation of the vessel, that should suggest another diagnosis. And then finally, pancreatic cancer commonly metastasizes to lymph nodes, but it is relatively uncommon for you to see big, bulky locoregional nodes. If you do see that, you see massive lymphadenopathy, you should think about another diagnosis, and usually that's going to be lymphoma. So what are some of the mimics that you need to be thinking about in your day-to-day practice? I'd say the big ones are going to be lymphoma, focal autoimmune pancreatitis, peripancreatic lymphadenopathy from another primary, duodenal tumors, groove pancreatitis, and fatty infiltration of the pancreatic head. Now, of all of these, the one diagnosis that I'd say comes up all the time, and we get cases referred in from outside institutions with quote-unquote pancreatic cancer, and it turns out to be fatty infiltration of the pancreatic head, aka pancreatic lipomatosis. I can't tell you how many cases I've seen that were billed as being a pancreatic cancer, but that just turned out to be focal fat. Now, in most cases, fatty infiltration of the pancreas will be diffuse, but it can rarely be focal, and it tends to have a predilection for the anterior aspect of the pancreatic head. And I've seen cases where, even someone like me who sees a lot of this on a day-to-day basis, I've been uncertain as to whether or not I was dealing with a primary pancreatic mass. But there are some features that should make you think that you're dealing with fatty infiltration. First of all, it tends to have very geographic margins. It's going to involve the anterior aspect of the pancreatic head, and there's going to be a straight line demarcating that hypodense part of the pancreas from the more normal appearing pancreatic parenchyma posteriorly. On top of that, it's not going to act like a tumor. You're not going to see mass effect, there's no dilated ducts, there's no deformity of the pancreatic contour, it's not going to do anything to the surrounding vessels. Now, I'd say in most cases, if you think about the possibility of fatty infiltration, this is not going to be a difficult diagnosis, but in those rare instances where you're truly not certain, just go on to get an MRI. An MR with in and out of phase chemical shift imaging is going to make this very easy to diagnose. The area of fatty infiltration is going to lose signal on the out of phase. Here's a good example. You can see that there's superficially something that looks like a hypodense lesion in the pancreatic head, but it's geographically marginated. There's a straight line separating the hypodense area from the posterior aspect of the pancreatic head. There's no mass effect, no dilated ducts. And the more you look at it, the more you realize it doesn't really look mass-like. This is classic fatty infiltration. Now, I'd say the second most common mimic that I see in my practice is going to be lymphoma. Now, it is worth noting that primary pancreatic lymphoma is actually really rare. It's less than 1% of all pancreatic tumors. Usually it's diffuse large B-cell lymphoma, and you're going to see it in immunocompromised patients or the extreme elderly. And honestly, it's so rare that I've seen very few cases of it. In fact, I think I've seen one case that was truly thought to be a primary pancreatic lymphoma. Now, secondary lymphomatous involvement of the pancreas, on the other hand, tends to be much more common, right? And this is actually not that uncommon, at least in my practice. And I have a handful of cases that I've seen just over the last year. Now, lymphoma can superficially look like a pancreatic cancer. It's going to be hypodense, poorly marginated. It's going to look relatively poorly enhancing. And it does have a tendency to involve the pancreatic head. But there are some features that should make you think of something else. First of all, it will often surround vessels, but there's going to be absolutely no vascular narrowing, no evidence of occlusion. It's not going to really ever narrow or attenuate the vessel. Secondly, unlike pancreatic cancer, which almost always infiltrates posteriorly into the retroperitoneum, lymphoma will infiltrate without any regard to anatomic boundaries. So it can infiltrate both anteriorly and posteriorly, which is quite uncommon. And then finally, as I mentioned before, pancreatic cancer is almost always associated often will metastasize to lymph nodes, but massive lymphadenopathy is uncommon, whereas with lymphoma, big-time lymphadenopathy is going to be very common. So here's an example. Here's a patient with a big mass that's encasing that's surrounding the entire pancreas. Easy to think that this is pancreatic cancer, but it doesn't look like any pancreatic cancer I've ever seen, right? It is involving multiple different organs. It's encasing vessels, but notice how the SMA and the splenic artery are absolutely going through this tumor unimpeded, unattenuated. There's massive lymphadenopathy. There's a big splenic mass. This is not a pancreatic cancer. This is diffuse large B-cell lymphoma. Now, it is worth noting that leukemia in its focal form, so-called chloroma or granulocytic sarcoma, can look identical to lymphoma, and you can rarely end up with leukemic infiltration of the pancreas. Here's an example of that. Big hypodense mass in the pancreatic body/tail segment. This turned out to be a chloroma. Now, another diagnosis that I'm increasingly seeing in my practice, or at least that we're becoming increasingly cognizant of, is autoimmune pancreatitis. Now, autoimmune pancreatitis usually is going to diffusely involve the pancreas, right? The pancreas is going to be diffusely enlarged. You're often going to see a low attenuation halo around the pancreas. You may see delayed enhancement of that halo, and often there's associated autoimmune IgG4-related cholangitis. So you may see strictures of the CBD, usually with thickening and enhancement of the distal CBD at the level of the ampulla. The problem is that autoimmune pancreatitis can rarely be focal. It can involve portions of the pancreas, especially the head, and can look very much like a pancreatic cancer. Here's an example. Mass in the pancreatic head. Notice that it's not obstructing the pancreatic or the common bile duct, so that's the feature that should make you think that you're probably not dealing with a pancreatic cancer. But to be honest, in cases like this where you have a very focal form of autoimmune pancreatitis, it can be virtually impossible to really exclude the presence of an underlying malignancy. Now, here's another entity that I think many people are not familiar with but can theoretically mimic pancreatic cancer, and that's groove pancreatitis. Now, this is a rare form of chronic pancreatitis that's going to affect the pancreatic or duodenal groove, the space between the pancreatic head, the duodenum, and the common bile duct. Now, this is a rare entity, extraordinarily difficult in terms of making the diagnosis based on imaging, and is usually, most often seen in patients who have other risk factors for chronic pancreatitis, especially alcoholism. Now, the imaging features can look a lot like pancreatic cancer, but there are some features that may at least make you think about this diagnosis prospectively. You're looking for sheet-like, curvilinear, hypodense soft tissue in the pancreatic or duodenal groove, usually with smooth, tapered narrowing of the distal CBD and the pancreatic duct, but no stigmata of traditional edematous pancreatitis. You're not going to see inflammatory change. You're not going to see free fluid. It's going to look kind of like sheet-like tumor. Now, over time, these patients do have the traditional risk factors for chronic pancreatitis, so they will develop the traditional stigmata, including calcifications, dilated pancreatic duct, beating, and irregularity. Here's an example. You can see that there's this sheet-like curvilinear soft tissue in the pancreatic or duodenal groove. It is mildly obstructing the pancreatic and common bile ducts. Very hard to say that that's not a pancreatic or duodenal malignancy. Here's another example, again, subtle soft tissue in the groove between the pancreas and the duodenum. There is some subtle cystic change within that soft tissue, which is not uncommon in these cases, but honestly, very difficult to say that that's not malignancy. Most of the cases of groove pancreatitis that I've seen have ultimately been operated on because it's very difficult to exclude the presence of an underlying malignancy, even with a negative biopsy. Now, why don't we move on now to our second major category of pancreatic masses, and we'll talk a little bit about neuroendocrine tumors. These have a number of different names. Often, many of you probably are familiar with the term islet cell tumor. I think we typically use the term neuroendocrine tumor nowadays. And these are tumors composed of well-differentiated endocrine cells. In the old days, we categorized these as being either functioning or non-functioning, but now we recognize that all neuroendocrine tumors are hormonally active, and so we tend to categorize them as being syndromic or non-syndromic based on whether they secrete enough hormone to cause laboratory and clinical findings. Now, there are a number of associations of neuroendocrine tumors with different syndromes. I'd say the most common that I come across in my practice are von Hippel-Lindau, neurofibromatosis, and MEN type 1. There's also a theoretical association with tuberous sclerosis. Now, syndromic NETs, or neuroendocrine tumors, are clinically evident lesions because the mass is producing enough hormone to actually cause an endocrinopathy. Now, because these lesions are causing symptoms, they tend to present when smaller. Now, even though we tend to think of these as just secreting one hormone, it's worth noting that syndromic NETs will often secrete multiple hormones, but it's the dominant hormone that's actually going to establish the patient's syndrome. Now, because these patients do tend to present earlier, the lesions tend to be smaller, so most often under 3 centimeters in size. There are a number of different syndromic NETs that have been described: insulinomas, glucagonomas, gastronomas, VIPomas, somatostatinomas, and so on and so forth. But the two most common types by far in our practice are insulinomas and gastronomas. Now, insulinomas tend to be small and they tend to be relatively benign. Only 10% are malignant. They're associated with the classic clinical symptoms of Whipple's triad: hypoglycemia, symptomatic hypoglycemia, and symptom improvement after the administration of glucose. Now, gastronomas, on the other hand, are much more often malignant. About 30% will present with liver metastases. They're often multiple, and they are not uncommonly extrapancreatic. So not only do they arise in the pancreas, they can arise in the so-called gastronoma triangle. Now, these patients will often end up with peptic ulcer disease, ulcers in unusual locations, especially post-bulbar duodenal ulcers, and they can present with so-called Zollinger-Ellison syndrome. Now, non-syndromic NETs, on the other hand, account for about 50% of all neuroendocrine tumors, and because they're not producing endocrinopathy and symptoms when smaller, they tend to be quite large when they present. And so the average size is about 5 centimeters. Now, the symptoms in these patients tend to eventually occur when the lesion gets large enough and you end up with mass effect, metastatic disease, and local invasion. Now, these tumors tend to look ugly and aggressive, right? So they're much more likely to be cystic, necrotic, they can have calcification, and they can just generally look aggressive with the presence of distant metastatic disease. Now, how do I tell whether a lesion is a neuroendocrine tumor or a pancreatic cancer? And the truth is that in most cases, it's going to be pretty obvious. First of all, neuroendocrine tumors will avidly enhance on the arterial phase, and they'll typically still be hypervascular on the venous phase as well. And that's something you're never going to see with an adenocarcinoma, which is going to be hypodense on all phases. Now, the arterial phase is going to be the most critical for identifying most pancreatic neuroendocrine tumors, but it is worth noting that in rare instances, you will see NETs that are more conspicuous on the venous phase. But I'd say as important as the enhancement pattern is, the degree of the margins of the tumor are just as important for making the diagnosis. In most cases, even if I don't have an arterial phase, just the margins of the mass on the venous phase will tell me whether I'm dealing with an adenocarcinoma or a neuroendocrine tumor. Adenocarcinomas are poorly marginated and ill-defined, often very difficult to discretely measure. Neuroendocrine tumors are well-circumscribed lesions. They have clear margins. You're going to be able to see on one, you're going to be able to clearly demarcate what's tumor and what's the adjacent peripancreatic fat. Now, these lesions can rarely be cystic or necrotic, and in fact, they can be so cystic that they can mimic other primary cystic lesions of the pancreas, like an IPMN. But in those cases where there's a significant cystic or necrotic component, there's almost always going to be a surrounding rim of hypervascular soft tissue, which should allow you to make the right diagnosis. Now, unlike a pancreatic cancer or pancreatic adenocarcinoma, neuroendocrine tumors typically will not obstruct either the pancreatic or biliary ducts. Now, that being said, large tumors can cause obstruction, and there is a small category of neuroendocrine tumors that, even though they're quite small, will secrete serotonin and other similar hormones that can cause fibrotic stricturing of the ducts. So even though most cases you're not going to see biliary pancreatic ductal obstruction, it can happen. You're almost never going to see upstream pancreatic atrophy, and it is not uncommon for you to see big, bulky local regional nodes, and those nodes are often going to be hypervascular on the arterial phase. So here's a chart really comparing and contrasting the imaging features of a neuroendocrine tumor and an adenocarcinoma. Remember, neuroendocrine tumors are well circumscribed, unlike the poorly marginated adenocarcinoma. In most cases, they are avidly enhancing and will be best seen on the arterial phase, unlike adenocarcinomas, which are hypovascular and best seen on the venous phase. Neuroendocrine tumors, interestingly, will invade the venous vasculature. So if you see a mass in the pancreas that's invading the SMV or the portal vein, that is almost never going to be a pancreatic adenocarcinoma and is usually going to represent a neuroendocrine tumor. Adenocarcinomas, on the other hand, will encase and narrow the mesenteric veins. Now, adenocarcinomas almost never calcify. In fact, virtually never calcify in the absence of treatment, whereas neuroendocrine tumors commonly calcify, and that calcification can be either central or diffuse. Now, as I mentioned, pancreatic adenocarcinoma will typically not give you big, bulky local regional nodes, whereas neuroendocrine tumors will often give you enlarged local regional lymphadenopathy. And of course, the metastatic disease is going to have the same enhancement pattern as the primary. So neuroendocrine metastases are going to be hypervascular and best seen in the arterial phase. Adenocarcinoma metastases are going to be hypovascular and best seen on the venous phase. So here's a classic pancreatic neuroendocrine tumor. Well circumscribed, well marginated. You can clearly demarcate the mass from the adjacent peripancreatic fat. And notice that it is avidly hypervascular on these arterial phase images. Notice also there is absolutely no upstream pancreatic atrophy, which would be quite unusual for a pancreatic cancer in this adenocarcinoma in this location. Now, we are increasingly, as we do more and more arterial phase imaging for a number of different indications, identifying small neuroendocrine tumors incidentally. Here's an example of that. This is a small neuroendocrine tumor, probably 6 or 7 millimeters, completely incidental finding in a patient who's being scanned, I think, for looking for a renal mass. Here's another example. Again, very small hypervascular lesion. Here's an example really illustrating that you still have to look for hypervascular lesions in the pancreas, even on the venous phase. Although they're typically most evident on the arterial phase, there are examples like this one where you're going to be able to make the diagnosis on the venous phase images as well. Now, as I mentioned, non-syndromic neuroendocrine tumors tend to be quite large. They look more aggressive, more likely to have cystic and necrotic change. Here's a big non-syndromic neuroendocrine tumor. Patient didn't have any evidence of endocrinopathy, but they ultimately came to clinical attention because of local mass effect and invasion from the tumor. Now, one of the things I'm always thinking about when I'm dealing with a pancreatic cystic lesion is, am I missing one of those rare cystic neuroendocrine tumors? Here's 3 examples. Now, in each of these 3 cases, I think it would be very easy to just say, well, okay, it's a small cyst in the pancreas. It's probably a small side branch IPMN. Who cares? Move on to the next case. But in each of these 3 cases, you'd be missing a quite significant diagnosis. Notice that these are not simple cysts. There is a rim of dense, irregular enhancement and soft tissue surrounding the margins of each of these cysts. Notice that the lesion in the bottom image actually has a large soft tissue component that's hypervascular. Anytime you see a hypervascular rim or soft tissue associated with a pancreatic cyst, you have to think about a cystic neuroendocrine tumor. Now, sometimes rather than just seeing a cyst, you're going to see actual necrotic degeneration. Tends to be more common with non-syndromic lesions, but can occur in syndromic lesions as well. Here's an example where you see there's a significant necrotic component, but again, that hypervascular soft tissue associated with the lesion is going to drive you towards the right diagnosis. Now, one of the things I always tell our residents and fellows, if you see a calcified pancreatic mass, you are not dealing with an adenocarcinoma, period. Never happens. On the other hand, this is quite common with neuroendocrine tumors. These calcifications in certain instances can be very diffuse, as in this case, or can be stippled and involve just a part of the lesion. But anytime you see a calcified solid pancreatic mass, you have to be thinking about a neuroendocrine tumor. Now, look for other signs as well. Here's a case where I actually didn't at first see the pancreatic lesion, right? And if you look at the bottom image, it's quite subtle. Even on arterial venous phase, you can kind of vaguely see that there's something there in the pancreas. But notice that there's this dramatic wall thickening of the stomach, right? It's involving the proximal and mid portions of the stomach, and that wall thickening of the stomach actually looks dramatically hypervascular. This is the classic distribution and the classic appearance of Zollinger-Ellison syndrome. The second I saw that, I went back, looked at the pancreas much more carefully, and we were able to identify this very subtle pancreatic neuroendocrine tumor that I think I wouldn't have seen if I hadn't seen the gastric findings first. Now, as I mentioned earlier, pancreatic cancers will tend to encase and narrow or even occlude the mesenteric vasculature. That doesn't tend to happen with neuroendocrine tumors. They tend to invade the mesenteric veins. Here's an example where you have a pancreatic neuroendocrine tumor in the pancreatic tail. It's invading and distending the entire splenic vein with tumor. You know that this isn't a pancreatic cancer. They don't do that. This has to be a neuroendocrine tumor. Here's another example. Again, you can see this large mass involving much of the pancreas. It's invading the portal vein and the splenic vein, distending those vessels. And notice on the coronal MIP arterial phase reconstruction, there's dramatic hypervascularity within the tumor thrombus, classic neuroendocrine tumor. Now, as I mentioned, metastatic disease, either from a neuroendocrine tumor or an adenocarcinoma, will have the same enhancement pattern as a primary tumor. Here's a patient who has a big hypervascular pancreatic neuroendocrine tumor. Notice that the liver metastasis looks virtually identical and has lots of internal neovascularity. Now, neuroendocrine tumor liver mets can be quite small. They can be miliary in terms of their appearance. They can look sub-centimeter. And this is one of the reasons why I really think MIP imaging is critical. I always use MIPs to look at the liver in any patient with a hypervascular primary. It can really make those subtle, small, early neuroendocrine tumors metastases stand out and become much more obvious. Now, just as we talked about a few mimics for pancreatic adenocarcinoma, there are several mimics of pancreatic neuroendocrine tumors. I'd say the most common mimic, and the one that comes up actually relatively frequently in my own practice, is metastatic disease to the pancreas, and classically renal cell carcinoma. Now, renal cell carcinoma can metastasize to the pancreas years after initial presentation, and because these are, again, fundamentally hypervascular tumors, especially with clear cell RCCs, a hypervascular met to the pancreas from an RCC will look indistinguishable from a neuroendocrine tumor based on the imaging alone. And so what's going to drive you towards the right diagnosis is going to be the patient's history. Here are 2 examples. The first, in the upper left, is just a small hypervascular lesion, could easily be a neuroendocrine tumor. And the second is a more dramatic case in the bottom right, where there are innumerable hypervascular lesions throughout the pancreas. Now, in both instances, if you were to tell me these are neuroendocrine tumor lesions, I would believe you, right? That's all comers going to be the most common diagnosis. But what's the clue here on each of these images that that's not the right diagnosis? Notice that the kidney is missing. The right kidney is missing in both cases. This patient has had a nephrectomy. These are renal cell carcinoma metastatic lesions. Now, the second mimic, and the one that I'm always worried about mistaking for a neuroendocrine tumor, is an intrapancreatic splenial. I've worked at 3 institutions, and at every institution I've been at, I've seen a case where an intrapancreatic splenial has been taken to the operating room because it was mistaken for a neuroendocrine tumor. Believe me, this is actually easy. This is an easier mistake to make than you'd think. After all, the pancreatic tail is the second most common location for an accessory spleen, and especially when you're dealing with just a single venous phase abdomen, very easily confused for a neuroendocrine tumor. But that being said, there are a few clues that may help you. Remember that an intrapancreatic splenial should have identical enhancement to the spleen on all phases of contrast, so it'll have that characteristic tiger stripe pattern on the arterial phase. And a neuroendocrine tumor, a splenial will never be more than 3 centimeters medial from the pancreatic tail. So if you see a lesion that's more than 3 centimeters medial from the tail, you're dealing with a neuroendocrine tumor. You're not dealing with a splenial. Now, I would say the key to making this diagnosis is to just think about the diagnosis, okay? When you make this mistake, it's usually because you don't even consider the possibility of a splenial. If you're not sure, this is one of those instances where you've got to get another test. Get a sulfur colloid Tec-99 scan or a heat-denatured RBC scan, just to make absolutely certain that you're not sending the patient to the operating room for what is fundamentally a benign lesion. Here are 2 examples, and I'll tell you both of these lesions are accessory spleens. One of them ended up going to the operating room and was unfortunately found to be an accessory spleen in the OR, but was thought to be a neuroendocrine tumor. But you can see in both instances, if you had thought about the possibility, this is a major mistake that you might have been able to avoid. So just think about it, and if you've thought about it, you're probably going to be able to recommend the next best appropriate step. Now, there are some more rare lesions that can mimic a neuroendocrine tumor as well. Here's a relatively uncommon lesion, a solid serous cystadenoma. Now, you are all familiar with the classic serous cystadenomas, which are honeycomb lesions, multiple small cystic spaces. They have a central scar, a central calcification. But there are cases where serous cystadenomas can have virtually no cystic component and can look solid, so-called serous adenomas. And they are hypervascular lesions that will avidly enhance and look identical to a neuroendocrine tumor. This is a virtually impossible diagnosis to make on CT, and frankly, I'd say that if you read enough of these, you're ultimately going to make this mistake, right? These lesions almost always are resected. There's really no way around making this mistake. What about peripancreatic GI stromal tumors? Now, GI stromal tumors can be found anywhere in the GI tract, tend to be more common in the stomach, but when you do see them in the small bowel, they tend to be most common in the second portion of the duodenum. Now, GI stromal tumors can be very variable in terms of their enhancement pattern, but they can be relatively hypervascular on the arterial phase, and they can look a lot like a neuroendocrine tumor. Now, the key to making the right diagnosis in these cases is to look for a fat plane between the mass and the pancreatic head. So in other words, figuring out that you're dealing with a peripancreatic lesion rather than a primary pancreatic lesion. But that being said, if you're not certain, it doesn't really matter. The treatment's going to be the same regardless of whether it's a neuroendocrine tumor or a GI stromal tumor. The same surgery is going to happen. It's going to be a Whipple procedure. It's not going to be critical that you make the you correctly identify or differentiate a GIST from a neuroendocrine tumor. Finally, here's another peripancreatic lesion that can look a lot like a neuroendocrine tumor, peripancreatic paragangliomas. Again, it's great if you're able to figure out that these are extrapancreatic and you're able to identify that fat plane between the pancreas and the mass. But once again, these are surgical lesions. Even if you're not able to make the diagnosis prospectively, as long as you're able to point the surgeon in the right direction and say that this is a lesion that needs to come out, you've done your job. Now, when you're talking about pancreatic NETs, I'd say in most cases, it doesn't matter whether you're able to differentiate one of these mimics from an NET, because the treatment's going to be the same. All of them are going to get the same surgical procedure, so accurate preoperative diagnosis isn't really going to change management. But the one diagnosis you cannot miss, the one diagnosis that is really going to make you look bad in front of your referring surgeons, is going to be when you misdiagnose a splenial as an NET. So anytime you see a neuroendocrine tumor near the tail, or what you think is a neuroendocrine tumor, sit back at least for a minute, think about the possibility that it could be a splenial, and decide whether or not you want to get a nuclear medicine study for confirmation. So in summary, hopefully I've shown you that It doesn't matter how good you are, how much you know about the pancreas. If you don't have the right protocols in place, if you're not using dual phase technique, it can be very difficult to make the correct diagnosis and really give the surgeon the information they need to determine whether a lesion should come out or not. I think it's pretty much mandatory nowadays that any pancreatic imaging, regardless of what suspected pancreatic diagnosis you're looking at, requires dual phase technique with both arterial and venous phase imaging. Secondly, when you're looking at these cases, I think it's really important that you understand the role of CT in terms of both diagnosing and staging pancreatic cancer. It's not enough when you're looking at a pancreatic cancer case to just say to your surgeon, well, there is a cancer there, period, right? You have to give your clinician the information that they need in order to determine whether that lesion is resectable or not. Always be thinking about mimics, right? Because a lot of these mimics are not going to be surgically treated. If you have lymphoma or autoimmune pancreatitis, those are potentially non-surgical cases, and it's great if you're able to make the diagnosis prospectively and save the patient an unneeded surgery. Finally, always look at the pancreas very carefully in the arterial phase images for small hypervascular lesions. The arterial phase is the most critical phase for diagnosing pancreatic neuroendocrine tumors, and we're increasingly identifying these lesions on dual phase studies being done for other reasons. So why don't we end there, and thanks everyone for listening. Hi, this is Shiva Raman. I'm from Johns Hopkins University in the Department of Radiology, and we're going to talk a little bit about computed tomography after pancreatic duodenectomy. We'll talk about normal findings and some complications that you should be looking out for. Now, complications of the Whipple procedure, we'll start a little bit by talking about the surgical procedure itself, including the anastomoses and how the procedure is performed. We'll talk a little bit about CT technique, including how we typically image patients at Johns Hopkins who have had a prior Whipple procedure. And we'll talk a little bit about normal findings, things that you shouldn't confuse with pathology, both in the acute perioperative period and when performing chronic surveillance. But we'll spend most of the lecture really going into a number of different complications that you might encounter when you're imaging these patients after they've undergone a Whipple. Now, the Whipple procedure, so-called pancreatic duodenectomy, is the most common procedure utilized today for resection of tumors in the pancreatic head, unslit process, and neck, as well as for lesions that occur in the duodenum, the extrahepatic bile duct, or in the ampulla. Now, for many, many years, the Whipple procedure was a dreaded surgery, right? Massive mortality, huge morbidity. But honestly, there have been dramatic improvements both in surgical technique and critical care, on top of the fact that I think imaging has helped clinicians in terms of dealing with many of the complications of the procedure, and accordingly, perioperative mortality rates are now relatively low, under 1%, although there is still a quite significant rate of complications. It is worth noting that your rate of complication and your rate of mortality are much lower if you undergo the procedure at a major center that does many, many of these procedures every year. Now, when you're talking about a Whipple procedure, there's really two types you should be familiar with. There's the classic Whipple, which entails resecting the pancreatic head, neck, and unslit process, as well as the duodenum, the gallbladder, the distal bile duct, and the proximal jejunum, and you remove the gastric antrum. And then there's the so-called pylorus preserving procedure, a Whipple procedure, where you resect all of the stuff I talked about earlier, but you retain the gastric antrum and the first portion of the duodenum. In a classic Whipple procedure, you're going to have a gastrojejunostomy, whereas in a pylorus preserving procedure, you're typically going to have a duodenojejunostomy. Now, the pylorus preserving procedure was originally intended to reduce the risk of bile reflux, but there's a lot of data in the literature suggesting that there's really not a lot of difference in terms of patient outcomes when you undergo the classic or the pylorus preserving Whipple. And honestly, at Hopkins, at least from what I've seen, a lot of whether or not you get the classic or the pylorus preserving Whipple is going to be based on your surgeon's preference and their own comfort level. Now, it is worth noting that the criteria for utilizing the Whipple procedure has dramatically expanded over the course of the last decade, right? In the old days, if you had pancreatic cancer and you wanted to get a resection, it essentially meant that you had to have no metastatic disease and no significant vascular involvement. But as we've developed this new category of borderline resectable pancreatic cancers, we found that even patients with relatively significant vascular involvement by tumor are still potentially surgical candidates, and that, at least at Hopkins, has resulted in a dramatic increase in the volume of Whipple procedures that we're performing at our institution. Now, there are a number of innovations that have come with that increasingly performing the Whipple procedure, and that includes laparoscopic Whipples, which we have a few surgeons here at Hopkins who are doing those, as well as relatively complicated vascular reconstruction methods that make those Whipple procedures possible in patients who have tumoral involvement. So SMV and portal vein reconstructions, venous interposition grafts, splenic vein grafts, all of these are used to facilitate the Whipple procedure in patients who have quite significant venous involvement by tumor. Now, as I mentioned before, the classic Whipple procedure is going to give you three anastomoses, right? You're going to have the pancreatic jejunostomy, so the pancreatic remnant and the jejunum. You're going to have a biliary enteric anastomosis, which can be a hepaticojejunostomy or a choledochojejunostomy. And then you're going to have either a gastrojejunostomy in the classic Whipple, so an anastomosis between the stomach and the jejunum, or in a pylorus preserving Whipple procedure where you retain the gastric antrum and the proximal duodenum, you're going to have a duodenojejunostomy. And so those are the three anastomoses that you need to really look at carefully every time you evaluate one of these cases, right? Every case, I find the three anastomoses: hepatico-J, pancreatico-J, and either the gastro-J or the duodenojejunostomy, depending on the type of Whipple procedure the patient has had. Now, I'm a strong believer that anyone who's had a prior Whipple procedure needs to be imaged with dual phase technique. And that means arterial phase imaging, typically at about 30 to 35 seconds after IV contrast, and a venous phase at typically 60 to 70 seconds after IV contrast. Now, I typically avoid giving positive oral contrast in this group of patients unless I'm concerned about a leak at the gastrojejunostomy. And the reason for that is that if you're really looking at the pancreatic remnant and the surgical bed, you don't want contrast pooling in the stomach, potentially resulting in beam hardening artifact or streak artifact that might prevent you from identifying a local recurrence. The only time I give positive oral contrast is in the acute setting where I'm worried about some kind of a leak, usually at the gastrojejunostomy. Now, as I mentioned, the first thing to do anytime you're looking at one of these cases is to find the three anastomoses. The pancreaticojejunostomy tends to be most obvious in the axial plane, and usually you're going to see the anastomosis somewhere near midline or maybe slightly to the right of midline, and immediately adjacent to the anastomosis, you're going to see basically a number of loops of small bowel in the right upper quadrant extending upwards towards the hepaticojejunostomy. Now, it is not at all uncommon to identify this radiodense linear foreign body within the pancreatic duct extending across the anastomosis, as in this case. That's a pancreatic duct stent, which is increasingly being used by surgeons to minimize the risks of a pancreatic leak or a pancreatic fistula. Now, the hepaticojejunostomy tends to be most obvious in the coronal plane, and so I always use my coronal MPRs to identify this particular anastomosis. In rare instances, as in this case, you're going to see a stent traversing the anastomosis, but this is not at all common. And typically, you're going to use gas within the biliary tree, extending from the bile ducts into the jejunum as a way to trace this particular anastomosis. And then finally, the gastrojejunostomy is going to be visible either in the axial or the coronal plane. And typically, it's going to be the easiest of the three anastomoses to identify. In this case, you can nicely see the anastomosis between the stomach and the adjacent jejunum. Now, I think it's important, especially if you're not used to looking at a lot of these cases. In my case, I look at postoperative Whipples pretty much every day, right? We do hundreds of Whipple resections here at Hopkins every year, so I see postoperative Whipple procedures all the time, and over time it becomes obvious what is normal postoperative change and what's actual pathology. But I work with residents and fellows who haven't seen a lot of these cases, and it can be very easy to mistake normal postoperative stuff from actual pathology. So what are you looking for? What's normal in the acute perioperative setting? Well, in the acute setting, it goes without saying that fluid, fat stranding, and edema surrounding the surgical bed are going to be common. There's almost always going to be induration surrounding the SMA and SMV. So in other words, stranding in density immediately posterior to the SMA and SMV, often quite crescentic in morphology. Usually it's just postoperative change. You're going to often see multiple reactive lymph nodes in the central mesentery, usually sub-centimeter, but can rarely be larger. These are not metastatic. These are reactive lymph nodes as a result of the inflammation. Now, in the acute postoperative setting, thickening at the anastomoses is not at all uncommon, right? So you can see thickening of the gastrojejunectomy, and often there may be mild proximal dilatation of the stomach as a result. And you can also see that the pancreatic duct may be dilated as a result of, probably as a result of edema at the pancreatic jejunectomy. Those are common findings, and in most patients, they're just going to resolve over the course of time. Similarly, a little bit of biliary dilatation is not uncommon in the acute setting, again, probably as a result of edema at the hepatococcygeneostomy. So in most cases, as long as it's mild, you're just going to follow it over time, but it doesn't necessarily mean that you've got a recurrent tumor or that you've got a stricture at the anastomosis. Now, here's a normal postoperative case, right? None of this is concerning. There's stranding and edema. Notice this induration behind the SMA and the SMV. Notice the presence of the pancreatic duct stent. All of these findings are going to resolve over time. You don't need to worry about a leak. You don't need to worry about the possibility of recurrent tumor. The pancreatic duct stent in some cases can stay in the same place for months at a time, or in other patients can migrate relatively rapidly into the bowel. It doesn't really matter. I just report where it is on in my dictation. Now, in the chronic setting, that tends to be where people get into more trouble, in that they mistake normal findings for tumor recurrence. Now, in most cases, the inflammatory stuff that I talked about earlier should resolve by about 3 to 6 months. So the induration in the surgical bed, the reactive lymphadenopathy, most of that is going to be gone either at their first follow-up or in their second follow-up by about 6 months. But the one finding that can stick around for a long period of time is this crescentic rind of soft tissue immediately posterior to the SMA and SMV. That is a classic location for postoperative fibrosis. I see it in nearly every patient that I look at. And it's the morphology that's going to help you differentiate this from tumor. It's going to be crescentic, linear, not mass-like. If you start seeing rounded soft tissue, nodular soft tissue, well, that's not likely to be fibrosis. You really have to worry more about recurrent tumor at that time. Now, in most cases, the pancreatic duct and the biliary tree, the dilation of the ducts is going to resolve on one of your follow-up studies. But that being said, it is possible that you can have mild pancreatic and biliary ductal dilatation forever, and it doesn't necessarily mean that you have a stricture. Where you do need to worry is if you see severe dilatation or if that dilatation is progressing over time, and in both cases you need to worry about either anastomotic stricture at the hepatococcygeneostomy or the pancreaticococcygeneostomy, or recurrent tumor that's actually obstructing the duct. Now, thickening of the bowel is actually quite common, especially the right upper quadrant jejunum or thickening of the gastrojejunectomy. And in most cases, this isn't pathology, doesn't mean that you have enteritis or ischemia, but it's usually because these patients are increasingly being treated with adjuvant radiation, either before or after their treatment, and these bowel loops end up getting included within the radiation port, and so they can look thickened for long, long periods of time. And that's not a pathologic finding. And for similar reasons, you can end up with geographic areas of steatosis in the left hepatic lobe as a result of radiation therapy that includes the left hepatic lobe within the radiation port. So now that we know what normal looks like, let's talk about some of the complications that you should be looking for and how exactly you can help guide the treatment of these complications. Now, by far, the most important complication that you need to be cognizant of is pancreatic fistula, which is a kind of fancy surgical term for a pancreatic leak. It represents breakdown either of the pancreaticojejunal anastomosis or a site of surgical injury in the pancreatic parenchyma, resulting in leakage of amylase-rich pancreatic secretions from the pancreatic duct. Now, classically, this was a clinical diagnosis, right? So they would look at the drain fluid amylase level, and if it was 3 times higher than the serum amylase on the 3rd postoperative day, then the surgeons would say, by definition, this patient has a pancreatic fistula. Now, that is still, to this day, the way in which this diagnosis is made in most patients. But that being said, we are increasingly seeing findings on CT that can help suggest this diagnosis, and in many cases, we can make the diagnosis on a CT scan, and they can confirm the diagnosis looking at the drain fluid amylase levels. Now, this is a critical diagnosis to make. This is the single most important cause of morbidity and mortality after the Whipple procedure. I'm going to talk about a bunch of complications. This is the one you've got to be thinking of. The rate of fistula is somewhere between 6 to 14%, and the mortality rate may be as high as 4% if you have a pancreatic fistula. So this is a critical diagnosis, and I'll tell you, talking with our surgeons, this is the one they're always the most worried about. Now, who gets a pancreatic fistula? Now, some of it has to do with surgical technique, but there are a number of risk factors, including having a relatively small pancreatic duct, soft pancreatic parenchyma, or having lots of intraoperative blood loss. And there's also an association with other complications. So if you have a pancreatic fistula, you're more likely to have sepsis, pancreatitis, form an abscess, hemorrhage, or develop delayed gastric emptying. So this is a big deal, right? If you end up with a pancreatic fistula, the odds are that you run the risk of developing other major complications, and you're much more likely to have a poor clinical outcome. Now, as I mentioned, this is primarily a clinical diagnosis based on your drain amylase levels, but any time in the immediate postoperative setting where you see a focal fluid collection, focal blood, or ectopic gas immediately adjacent to the pancreatic jejunostomy, you have to worry about the possibility of a leak. And especially if you can trace that fluid or gas directly in contiguity with the pancreatic duct or the anastomotic suture line. So here's an example. This is a patient who came to us with a known diagnosis of a pancreatic fistula. They had a drain amylase level of close to 5,000, a serum amylase of 26. So as I mentioned, clinically you can make the diagnosis of a pancreatic fistula based on the drain amylase alone. But notice that the CT scan is classic for a leak. There's a focal fluid collection immediately adjacent to the pancreatic jejunal anastomosis. There's ectopic gas. We're not seeing the tiny amounts of free fluid adjacent to the pancreatic bed that I said was normal earlier. This is a large amount of fluid, a discrete fluid collection, lots of ectopic gas, all of which are very close to the pancreatic jejunal anastomosis. Notice that the fluid collection is actually directly invaginating into the anastomosis itself. This is clearly a leak, and you can see in the second image that they've put in a surgical drain, or percutaneous drain. Here's another example. Again, you can see that there is a focal fluid collection directly extending into the pancreatic jejunal anastomosis. If you see that in the immediate postoperative setting, that is a leak until proven otherwise, and you need to call the surgeon and make sure that they have looked at drain amylase levels to confirm the diagnosis. Now, most cases today, if you develop a pancreatic fistula, the patient is going to be treated conservatively. They're going to put in a percutaneous drain to kind of deal with the fluid collection, but the patient typically is not going to go directly to the operating room. The only instance where you might potentially precipitate the patient going back to the OR is if you see signs of massive anastomotic dehiscence. So large free air, large fluid collections, something that makes you suspect that the anastomosis is completely broken down. And typically this is not a clinical dilemma, right? When you have massive anastomotic dehiscence at the pancreatic jejunostomy, these patients are really sick, they're in the ICU, they're on the verge of dying. So this is not usually going to be some kind of a dilemma for the surgeons to deal with. Now, pancreatic jejunal leaks are by far the most common leaks that we deal with in clinical practice, right? Yes, you can rarely end up with leaks at the gastrojejunostomy or at the biliary enteric anastomosis, but honestly, they're pretty rare. Gastrojejunostomy leaks in particular are extraordinarily rare, right? I've only seen, I think, one or two over the last few years, and almost always these are secondary to major technical failures at surgery, and it goes without saying that this is a big deal, almost always associated with major morbidity and mortality, and a gastrojejunostomy leak typically will require them to go back in to do operative intervention. Now, bile leaks or biliary enteric anastomotic leaks are much less common than pancreatic fistula, but certainly much more common than a gastrojejunostomy leak. Again, typically due to technical failure at surgery. You're going to make this diagnosis when you see a focal fluid collection or a large amount of free fluid directly adjacent to the biliary enteric anastomosis. Remember, the location of a fluid collection can be very helpful in terms of figuring out where the patient has a leak. If you see a fluid collection adjacent to the pancreatic jejunostomy, it's most likely a pancreatic fistula or a pancreatic jejunal leak. On the other hand, if you see a fluid collection in the right upper quadrant near the hepatic jejunostomy, you have to worry that it's probably a bile leak from the hepatic jejunostomy. If you're not sure, hepatobiliary scintigraphy or nuclear medicine studies can be very helpful in terms of defining whether the patient truly does have a leak from the biliary enteric anastomosis. Now, pancreatic fistula is the most important complication. I would say the second most important complication that we deal with or see as radiologists is going to be postoperative hemorrhage. Now, if you see enough postoperative Whipple cases, you will see postoperative hemorrhages. And I think a lot of people just aren't aware that this is a major well-known complication of the Whipple procedure, but it is. And even though it's relatively rare, it does occur in up to about 4% of patients, and when it does occur, it's associated with quite significant mortality rates, perhaps as high as about 40%. Now, postoperative hemorrhage after the Whipple procedure typically is extraluminal, so outside of the bowel, 2/3 of cases, but can be intraluminal as well, so can occur within the gastric remnant or the right upper quadrant small bowel. Now, the initial presence of blood clinically clinically or on a CT scan is termed a sentinel bleed. So the first time you bleed, you have to be urgently worked up, as that bleeding implies that you either have A, structural vascular abnormality, or B, an anastomotic dehiscence. But either way, that bleed really heralds the fact that you have something really bad going on and you really need to be worked up to figure out what it is. Now, postoperative hemorrhage can be broadly divided into two types. There is early postoperative hemorrhage that occurs in the first 24 hours after surgery and is almost always going to be bleeding from the GDA stump, typically as a result of inadequate ligation during surgery. On the other hand, late postoperative hemorrhage tends to occur a few days later, usually after 5 days, and by this point you're dealing with a real structural abnormality of the vasculature. So it could be an erosion, a pseudoaneurysm, but again, it's typically going to be from the GDA stump, either active erosion with extravasation or a pseudoaneurysm. Now, these late postoperative bleeds have a very high association with anastomotic breakdown, and again, it goes without saying, associated with very high morbidity and mortality. So here's a patient immediately after the Whipple procedure. You can see that there's a big bleed. Notice the presence of active extravasation. This patient actually ended up going directly to angio for embolization. Here's another example. This patient is about, I think, 6 days after surgery. You can see there's a big hematoma surrounding the pancreatic bed. Now, as I mentioned before, when you have late post-Whipple bleeds, there tends to be an underlying vascular abnormality, a structural abnormality. And in this case, you can see that there's a large pseudoaneurysm of the splenic artery. Now, this is one of the reasons why I am a strong believer you've got to get arterial phase images routinely in patients who've had a prior Whipple. I'm going to promise you, will miss small pseudoaneurysms if you're just dealing with a venous phase. Now, in most cases, the arterial phase may not help you, but in that 1 in 100 case where you're dealing with a large bleed and you want to find that subtle pseudoaneurysm or active extravasation, you will be thankful that you're routinely acquiring the arterial phase images as part of your protocol. Here's another example. This patient had a large bleed adjacent to the surgical bed a few days after the Whipple procedure and noticed that there's a pseudoaneurysm on the angio arising from the inferior pancreatic duodenal artery. Here's another example. Again, a large bleed, active extravasation from the GDA stump. You can see this layering, active extravasation. This patient is, I think, immediately post-op, and so as you'd expect, it's usually going to represent bleeding from the GDA stump. As I mentioned earlier, 2/3 of cases are intraluminal, but I've seen plenty of examples where patients have postoperative Whipple bleeds where it's intraluminal. Classically, either the gastric remnant or the right upper quadrant small bowel. Here's an example. This patient was having massive GI bleeding after surgery, and you can see that there's lots of blood distending these right upper quadrant jejunal loops. And ostensibly, this bleeding has something to do with problems in the vasculature related to the way in which the surgery was done. Now, those are probably the two most important complications in the acute setting. A common complication that I think we tend to miss, or at least underdiagnose on CT, is postoperative pancreatitis. And this is actually quite a difficult diagnosis because how do you know if you're dealing with pancreatitis or alternatively just postoperative inflammatory change? So even though this is pretty common, probably in about 1/3 of all cases, I'd say that we very rarely ever make this diagnosis because we just write it off as being postoperative. That being said, if you see a disproportionate amount of inflammation around the pancreatic remnant, rather than diffusely in the surgical bed, and especially when you see a disproportionate amount of fluid tracking from the pancreas along the pararenal spaces, you should at least think about the possibility of postoperative pancreatitis. Now, another major complication that you have to be looking for when you're dealing with these postoperative cases is portomesenteric venous thrombosis. And this has actually become more and more of a problem as surgeons are doing all kinds of complex venous reconstructions to treat patients who at one point were considered unresectable because of tumoral involvement. It goes without saying that you start doing more venous interposition grafts, jump grafts, so on and so forth, that your risk of venous thrombosis goes up considerably. So if you look at the traditional literature, it says that 17% of patients with a Whipple procedure develop venous thrombosis, and I'd say that's probably an underestimate, given that we've only in the last few years started seeing these more and more complex venous reconstructions. Now, in most cases, patients with portomesenteric venous thrombosis will be treated with systemic anticoagulation, but in the immediate postoperative setting, surgical thrombectomy is theoretically an option. Now, this is a diagnosis that you really shouldn't miss, provided that you take the time to actually look at the vasculature in every postoperative case. This has to be a part of your standard search algorithm. Every time I look at a post-Whipple, I'm looking at the portal vein, looking at the confluence, looking at the SMV. And as long as you look at those vessels, you're not going to miss this diagnosis. This is pretty obvious, right? Portal vein thrombosis, not a difficult diagnosis, provided that you actually take the time to look at the portal vein. Similarly, SMV thrombosis, not difficult. Take the time to look at the vessel, use the coronal reconstructions when you're looking at the SMV, and you won't miss this diagnosis. Now, a relatively rare complication is hepatic infarction, but this is something that you'll see every once in a while. Usually in patients who not only have some kind of surgical injury to the vessel, but also an underlying abnormality in the mesenteric arterial vasculature. And the reason for that is because the liver has a dual blood supply via the hepatic artery and the portal vein, just having a single abnormality or a single vessel involved usually isn't enough to give you an infarct. So typically you have to have an underlying abnormality in the arterial vasculature and then something that pushes you over the edge, whether it's an arterial thrombosis or portal venous clot, so on and so forth. So always these patients will have, severe atherosclerotic disease, median arcuate ligament syndrome, FMD, vasculitis, so on and so forth. And then the surgery and some complication associated with the surgery typically pushes them over the top. Now, I'd say the most common is some kind of an injury to either the hepatic artery or the celiac artery during surgical resection or dissection, and that tends to be especially problematic when you have a larger tumor that's surrounding multiple vessels. And as you can imagine, as we're resecting more and more tumors that do have underlying vascular involvement, this is increasingly common. Now, one situation where I've seen this happen, actually the most common situation where I've seen this happen, is where the presence of a replaced or accessory right hepatic artery wasn't noted on the preoperative scan, wasn't noted at surgery, it was inadvertently sacrificed during the procedure, and the patient ends up with a right hepatic lobe infarct. Now, this is what you don't want happening, right? This patient had a large right hepatic lobe infarct. They actually had, I believe, a replaced right hepatic artery that wasn't noted at surgery or on preoperative imaging. And that infarct has gone on to develop into a biloma. The biloma got superinfected, and now you've got a big infected infarct or infected liver abscess. Now, what's the most common complication in the postoperative setting? And it's actually something that we don't think of as a big deal, and honestly, we don't tend to make this diagnosis a lot on imaging, but it's quite common, and that's delayed gastric emptying, which affects probably about 50% of patients who have undergone a Whipple procedure. No one knows why it happens, right? It may be because of some kind of localized disturbance of the autonomic innervation of the stomach near the operative bed, but that's just a guess. No one really has a good idea why it happens, but we do know that it tends to be more common in patients who have other postoperative complications. Abscess, fistula, intraoperative blood loss, and so on and so forth. Now, in most cases, it's going to be a tough diagnosis to make on a CT scan, and honestly, it's primarily a clinical diagnosis. The surgeons define this as a patient who has prolonged need for a nasogastric tube. So basically, they take the NG tube out, the patient can't tolerate it, they have to put the NG tube back down. That is quote-unquote delayed gastric emptying. But there are some features on a CT scan that can help you at least suggest a diagnosis. So if you see a massively distended stomach with lots of retained ingested material, food particulate material, then you're probably dealing with a patient who has delayed gastric emptying. Now, honestly, the diagnosis is usually going to be obvious to the surgeons clinically. CT isn't really critical for this diagnosis, but it's, I think, something good for the radiologist to understand as to why they're seeing a distended stomach after the Whipple. Now, in most cases, it has to do with the underlying autonomic innervation, but in the immediate postoperative period, you can end up with a dilated stomach as a result of edema and thickening at the gastrojejunal anastomosis, as in this case. But in most instances where you have discrete edema at the anastomosis resulting in some form of partial obstruction, that should resolve over time as the edema goes away. Now, in the chronic setting, one of the complications you have to think about is anastomotic stricture, and this is actually a pretty common delayed complication, both at the hepaticojejunostomy and to a lesser extent at the pancreaticojejunostomy. Now, the timelines or the time frames in which you're going to be looking for these anastomotic strictures is, I think, important to know. Pancreatic and jejunal strictures tend to occur pretty early, right? And so the median time to diagnosis is 3 months. So this is something you're going to see on their immediate postoperative follow-up or maybe a couple of follow-ups down the line. On the other hand, hepaticojejunostomy strictures take a little longer to develop, 18 months, 2 years. So this is something you're going to be looking at years down the line potentially, and so not something you're going to see in the immediate first follow-up or second follow-up. Now, the key when you're looking for anastomotic strictures is to pay careful attention to the size of both the pancreatic and bile ducts, pancreatic duct and the bile ducts. So in every study, this is something that goes into my dictation in the body of the report. I talk about whether the pancreatic duct is stable in size. Is it large? If so, has it changed? Same thing with the biliary tree. Is there new or increasing biliary ductal dilatation? Now, if I see a change in size of either the biliary tree or the pancreatic duct, the first thing I'm going to look for is the presence of a new occult obstructing tumor, right? That's the thing you don't want to miss. You don't want to miss the fact that their pancreatic duct is dilated because they've developed recurrent tumor involving the anastomosis. But if you don't see tumor, then most likely you're dealing with a benign stricture, and that's something that can be in most instances treated non-operatively. And nowadays, patients are typically going to be treated with balloon dilatation. Now, here's an example where I think it'd be very easy to just say, well, the patient has a dilated pancreatic duct, probably have a stricture, right? This is actually new. So the patient had a scan, I think 3 months prior, which looked normal. Now they've got a moderately dilated pancreatic duct. But notice that this pancreatic duct, even though dilated, does not extend all the way to the pancreatic-jejunal anastomosis. It actually stops proximal to the anastomosis. And if you look carefully, especially in the image in the bottom right, there's this subtle nodular focus of hypodensity. Remember what I said earlier. Anytime you see an increased size of the pancreatic duct or the common bile or the biliary tree, you need to rule out the presence of an occult obstructing tumor. And in this case, there was a subtle sub-centimeter obstructing lesion at the pancreatic jejunostomy, and that was confirmed based on endoscopic ultrasound. So in summary, hopefully I've given you again a sense for why proper CT technique is critical. Now, I will admit, in most cases, as long as you have good venous phase images, you're going to be able to identify most complications. But as I've shown you, postoperative bleeding is one of the most feared complications of the Whipple procedure, and if you don't have arterial phase imaging, you potentially could miss active extravasation or a structural vascular anomaly, such as a pseudoaneurysm, that potentially could cause significant morbidity and mortality. Second, understand what's normal. I'd say some of the biggest mistakes I've seen after a Whipple procedure in terms of interpretation have been when people have confused normal findings for pathology or vice versa. They saw something that was clearly abnormal, but they figured, well, it probably is just normal post-op. If you understand what normal looks like, you're going to be in a much better position to identify appropriately those complications that may be life-threatening. Finally, I really believe in taking an algorithmic approach when I'm looking at these post-operative cases. I look at every one of these cases the same way every single time. I look at each of the anastomoses, and then I look for all of the complications that I talked about earlier. Provided that you look at the anatomy adequately and you look carefully for the complications I talked about, you're not going to miss anything major that could lead to significant patient morbidity and mortality. So that's all I have. Thanks again. I'll see you guys later.
Hi, this is Elliot Fishman, and welcome to our latest vodcast. And this is going to be on the incidental cyst. And in fact, we recently did a Facebook Live. And the reason we're doing this now is because the ACR came out with their new guidelines for how to manage pancreatic cysts. And I thought it'd be a good time to simply address this. We have other lectures which I've given, and I have a new lecture coming out on cystic pancreatic lesions. But this is just going to focus on how we manage the incidental pancreatic cyst. We know that it's very common. This article we did on 16-slice CT said 2.6% incidental detection of pancreatic cysts. Now, that was at 16-slice. Imagine now with thinner sections and higher resolution, it's probably closer to, well, surely at least 5%, and this article does mention that. Most of these are simply small cysts or IPMNs. The question is, how do you manage these patients? We know as lesions get larger, the chance of malignancy increases, and so you're more aggressive. The Tanaka criteria typically talks about removing lesions over 3 centimeters, but what do we do with these incidental lesions? Now, I mentioned 5%. There was an article from the MR literature that suggested almost 20% of patients had incidental cysts. MR is very good at picking up very small cysts, but regardless, you can see it's a very common problem. And just for example, here's a simple 1 centimeter or so cyst in the body of the pancreas. And here's a second example of a 2 centimeter lesion, or 2.4. Again, what do you do? Do you follow these? Do you biopsy these? Do you do EUS? What exactly should you be doing? What is the standard? What do you recommend to patients and to your referring physicians? Now, there was an article in JACR 2010. Surgery should be considered for cysts larger than 3 cm if it's a serous cystadenoma, surgery for 4 cm. Following smaller cysts smaller than 1 cm cannot be further characterized. Perhaps we shouldn't follow those. Perhaps older patients we shouldn't follow. A lot of questions. They spoke about aspiration to exclude pseudocysts before surgery. Again, how do you follow patients? All of this was a question, and it's been a problem. Now, what's typically happened is most institutions have developed their own criteria. This is Mass General. Annual imaging surveillance is generally sufficient for benign serous cystadenomas under 4 cm and for asymptomatic lesions. Asymptomatic thin-walled unilocular cysts smaller than 3 cm or side branch IPMNs should be followed with CT or MR at 6 and 12-month intervals after detection. And Saani goes on to say cystic lesions with complex features or growth rates over a centimeter a year should be followed more closely or recommended for resection if the patient's conditions allow surgery. Symptomatic cystic lesions, neoplasms with high-grade potential, lesions larger than 3 cm should be referred for surgical evaluation. Endoscopic ultrasound with fine needle aspiration biopsy can be used preoperatively to assess the risk of malignancy. And that's a pretty good statement. The question then also comes up, how long do you follow these patients for? There was an article in Radiology a couple of years ago that suggested 2 years, but people then wrote, hey, we've seen many lesions where no change happens for 2 years, and then year 3, it's a problem. So we know 2 years is not a good follow-up, and we know that when we talk about cystic pancreatic lesions, and we talk about field defects, and we talk about Pannin, we talk about 10 years to lesion detection. So again, 2 years didn't do it, and so Radiology, that article was revised. But what do we do? Because what can we tell our referring docs, and what do we tell our patients? This article in Press, despite published guidance recommendations and reported awareness of them, fewer than half of follow-up recommendations for focal cystic pancreatic lesions are consistent with guidance and considerably vary between physicians. And we know that. Now, perhaps the reason is radiologists may favor follow-up recommendations that more closely reflect the management algorithm preferred by ordering providers, which means their institution, rather than provided by outside organizations. But at least if you do what's local, we have some rules at Hopkins, and Mass General has rules, and MD Anderson has rules, Mayo Clinic has rules. Now, often these rules are the same, but at least you're following a set of rules, and that becomes very important. And we talk about this all the time, that there is often no perfect answer, but you can't have 5 radiologists giving 5 different answers, and you can't be giving different answers based on days of the week. Well, I mentioned we just have a new article, and this is the article by Alec Megabo et al., Management of Incidental Pancreatic Cysts, a white paper of the ACR Incidental Findings Committee. And I'll just show you what they did and what they recommended. I won't try to give my 2 cents, but let me just tell you what they recommended, and it's a good step. They put things in 5 categories: under 1.5 cm incidental pancreatic cyst, 1.5 to 2.5 incidental cysts with main duct communication, 1 to 2.5 incidental cysts without communication, greater than 2.5 cm incidental, and lesions occurring in patients over age 80. Now, they made some points, and I'll just take one of the statements. How long do you need to follow these patients? For most patients, we advocate 9 to 10 years, terminating at age 80. For patients who are under 65 at time of the initial cyst detection, a follow-up terminating at age 80 will exceed the 9 to 10 year length, but may be prudent. Okay, you can see that they're still not perfect. There is no perfect answer, because if you wanted a perfect answer, it would be forever. But forever is not a perfect answer. So maybe 10 years, and my prediction will be before 10 years from today starts, we'll have another recommendation. But let me show you what they did. And again, you could read this on your own, read the whole article. So here's a good example: incidental pancreatic cyst in a patient over 80. Again, the idea is to be conservative. The risk-reward of doing a Whipple's procedure maybe favors doing nothing. And you could see re-image Q 2 years times 2. If you're really worried, perhaps you can do EUS. But you can see there's a lot of push to basically sit tight and do nothing. And sometimes less is more. Under 1.5 cm cyst, they break it up into under 65 or 65 to 79. And look at the recommendations. Under 65, 1 year times 5 to follow, then Q 2 years times 2, which gives you the 9 years. And if you're older, Q2 times 5, stop if stable over 10 years. If there's growth, again, carefully image the patient. So again, this tries to be conservative as well. The smaller lesions have a lower chance of being malignant. You're looking for interval growth. If the lesions start growing, and again, people often say 1 cm a year, then it's a different story. And you can see, look at the image on your left, under 65, stop if cyst is still under 1.5 cm over a minimum of 10 years. But they're saying at least a 10-year follow-up. So again, you can see we'll be making good friends with these patients for a while. Now, in the 1.5 to 2.5 range, communication absent or cannot be determined. Then they talk about Q 6 months times 4, then Q year times 2, then Q year times 3. So very close follow-up initially, so you can figure out, is this lesion growing? Is this to worry? And the longer you follow it, the more you spread out the follow-ups, because then we're less concerned. We're still going to be concerned, and if you are concerned with the lesion, do EUS or fine needle aspiration. And you can see then, depending on that, you may need to do surgery, or you may need to just simply follow. And again, but perhaps follow for that 10-year period. So again, some strategies in that regard. 1.5 to 2.5, communicated with main pancreatic duct. And again, you can see in the higher ones, 2 to 2.5, perhaps do EUS if you have any question at all. If not, follow closely initially for a couple years every 6 months. If it's under 2 cm, Q1 times 5 years, and then Q2 times 2. Again, watching for interval growth. So the biggest things we look at over time is the lesion getting larger, is it developing septations or nodularity. And then this last one is over 2.5. If it's high risk, then you biopsy it or you take it out. If it's low risk, again, careful follow-up, Q 6 months times 4. Stable over the 2 years, then Q1 times 2, and then still stable, then Q2 times 3. So again, we're getting to that 10-year mark. And again, they're not saying to stop at 10 years, but they're saying you can consider stopping if there's been no change. So again, it does give you some information. And as Megabo says, the natural history of incidental pancreatic lesions remains uncertain, and our recommendations cannot be simple or entirely definitive. Several multi-institutional and specialty society consensus papers, analysis, large-scale studies have appeared, but the quality of evidence has been characterized as poor or inconclusive, and conclusions remain controversial. So they are basically saying we're not positive and we're doing the best we can. So here are 5 of their principles. All incidental cysts should be presumed mucinous unless the cyst has definitive features of an alternative diagnosis, like a serous cystadenoma, and has been aspirated and proven not to be mucinous. Mucinous cysts should be followed or considered for surgery. And again, there's 9 to 10-year follow-up, with the schedules varying depending on patient age and the appearance and size of the lesion. If the lesion tends to grow or is worrisome, then you have to sample it. Cyst size directs follow-up or intervention, although a cyst size thresholds under 1.5, 1.5 to 2.5, or over 2.5 differ from the commonly used 3 cm threshold. They are sensitive to the Sendai criteria of 3 cm, under, or over. Number 3, because the flow charts apply to a range of cyst sizes, growth may require shifting from one flow chart to another, most commonly when a cyst goes from under 1.5 to over 1.5. Again, they mentioned a new 9 to 10 year follow-up period is not necessarily recommended when patients are reaching 80, but in younger patients, you need to start the clock over again. Again, the point about tissue sampling. Number 4, development of worrisome features or high-risk stigmata should prompt EUS, FNA, and surgical consultation. The exception is that cysts over 3 cm without any additional worrisome features or high-risk stigmata can be alternative be followed. And finally, number 5, comparison with prior studies is critical. We do want to see is the lesion growing, and that's why when in the beginning, when we don't know what a 2 cm lesion has done, has it gone from 1 to 2 over the last 3 months, you go Q 6 months times 4, then you have a much tighter range, and you can see if there's any change before it becomes really significant. Now, this is important, and again, this makes things very complicated. You're going to have a lot of patients. One thing we have at Hopkins is a multidisciplinary cyst clinic. It's a good way of managing cyst patients. It's a good way of following them. Because remember now, if you're following someone for 10 years, you're becoming like mammography. Do you need to send reminders? What if a patient doesn't show up? Do you need to call them? It creates all sorts of new issues and potentially new liabilities. So we do have certain rules at Hopkins, depending on the situation. Follow-up in 3 to 6 months, EUS and surgery in patients with main duct IPMNs, MCNs, or growing more than 3 to 5 millimeters over a year. And we have a real chart for doing it, how we follow these lesions, and we do follow them a lot. And when you compare our results to the referring institution where the patients came from, you could see surveillance was more common in our zone, and surgery was more common also. But again, many other people were discharged from follow-up. We spoke about risk factors. And again, we did change the numbers specifically, and multidisciplinary input with the multidisciplinary conference, it's helpful in the management of patients with pancreatic cysts and alters management decisions up to 30% of cases. So again, one of the things we find out, we learned this with pancreatic cancer, we're relearning with pancreatic cysts. Get together, look at the cases, and then you could give the right diagnosis and the best management decision. And from that same article, most common diagnosis was IPMN. A multidisciplinary conference altered the risk category in 8% of 138 patients. Management category in 30%. Management was increased in 52 patients, including 22 patients who were recommended surgery. Management was decreased in 16, including 10 who had their recommendation going from surgery to surveillance. So you can see when we see the patient, is not necessarily going to be we're going to get more surgery. It may be we're going to get more follow-up. And again, 1/3 of the management changes came from this conference. So none of the patients in whom the recommendation was changed from surgery to surveillance developed evidence of malignancy during follow-up, and that's still true today. So again, you want to make certain when you make recommendations, you make the right recommendations. And let me then end with this Mark Robin with his article, Non-adherence to management recommendations among radiologists was particularly notable in the subset of cases in which no follow-up recommendation was made. Just over 40% of reports correctly followed ACR guidelines but not providing a follow-up recommendation. Based on the algorithm, however, our radiologist should have provided a follow-up recommendation in almost 60% of the sample. So what we're saying to you is you need to have a strategy. You need to follow the strategy. It's not perfect, but it's the best we have. So the ACR is a good one for you to follow. If your institution has a lot of experience and it varies a little bit, you can follow your own institution. But at the end of the day, you need some type of rules. It's not the wild, wild west. We need some rules, and with rules, we'll all do a whole lot better, and the patients will sleep a whole lot better. And with that, have a great day. Bye.
So good morning, ladies and gentlemen. I hope you enjoyed the dinner of yesterday evening. So this morning we will discuss this topic concerning dilated pancreatic duct. Before to talk about the dilation of the pancreatic duct, few words about the normal pancreatic ducts, which consist of the main pancreatic duct, the side branches, and eventually the anatomical variants. May be interesting to remember that the face description of the main pancreatic duct was made by Wilson, who was a German anatomist, but at that time he worked in Italy, in Padua, in the old University of Padua. The normal main pancreatic duct, the Wilson duct, has a diameter which depends on the site. In the head is 3.5 millimeter, in the body is 2.5 millimeter, in the tail 1.5 millimeter. Maybe that we are less interested in the length of the main pancreatic duct, but this varies from 9.5 centimeter to 25 centimeter. And how can we image the pancreatic duct? Well, today we have several possibilities with ultrasonography, of course, with multi-detector computed tomography, with MRI and magnetic resonance cholangiopancreatography, and of course with ERCP, or whether today the most important modality has become magnetic resonance imaging with magnetic resonance cholangiopancreatography. The dilation of the pancreatic duct may be complete when the dilation involves most of the main pancreatic duct from the papilla to the tail of the pancreas, or partial dilation when the dilation involves only a part of the MPD, like a segment in the tail, in the body, or in the head, or eventually in the body tail, or in the head and the body. We can have also multiple segmental dilations. And the dilation, either complete or partial, can be associated with stenosis or occlusion, or without stenosis or occlusion. And we will try to cover all these different possibilities. All the pathologies involving the pancreas can produce dilation of the pancreatic duct, or whether acute pancreatitis will rarely be associated with dilation of the pancreatic duct, while chronic pancreatitis and pancreatic tumor are usually associated with dilation of the main pancreatic duct. So we will start looking at these pathologies. We start with acute pancreatitis. I've already said that acute pancreatitis is rarely associated with dilation of the main pancreatic duct, and this is because of the compression of the pancreatic edematous parenchyma on the ductal system of the pancreas. Dilation can be seen in high-grade necrotizing acute pancreatitis, like grade C and D of Balthazar classification. Anyway, the degree of dilation will be mild, like in this example of extensive acute necrotizing pancreatitis of the head of the pancreas, where we see mild dilation of the main pancreatic duct and side branches, which is well demonstrated on this MR cholangiopancreatography. Another case of dilation of the main pancreatic duct, well seen at computed tomography, MRCP and ERCP, probably due to a major involvement of the head of the pancreas in this case, which produced some degree of compression of the proximal part of the main pancreatic duct. Another example of extensive acute pancreatitis involving the head and the surrounding structures, with dilation of the main pancreatic duct, which show irregularities, which are best demonstrated at the MRCP with these irregularities. This is because this patient had a history of recurrent pancreatitis with an acute episodes of acute necrotizing pancreatitis. Moving to chronic pancreatitis, in this disease we will see a frequent dilation of the main pancreatic duct associated with strictures, irregularities, and ectasia of the side branches. This is well known and is the basis of the Cambridge criteria. Cambridge criteria were based on previously ERCP, but this classification divides Cambridge 1, in which there are no abnormalities of the pancreatic ductal anatomy, Cambridge 2, in which there is dilation of less than 3 side branches, Cambridge 3, which is a mild disease where we have 3 side branches with a normal main pancreatic duct, 4, in which there are similar findings to category 3, plus stenosis and dilation, and Cambridge 5, where we have additional calculi, obstruction, cyst, and stenosis. These are examples of this classification based on MRCP, a normal pancreatic duct, a Cambridge 2, where we detect only 2 side branches and the borderline main pancreatic duct, a Cambridge 3, where we see still a borderline dilation of the main pancreatic duct together with multiple dilation of the side branches, a Cambridge 4, where we see a definitely dilated main pancreatic duct with irregularities and dilation of the side branches, and the Cambridge 5, where we see additional field effects, which are best demonstrated on computed tomography, as computed tomography is the most sensitive technique to show the presence of stones. However, we have also to remember that chronic pancreatitis may be either diffuse or focal, and so we can have a similar appearance to the previous case with dilation of the main pancreatic duct, irregularities, cysts, and side branches dilated, or focal, where we see a stenosis of a segment of the main pancreatic duct with upstream dilation with dilated side branches. It is also important to note that these images has to be compared with the axial images, where we see the extensive involvement of the pancreatic parenchyma, which appears hypointense on this T1 weighted FATSAT image due to the fibrotic evolution of the pancreatic parenchyma. In this case of focal pancreatitis, chronic pancreatitis, we detect the diffuse hypointensity of the involved pancreas, and you can see the normal appearance of the head of the pancreas, which has its normal high signal intensity and normal vascularization following contrast administration. When considering chronic pancreatitis, we have to remember that it may be very useful to use secretin stimulation to study the duct and the function of the pancreas. Secretin gives a measurement of pancreatic secretion volume and enable to assess the exocrine function of the gland. But very important, it provides more detailed information about ductal changes. This is an example. Without secretin, we see irregularities at the level of the tail of the pancreas, one side branch dilated. Following secretin administration, we see the increase in size of the main pancreatic duct, but at least 1, 2, 3, 4 side branches dilated. At the end of the test, at 10 minutes, we see that the main pancreatic duct has the same caliber as the basal study. So this is a normal function of the pancreas with normal filling of the duodenal loop. Chronic pancreatitis usually classified, especially in the advanced stage, as obstructive pancreatitis and non-obstructive pancreatitis. Obstructive pancreatitis is generally due to inflammatory stenosis at the level of the major papilla, or to malformations like pancreas divisum, or scars as a result of episodes of acute necrotizing pancreatitis, or due to the duodenal wall dystrophy or paraduodenal pancreatitis, and in few cases to slow-growing tumors. Just an example, this is a a patient in which we have a baseline study before secretin, in which we see some degree of dilation of the main pancreatic duct, but this becomes obvious following secretin administration. We see the dilation of the main pancreatic duct. We detect also a dilation of the Santorini duct. At the end of the test, at 10 minutes, we see that the duct is still dilated, and this is an indirect sign of an inflammation at the level of the papilla. You can notice, however, that in this case the function, the exocrine function, is still maintained with good filling of the duodenal loop. The non-obstructive pancreatitis are the autoimmune pancreatitis and gene mutation associated pancreatitis. It is interesting to remember, however, that autoimmune pancreatitis is not associated with dilation of the main pancreatic duct, since the duct is compressed by the cellular material, by the lymphoplasmocytic infiltrates around it. And so, in general, as in this case, we see diffuse and irregular narrowing of the main pancreatic duct and associated involvement of the biliary ducts, as in this case, and which can involve also the intrahepatic bile ducts in a form of autoimmune cholangitis, or whether, in some cases, autoimmune pancreatitis can be associated with dilation of the main pancreatic duct. This occurs in cases of focal pancreatitis, mainly located in the head of the pancreas, since this disease compresses the main pancreatic duct, so we have an upstream dilation of the main pancreatic duct in some cases of focal autoimmune pancreatitis. Moving to pancreatic tumor, in these cases we see frequent dilation, but also in the cases of pancreatic tumors, we can make a distinction between those tumors which are frequently associated with dilation of the main pancreatic duct, such as pancreatic adenocarcinoma, tumor of the papilla of Vater, IPMN of the main pancreatic duct, and those tumors which are rarely associated with the dilation of the main pancreatic duct. In few cases, we will see dilation with neuroendocrine tumors or with cystic tumors like serous and mucinous cystoadenomas and mucinous cystoadenocarcinomas. Rarely, there is dilation in cases of IPMN of the branch ducts also. Concerning pancreatic tumor and dilation of the main pancreatic duct, we see irregular ductal stenosis associated with dilation of the upstream main pancreatic duct and side branches because the tumor causes a chronic obstruction. So what we see is an upstream obstructive chronic pancreatitis in many of these cases. An additional sign, very important, is the double duct sign, which is seen in the lesion of the head of the pancreas and consists in the dilation of the main pancreatic duct and the common bile duct. In cases of lesion located in the body and tail, we will see usually an abrupt narrowing with upstream dilation of the main pancreatic duct. So this is the typical double duct signs, dilation of the common bile duct and the Wirsung duct caused by a pancreatic tumor, a pancreatic adenocarcinoma, which cause this type of obstruction. Alternatively, the same feature can be caused by a tumor located at the level of the papilla, as shown in this slide, where we see the dilation of the main pancreatic duct and the dilation of the common bile duct. Similar feature as seen in MR imaging. This is a typical appearance of the double duct sign with MR imaging, dilation of both ducts. And of course, we have also always to rely on the coronal and axial images where we see this mass at the level of the head of the pancreas with this necrotic appearance, a typical case of pancreatic adenocarcinoma. Another example of double duct signs, dilation of the two ducts with a filling defect at the distal common bile duct, which may resemble large stones, or whether we have always to refer to the axial or coronal images, and in this case it is rather obvious that this lesion is enhancing following contrast administration, and this was a case of tumor of the papilla of Vater. The abrupt narrowing with the upstream dilation is seen in more distally located lesions, like in tumor of the body or tail of the pancreas, which infiltrate the main pancreatic duct and cause this type of dilation, or extensive lesion located in the head of the pancreas. In this case, we see the dilation of the main pancreatic duct at the level of the body and tail of the pancreas. Or whether the cases are not always so obvious, because we can see dilation of the main pancreatic duct, two examples of different types of stenosis, but these two cases may resemble very similar if we compare the two images. And it has shown in the recent past that the injection of secretin may be of value in these cases, because after secretin injection, in the case you see the tract which was stenosed filling with the fluid, this will be a benign stricture, while if there is no filling of the segment which was involved previously to secretin injection, this is most likely to be a malignant lesion. So this is a case of obstructive chronic pancreatitis, and this is a case of adenocarcinoma of the pancreas, of the head of the pancreas, and this sign is called duct penetrating sign. It was described by Ishikawa in 2001, and it is of value when you have to differentiate some difficult stenosis of the pancreas. Another cause of dilation of the main pancreatic duct is, of course, IPMN. IPMN may be segmental or diffuse. They involve the main pancreatic duct. In other cases, when associated with branch duct dilation, we call mixed IPMN. Of course, IPMN may involve only the branch ducts, the secondary or IPMN of the branch ducts. In cases of IPMN, we have ductal dilatation, which can be generalized or segmental. The ectasia is caused by a papillary tumor like this one that completely fills the duct, or by a tumor in the proximal portion of the main pancreatic duct, mechanically blocking the entire duct because it is filled by mucus secretion. Here we have a series of examples of IPMN involving the main pancreatic duct. You see this feature of sharp margin. In general, the main pancreatic duct has sharp margin, and this is one of the differential criteria with the dilation we see in chronic pancreatitis. The involvement may be complete, as in this case, or partial, as in this case, where the major involvement is in the body tail of the pancreas. You can see that in some cases, the enlargement and the involvement of the main pancreatic duct is very, very large, very impressive. In other cases, we will see filling defects within the dilated pancreatic duct. These filling defects may be due either to mucus content or to papillary projection, as in this case where we see this papillary projection inside the dilated main pancreatic duct, with showing enhancement following contrast administration. Moving to the pancreatic tumors with rare dilation, in general, dilation with neuroendocrine tumor, like in this case, is not so common. This criteria is one of the criteria for the differential diagnosis between pancreatic adenocarcinoma which is associated with dilation of the main pancreatic duct, and neuroendocrine tumor, which usually are not associated with dilation, or whether you can see, of course, some degree of dilation, like in these cases, also with large neuroendocrine tumor. An interesting example of neuroendocrine tumor, which involves the main pancreatic duct, can be seen in these two cases, in which we detect mild dilation of the main pancreatic duct at the level of the tail of the pancreas, caused by this small area of enhancement at the level of the initial dilation of the main pancreatic duct. Another example of dilation, and you may see in this area a small enhancement at the level of the initial dilation of the main pancreatic duct. Both these cases were operated, and you may see the lesion of this case located in this part of the anatomic specimen. This is the Wirsung duct, which was dilated. Both cases were classified as carcinoma, and there is an interesting study which dedicated to this type of lesion. Small carcinoid may produce dilation of the main pancreatic duct because they produce serotonin, and serotonin produces fibrosis around it, like the same we see at the level of the mesentery, and this is the explanation for this dilation of the main pancreatic duct. Rarely, but it is possible to see dilation of the main pancreatic duct also in cases of large cystic tumor, like in this example of large mucinous cystoadenocarcinomas of the tail of the pancreas with this dilated main pancreatic duct with sign of chronic obstructive pancreatitis. Finally, the IPMN of the branch ducts may be associated with dilation. They, in fact, are cystic dilation of the secondary ductal system, usually very small, may be unifocal and multifocal, and these are a series of examples of very small IPMN and IPMN isolated, IPMN at the level of the tail of the pancreas, multiple IPMN. The typical IPMN are these cases in which we see a definite communication with the main pancreatic duct. And you may notice that this main pancreatic duct has a mild dilation. The explanation of this mild dilation may be two causes. One is that it could be an associated mixed IPMN. That means that the IPMN involves these ducts, but also the main pancreatic duct. But an alternative is that the mucus produced by the IPMN go inside the main pancreatic duct, and the flow is obstructed by the mucus. So the main pancreatic duct is relatively dilated for a sort of sub-obstruction. Dilated pancreatic duct in case of IPMN raise the risk factor for the presence of carcinoma. This is a controversial topic, so I will be very short on this topic. There is the possibility of a neoplastic evolution. There is a wide range of reported data in the literature from 6 to 46%, but this afternoon there will be a lecture on this topic, so I will go very fast. Criteria for risk are the association of dilation of the main pancreatic duct, mural nodules, cyst size greater than 3 centimeters. Cyst size greater than 3 centimeters is an important factor. So we have seen different examples of dilation of the main pancreatic duct and associated side branches in cases of acute pancreatitis, chronic pancreatitis, and different type of tumors. And we have seen cases of complete dilation, partial dilation, associated or not with stenosis or occlusion of the main pancreatic duct. I will go through few examples just to simplify the approach to the dilation of the main pancreatic duct, starting with some cases of complete dilation associated with the stenosis. When we see a dilation complete or almost complete of the main pancreatic duct, we have to think to common causes and rare causes. Among the common causes, pancreatic adenocarcinoma is the first possibility. And when we see a double duct sign, it is the most likely possibility. Like in this example, which is of course confirmed by the other sections we obtained during the MR examination, which shows a relatively large tumor of the head of the pancreas. So this was a pancreatic adenocarcinoma. Another possibility, again, two double duct signs. Both the ducts are dilated, but we see filling defects both in the common bile ducts and the pancreatic duct. These represent stones. So we are with the case of pancreatic chronic pancreatitis as confirmed by computed tomography in this case. So this is rather obvious. This may be a more difficult case. We have dilation of the bile ducts and not too much, but also the main pancreatic duct is dilated. So we have again a double duct sign, and I have said that in general when we see a double duct sign we have to think to a neoplastic condition first. But in this case, if we look at the axial images, we see that there is a low signal intensity in the head of the pancreas, which is enlarged in the basal scan. But following contrast enhancement, we do not see the low signal intensity area we usually see with pancreatic adenocarcinoma. In the equilibrium phase, we see that there is a late enhancement. And we learn that this is one of the features of autoimmune pancreatitis. Additionally, if we look closely the main pancreatic duct, we see multiple strictures. And multiple strictures are another feature of autoimmune pancreatitis. So this case was effectively an autoimmune pancreatitis. Moving to dilation without stenosis, the most likely possibility is IPMN of the main pancreatic duct, and these are other cases of extensive IPMN of the main pancreatic duct. These are really mixed IPMN of the main pancreatic duct. But again, the diagnosis in these cases looks not very difficult. This can be demonstrated also with CT. I usually show cases of MR when concerning IPMN of the main pancreatic duct, but I want to point out that also CT can show dilation with uniform margin with associated dilation of the side branches, representing a case of mixed IPMN of the main pancreatic duct. Moving to the partial dilation with stenosis or occlusion, well, we have seen in the previous part that partial dilation of the main pancreatic duct with stenosis among common causes we will find pancreatic adenocarcinoma, and of course this is the most likely possibility, and the axial section will confirm the presence of a low signal intensity area in the T1 FAT-SAT image with non-homogeneous enhancement following contrast administration and restriction in diffusion-weighted images and ADC, or whether there are also other causes. But this is the most common cause, and all cases like this will be first a pancreatic adenocarcinoma and then other possibilities. Alternatively, we can see rarely neuroendocrine tumor, other cystic lesion, autoimmune pancreatitis. But remember, when you see a lesion like this or a lesion like this will be most likely a pancreatic adenocarcinoma. You may use, as we have already seen, secretin administration if you don't see the filling of this segment, of the stenotic segment, this will be a pancreatic adenocarcinoma, as shown in this example. Look at this case. We have dilation of the main pancreatic duct upstream this lesion, but of course we have the possibility to understand that this is not a case of pancreatic adenocarcinoma, because following contrast administration we see the enhancing lesion to a degree similar to that of the aorta, so this is a neuroendocrine tumor, while these are rare cases of cystic lesion, large cystic lesion. This is a serous cystoadenoma, which cause dilation of the upstream main pancreatic duct. Rare causes, but it has to be remembered, of dilation of the main pancreatic duct can occur following acute pancreatitis, acute necrotic pancreatitis. If we see this stenosis the first time, it may be difficult to characterize this type of stenosis, but the clinical histories, and especially previous imaging, will explain the reason for this stenosis. This patient had an extensive acute necrotizing pancreatitis, which evolved positively with digression, with the solution of this fluid collection, but a scar developed at this level. 1 year before, the patient had already some degree of dilation of the main pancreatic duct, and 1 year later there was a dilation, a definite dilation, and so this was a case of scar post-acute pancreatitis. And also autoimmune pancreatitis sometimes has to be considered in the differential diagnosis. Remember, multiple stenosis of the main pancreatic duct at MRCP. Think the possibility of this relatively rare condition. Of course, you will rely also on this other imaging feature, the enlargement of the gland, the late enhancement in the equilibrium phase typical of this disease, and eventually you have also the follow-up for after steroid therapy, which will show the decreasing size of the gland and the almost normal appearance of the main pancreatic duct following steroid therapy. We have also the possibility of dilation without stenosis of occlusion. These occur in cases of IPMN of the main pancreatic duct. We have already seen this example. You see dilation, but you don't see stenosis. So although this case may be difficult, when you see a dilation of the main pancreatic duct without stenosis, think to the possibility of IPMN of the main pancreatic duct. This is another example with computed tomography. We have this dilation, isolated dilation, but there is no stenosis. We see the dilation till the papilla without a definite stenosis, so we have to think to the possibility of an IPMN of the main pancreatic duct. So we have seen different cases in different pathologies of dilation of the pancreatic duct system. This is there is a controversy in the literature about the significance of slight dilation of the main pancreatic duct associated or not to the presence of pancreatic cyst. If you go to the literature, you may find different papers on these topics. First of all, this paper from Tanaka, which published in the Japanese literature in 2002, a paper concerning main pancreatic duct dilation, a sign of high risk for pancreatic cancer. There are a number of papers concerning the significance of cyst in the pancreas. I refer to this by Fernandez del Castillo, incidental pancreatic cyst, clinical pathological characteristics. More recently, in Radiology 2010, the same Japanese author presented a paper on slight dilation of the main pancreatic duct and presence of pancreatic cyst as predictive signs of pancreatic cancer. This was a prospective study based on large population, and in the same number of radiology, there is a commentary, an extensive commentary by Megibov on the paper from Tanaka. So this is another important feature on the significance of the dilation of the pancreatic duct, which is rather different from the cases we have seen. But the important thing coming from this paper is that this author, by monitoring this group of patients for a long period of time, they demonstrated that there is an increased risk to develop pancreatic cancer in the patient with the dilation of the main pancreatic duct greater than 2.5 millimeter measured at ultrasound, and similar features were found concerning cysts. If patient had both main pancreatic duct dilation and cyst, the pancreatic cancer development was more likely, and they predicted that the incidence could be 1,000, about 1,000 per 100,000 versus 37.5 cases per 100,000 in the normal population matched for same age. So these are data which are important. We can understand that these data are important, and at the end of the paper they recommend periodic checkup at least once a year for people with slight dilation of the main pancreatic duct and pancreatic simple cyst. And in fact, we agree partially with this conclusion. We also make follow-up for cysts in the pancreas. So this is an example of probably many of those cysts in the paper of Tanaka were IPMN of the branch duct. This is one of our cases in which 2 years later we see a mild increase in size of this IPMN located at the level of the head of the pancreas. In our experience on a series of more than 150 patients, or whether we see very mild changes over time in the mean follow-up of these lesions. In the head, there was a very mild increase in the size of the cyst. This was something, there was a greater increase in the size of the cyst in the body tail of the pancreas. But anyway, in the mean of 2 years, but we have patients with a longer follow-up of 5 years and more, these changes in size was minimal. And similarly, in the same paper, we could observe a very mild increase in the size of the main pancreatic duct. No change in the size in the head of the pancreas, a mild change in the size in the main pancreatic duct in the body tail of the pancreas. So there we recognize that there is a predictive value to the development of a risk of pancreatic adenocarcinoma in the presence of slight dilation and cyst, or whether, as pointed out by Megibov, in the same number of radiology, we have to think about the risk of overdiagnosis, overtesting, and of course, increased cost when evaluating these mild changes at the level of the pancreas. So to conclude my presentation, dilation of the main pancreatic duct is an important sign, as we have seen in my presentation, but it has to be evaluated together with other imaging features to reach a correct diagnosis of the pancreatic diseases. So I thank you for your kind attention. Thank you very much.
Hello everyone, I'm Dr. Linda Chu and I'm an assistant professor of radiology at Johns Hopkins. And today we will be talking about multi-detector CT of pancreatic cancer, pearls and pitfalls. So in this brief talk, we're going to go over some technical errors and interpretation errors that contribute to the misdiagnosis of pancreatic cancer. I'll present the material in a case-based review format of these challenges in pancreatic cancer detection and suggest some potential solutions to mitigate these errors. Pancreatic ductal adenocarcinoma is the 12th most common cause of cancer, but it's the 3rd most common cause of cancer death in the U.S., and that's because the prognosis of the disease is dismal, with only about a 5-year survival rate of 8%. More than 50% of patients already have metastatic disease at the time of diagnosis and are not candidates for surgical resection. CT and MRI are the most commonly used imaging modalities for the initial evaluation of suspected pancreatic cancer. Sensitivity of CT and MRI for detection of pancreatic cancer ranges from about 76 to 96%. But the accuracy of pancreatic cancer detection and staging critically depends on imaging technique and experience of the radiologists. We're all familiar with this classic case of PDAC, in which you see this large hypoenhancing pancreatic body mass. And we oftentimes also see secondary signs, such as in this case when we have dilatation of the pancreatic duct and associated atrophy of the pancreatic body and tail. And usually with head tumors, we'll see obstruction of both the main pancreatic duct and the common bile duct, known as the double duct sign. And in some more advanced cases, we may see vascular encasement and stricture. Some more classic examples of PDAC. Here we have an ill-defined hypoenhancing mass within the pancreatic body. And again, we have the secondary signs of a dilated pancreatic duct and parenchymal atrophy. Here is the case on the coronal view, in which we see this hypoenhancing mass in the head, and we have obstruction of the common bile duct. In this different example, we have a more infiltrative kind of growth pattern, and here we do see vascular encasement of the central mesenteric vessels, and some of these are better seen on the coronal images. So early findings of pancreatic cancer can be detected up to 34 months in advance prior to clinical diagnosis of PDAC in a retrospective study. And both the diagnosis and staging of PDAC are very challenging, and up to 19% of patients referred to a tertiary referral center had a change in the status of their clinical staging or diagnosis. Detection of PDAC is challenging due to various technical errors and interpretation errors, and recognition and mitigation of these errors will have a profound impact in earlier disease diagnosis and improvement of patient prognosis. When I think about the challenges in PDAC detection, I can break them down into different categories. There may be various technical challenges, and even if you perform the case with the best possible technique, there are some features about the tumors themselves that can make things challenging. There may be coexisting pathology that make detection difficult, or the radiologist may be susceptible to cognitive errors that make the detection challenging. And there are also mimickers of PDAC that are either normal anatomic structures or non-neoplastic diseases that can simulate the appearance of PDAC. So first, we're going to go over some of the technical challenges. I think one of the big technical challenges is sometimes the CT scan may be obtained for a different purpose, or patient may have renal insufficiency, and it's obtained with a non-contrast technique. So this case was a case that was done as an outside institution, and what you do see is that there's this very ill-defined soft tissue that extends from the pancreatic tail into the spleen. And it's kind of hard to figure out what exactly is going on. And in fact, the outside report said just nondescript fullness of the pancreatic tail, and significance is undetermined. And frankly, if I were the referring clinician, I may be rather perplexed about what I should be doing with this case. In this case, because of underlying renal insufficiency, they pursued a non-contrast MRI at the outside institution. And again, you see this ill-defined soft tissue that's extending from the pancreatic tail to the spleen. That's still not very conclusive, and they went on to get a PET in which we see abnormal metabolic activity corresponding to this abnormal soft tissue, and this was a biopsy-proven pancreatic adenocarcinoma. A similar case here that was done at Hopkins, in which my very astute colleagues noticed that there's also abnormal fullness of the pancreatic tail compared to the body. Frankly, this is a very tricky case and it can be very easy to miss, but if you look closely, there is this very subtle hypoattenuation of the tail and subtle fullness relative to the normal background pancreas. And again, you can appreciate there's this subtle fullness and subtle hypoattenuation on the coronal view. So we appropriately recommended a dedicated pancreatic protocol CT. And you see that there's a hypoenhancing mass within the tail, and it was consistent with pancreatic adenocarcinoma. So pancreatic pathology may be incidentally detected on non-contrast CT obtained for other clinical indications, and any suspicious pancreatic pathology should be further evaluated with a biphasic pancreatic protocol CT. And the recommended CT technique was published in this paper in Radiology a few years ago, in which it described what the recommended technique should be and what the reporting template should be. So in this table, I have summarized the consensus recommendation in the middle column and our more specific JHU protocol on the right-hand side. So the recommendation is that you should perform the study with sub-millimeter section thickness, in our case 0.6 millimeter collimation, and we give a liter of water as a neutral oral contrast because that way it won't interfere with the 3D reconstructions. We give between 100 to 120 milliliters of non-ionic contrast and inject at an injection rate of 4 to 5 milliliters per second. That way we get very nice enhancement of all the organs and very nice soft tissue differentiation between the tumor and the background pancreas. In the consensus, they recommend the pancreatic parenchymal phase with the acquisition between 40 to 50 seconds after injection. At Hopkins, we do tend to run it slightly earlier. We do bolus tracking of the abdominal aorta with a threshold of 230 Hauser units, and that usually works out to be about 35 seconds or so. And both of them, we recommend a portovenous phase. And I think image reconstruction is also very important. We routinely reconstruct into thins, the 0.75 millimeter slices and the 3 millimeter slices. Most people would do the interpretation on the 3 millimeter slices because they tend to be less noisy, but the thins, the 0.75 millimeters, are very nice for troubleshooting. And we also routinely look at MPRs, MIPS, and 3D volume rendered images to look at vascular involvement, which is critical for staging purposes. And just to emphasize the importance of the biphasic technique, this is a case of a patient with pancreatic neuroendocrine tumor. And you can see that on the arterial phase images, you can see this really brightly enhancing bilobed mass within the body. But when you look at the venous phase images that's acquired about 30 seconds later, you can barely perceive the mass. All you appreciate is really this very subtle contour abnormality of the pancreas. And if the venous phase CT is all that you have, you can easily miss this pancreatic neuroendocrine tumor. A similar case here, patient with history of metastatic renal cell carcinoma to the pancreas. If you strictly just look at the venous phase images, again, you may see some of the small tumors, but this tumor that's actually bigger is rather hard to see. But you can see them all very clearly on the arterial phase images. Another factor on the technical side, as I mentioned, are their critical MPR and 3D reconstructions. This is a very locally advanced pancreatic cancer in which you have encasement of the SMA branches and you have tumor thrombus extending into the SMV. You can make out all these findings on the axial images, but when you look on the MPR coronal images and the volume rendered images, you can appreciate this tumor thrombus extending into the SMV much easier compared to just regular axial images. Another similar case here of a locally advanced pancreatic cancer in which it encases both the arteries and the portal SMV confluence. And again, some of these MIP reconstructions can help lay out the course of the vessel and allow you to further appreciate the degree of local vascular involvement. And more recently, now we are doing a lot of these cases with cinematic rendering, and if you haven't seen these cinematic render images before, they basically use a different lighting model so that you can get more photorealistic images. You can get better shadowing effects, better depth perception, so these images are really great to look at the vascular involvement, and our surgeons really like these for pre-surgical planning. And in fact, when they really love it when we can show them in kind of a movie, in which in a different patient here, we just have this locally advanced pancreatic cancer that clearly is encasing the central mesenteric vessels. And with just changing the windowing effects, we can fade out the tumor and the adjacent soft tissues to fully focus on the underlying vasculature, and we can see the effect of the vasculature so the surgeons can plan if the tumor is going to be resectable or what kind of vascular reconstruction options that the patient has. Another technical issue that's usually more of a problem with MRI would be suboptimal image quality. This is a patient who had a pancreatic cancer, but by the time they got to the post-GAD images, had a really hard time holding their breath. As a result, all of these images are rather blurry and have a lot of respiratory motion artifact. You can still appreciate that there's a tumor there, but it would be very difficult to see in terms of vascular involvement and staging purposes. And just to show you, that mass corresponds to this FDG avid mass on the PET-CT. The reported accuracy in determining tumor resectability is higher for CT compared to MRI, and MRI is much more susceptible to respiratory motion and other artifacts compared to CT. MR is usually reserved as a second-line modality for pancreatic cancer staging, usually in the setting where contrast-enhanced CT is contraindicated due to either severe renal insufficiency or contrast allergy. Another problem that's more commonly found with MRI than with CT would be incomplete anatomic coverage. This is a case from a patient who has history of pancreatic cysts and who has been coming for follow-up year after year. And on this MRCP, we see that there are multiple pancreatic cysts throughout the pancreas, and we just read it as stable IPMNs. What we failed to recognize is that there is this subtly T2 hyperintense lesion in the uncinate process that we did not completely cover in our axial stack of images. Unfortunately for the patient, on the follow-up CT 10 months later, this mass has grown significantly bigger and is locally advanced, and the patient was no longer surgically resectable. So just be aware that the pancreatic head and uncinate process may be incompletely included in the axial MR images due to variability in patients' breath hold, and we need to educate our technologists to recognize incomplete coverage through quality assurance mechanisms. And just a shout out to CT, that I think for the detection and staging of pancreatic cancer, CT is really the best modality around. And next, we'll go over some challenging PDAC cases that make the diagnosis tricky and easy to miss. So obviously, if the pancreatic cancer is small, that would make it very difficult to diagnose, such as this patient here, that it has, if you look very closely, it has a subtle hypoenhancing area within the pancreatic body-tail junction. And on the coronal, again, you see this kind of very subtle hypoenhancement of the pancreatic body. This was not recognized on the outside, and unfortunately, on a follow-up CT 8 months later, patient has developed a locally advanced pancreatic cancer and was no longer surgically resectable. So one important thing to keep in mind is that if you routinely look at the sub-millimeter thin CT slices, that could help you minimize any volume averaging effects and improve the visualization of the small masses. And also, I think that reviewing coronal images also help, because a lot of the times if you look at just straight axial images, it can be tricky to see if what you're seeing is just a little bit of a fat lobulation or if it's truly a mass. And if you look on the coronal images, that gives you a better sense of the normal contour of the pancreas. Another type of case that is very tricky would be the exophytic growth pattern, such as this case here. When you look at it, most of the pancreatic head looks pretty good, but you have this abnormal soft tissue within the retroperitoneum that's encasing the vessels. And then if you look very closely, trying to figure out where this abnormal retroperitoneal soft tissue is coming from, then you start to notice that it's contiguous with the uncinate process and there's subtle hypoenhancement there. So exophytic pancreatic mass with an infiltrative growth pattern can be mistaken for metastatic lymphadenopathy, lymphoma, neurogenic tumors, or even vasculitis. Subtle hypoenhancement of the pancreas that is continuous with this soft tissue infiltration is the clue to its organ of origin. The next type of case I would say is the most common miss that I see in cases that come through our second opinion service. So when you look at this case here, you see this dilated pancreatic duct that has an abrupt duct cutoff at the pancreatic neck. When you look at the rest of the head neck region, it looks a little bit bulbous, but you don't really see a discrete hypoenhancing mass. And again, showing on more 3D reconstructions, again, you see this dilated pancreatic duct, and they even have an MRCP that shows dilated pancreatic duct with abrupt duct cutoff. I've seen many cases where this was dismissed as pancreatitis, but this is really a warning sign that you have to worry that there is a small mass there that's causing obstruction. This is a companion case that on the outside MRI it was called pancreatitis. Similar to the case that I have already shown you, again you see this mildly dilated pancreatic duct with abrupt duct cutoff. And when they got a follow-up CT a little bit later, now you see a much more discrete hypoenhancing mass that's a cause of obstruction. So up to almost 20% of PDACs demonstrate isoenhancement relative to the background pancreatic parenchyma. And isoenhancement is more commonly seen with smaller tumors. And in these cases, you really need to rely on secondary signs of pancreatic duct or common bile duct obstruction. If you see an abrupt caliber change of pancreatic duct with atrophy, you need to call it a pancreatic mass until proven otherwise. And sometimes cases get even more tricky, such as the case here. When you first look, you may not even appreciate much, but when you look very closely, you notice that's a normal fatty marbling pattern of the pancreas, and that fat marbling is lost within the pancreatic head, and you have this more homogeneously enhancing soft tissue in the head. This was not recognized on the outside CT, and the patient had persistent symptoms, and they proceeded to MRI, in which you see a subtly hypoenhancing mass within the head, and this was pathologically proven PDAC. Another companion case, a similar case, in which at first glance, again, you don't really see much of anything. But then if you look closely, you recognize that's a normal fat marbling of the pancreatic head in the body. But in this neck region, that appears more solid looking and you don't have the fat marbling. And the Whipple resection showed a 1.5 centimeter acinar cell carcinoma. Similar case here, subtle, very subtle hypoenhancement in the neck. And then, but one way to bring out that kind of abnormal textural change would be with cinematic rendering, in which when I show you the cinematic rendered image, you can appreciate a little bit better that subtle textural change at the neck. And here just laying it out on the coronal view. So in these iso-enhancing tumors, the subtle textural change and loss of normal fatty lobulation are the most important clues in detection of these iso-enhancing masses. And 3D reconstructions and cinematic rendering may accentuate these focal textural changes. MR and PET-CT may be helpful in detection of these tumors. MR have a sensitivity of about 79% and PET-CT about 74%. Another type of tricky case would be the presence of very subtle pancreatic duct irregularity. So when you look at this case here on the axial images, you appreciate a mildly dilated pancreatic duct. And when you put the images on an oblique sagittal, you appreciate that there's this dilated pancreatic duct, and there's a luminal filling defect that's within the pancreatic duct. And the patient went on to a Whipple, and it showed a 7 millimeter PDAC. So any dilated pancreatic duct needs to be carefully evaluated for any subtle pancreatic duct irregularity or obstructive lesion. And these subtle pancreatic duct lesions may be best shown on oblique coronal on sagittal MPR. And finally, in terms of tricky cases, sometimes even when the tumor is really large, it could be tricky, such as the case here. You see this diffusely abnormal enhancement of the pancreas and very heterogeneous and almost mask-like enlargement. So you may be thinking, could this be a cancer? Could this be pancreatitis? And that was a differential they gave on the outside, either an inflammatory process or neoplasm. And biopsy showed PDAC. But when you look at this mass a little bit more closely, you don't see a whole lot of peripancreatic soft tissue stranding or fluid like you would expect to see with pancreatitis. And it's also more mass effect, more vascular encasement and narrowing than you would typically see with pancreatitis. So that may be a clue that this is PDAC rather than pancreatitis. So diffuse tumor infiltration may mimic an inflammatory process, and the diagnosis can be confirmed by clinical history, lab values, and or tissue sampling. Pancreatic lymphoma can have a similar appearance, but it is less likely to cause significant pancreatic duct and common bile duct dilatation compared to PDAC. And then we're going to pause here for a little bit and go get some coffee, and then we'll come back and look at the other cases.
If you liked what you heard here today, please make sure to hit that subscribe button and visit our website ctassist.com for lectures, quizzes, pearls, and more. Also, be sure to check out our apps that are available for free on the Apple Store. All links are in the description box below.
Welcome back. So we're going to continue our discussion on pancreatic cancer, pearls, and pitfalls. So in the previous segment, we've already gone over some technical challenges and some challenging cases. And another reason why the diagnosis can be tricky is due to the presence of coexisting pathology. And we're going to show you some of those examples. So this is a case of a patient with underlying chronic pancreatitis. So when you look at the pancreas, it's very heterogeneous. You've got a very dilated pancreatic duct, you got parenchymal calcifications, and even the parenchyma is heterogeneous. And it would be very difficult to identify the presence of a superimposed cancer. This patient went on to have MRI as well, in which you see similar findings of a very dilated pancreatic duct with dilated side branches. On the MRI, we did notice that there was a very subtly hypoenhancing lesion in the head with corresponding restricted diffusion, and we said that was suspicious and recommended EUS, and it was a pathologically confirmed PDAC. On a companion case, it's another patient with history of chronic pancreatitis with recurrent pseudocyst, and again, you see there are a lot of cystic lesions everywhere, very heterogeneous appearance of the head, and frankly, because the patient was only 29 years old, we weren't even thinking about cancer on the differential. This was until when the patient developed these ill-defined hypodense lesions in the liver, we thought those were abscesses. And when we went on to biopsy these lesions, they turned out to be metastatic PDAC. Pancreatic ductal dilatation and parenchymal heterogeneity in chronic pancreatitis can render superimposed PDAC very difficult to detect. Chronic pancreatitis is associated with about 8-fold increased risk of PDAC within 5 years. And MRI may help in differentiation of PDAC from mass-forming pancreatitis. I think the important thing in these cases is your follow-up or prior exams are really going to be a great help. Any morphologic changes over serial exams may prompt further evaluation with EUS and or biopsy. Another reason why cases can be tricky is that, such as the case here, that you see there's a cystic mass, there's a dilated pancreatic duct, and it was just read as IPMN. And we all know that we see these IPMNs, they are like a dime a dozen, we see them daily. But so when we just dismiss them as IPMN and without raising any red flags, patient may get lost to follow-up and not get worked up for this. And when we look at the CT, we can appreciate that this is not just a cystic mass, that there's a heterogeneously enhancing solid component to it. And this is a solid and cystic pancreatic cancer arising from an IPMN. So the solid component of an IPMN and superimposed PDAC can be very difficult to detect on non-contrast enhanced MR exam. At our institution, MRCP is routinely performed with IV contrast to facilitate detection of the solid component or asynchronous PDAC. The presence of enhancing solid components is a high-risk stigma for an IPMN and should prompt further evaluation with EUS and or biopsy. And there can be also cognitive errors that make it challenging to detect PDAC, such as the case here. So in this case, we see that there's a very well-defined lobulated cystic mass within the tail, presumed to represent an IPMN. But the reader of this case also noticed that there's this subtly dilated pancreatic duct, and there's some focal textural change within the proximal body. And we appropriately recommended this case to EUS more for further evaluation of this lesion. The EUS was just read as side branch IPMN. They didn't see anything suspicious. The patient came back 6 months later, and unfortunately for the patient, now there's a much more obvious hypoenhancing lesion in the proximal pancreatic body. The pancreatic duct dilatation is more obvious, and now patient also has developed liver metastases. In another case, in which this patient has history of multifocal IPMNs, in which you see these cystic lesions studded all throughout the pancreas, so that you don't even have any normal pancreas to compare to. But if you look more closely, this part of the pancreas just kind of looks different from the rest. It's a little bit more solid and heterogeneously enhancing. And patient went to surgery, and it is a path-proven PDAC within the head. So just to keep in mind that IPMNs and other cystic lesions are easy to detect due to a relatively large difference in signal intensities compared to the background pancreas. The radiologist can be distracted by these cystic lesions and fail to detect the relatively subtle synchronous PDAC, and just beware of satisfaction of search, because it's very tempting when these IPMN or pancreatic cyst follow-up cases come through. You just kind of quickly look at the cyst and say they're stable cyst, and then good luck and come back in a year. But be very careful and closely scrutinize the entire pancreas for any subtle lesion, because these patients are coming for follow-up not so much for fear of malignant transformation of the cyst themselves, but because it's a field effect that the whole pancreas of these patients are at increased risk of developing cancer, and we need to look at the whole pancreas very carefully. Another reason why these cases are challenging is that a lot of them present as incidental findings, such as the patient here. She came in for a renal protocol CT for evaluation of hematuria, and when you look at the pancreas, you see there's this hypoenhancing mass within the tail with a cystic component, and when they did a biopsy, it was an IPMN with at least high-grade dysplasia. And sometimes we didn't do so well, such as this patient here who came in for PE protocol chest CT. The chest was fine, but then what we didn't recognize was that in the most bottom slices, there's a hypoenhancing mass within the pancreatic body. This was not called, and then unfortunately 3 years later, when we see the patient back again, they have developed metastatic pancreatic neuroendocrine tumor with liver metastases. So pancreatic pathology may be present on exams obtained for other clinical indications. And this can be a diagnostic challenge due to suboptimal protocol or edge of film effect, such as the PE chest case. Systematic evaluation of all the organs within the field of view is essential to avoid a miss. In this last section, I will show you some examples of mimickers of PDAC. So the first mimicker that we frequently see is focal fatty infiltration. So when you look at the case here, there's this subtle textural change within the pancreatic head that's a little bit hypoenhancing. But when we look at it, I don't have all the slices to show you, but there's no pancreatic duct dilatation and no common bile duct dilatation. So that in the absence of mass effect, we would think about focal fatty infiltration as one of the possibilities. And we can confirm that on MRI, in which we have the in-phase MRI. We see this T1 hyperintense signal. And on the out-of-phase MRI, we see signal loss on the anterior part of the pancreatic head, consistent with focal fatty infiltration. So focal fatty infiltration is most prominent in the anterior aspect of the pancreatic head. And with focal fat, we do not expect to see any mass effect on the CPD or the pancreatic duct. And characteristic fat signal on MRI can confirm the diagnosis. Another mimicker is the intrapancreatic accessory spleen. And when we look at the pancreas here, we have the normal body and tail, but there's this structure here that's a little bit lobulated and kind of jutting out from the pancreatic tail. When we compare the arterial and the venous phase images, this lesion shows very similar enhancement pattern relative to the spleen. So the differentials you would be considering would be a PNET versus an intrapancreatic accessory spleen. So an intrapancreatic accessory spleen should mirror splenic signal on all sequences. It is usually located at the tip or along the dorsal surface of the pancreatic tail. The differential diagnosis would be a pancreatic neuroendocrine tumor or hypervascular metastases such as those arising from renal cell carcinoma. When in doubt, we can always get a technetium-99m heat-damaged red blood cell scan for further confirmation. Previously, I've shown you many cases in which pancreatic cancer were falsely dismissed as pancreatitis, but we also have the other way around. Sometimes pancreatitis can appear very mass-like and mimic the appearance of a pancreatic tumor. In this patient here, we see this very infiltrative soft tissue that's within the peripancreatic soft tissues and spreading along the path of the central mesenteric vessels. Very solid mass-like, and I would say not a whole lot of peripancreatic fluid or stranding. So we read it as highly suspicious for malignancy. They did biopsies and there was no malignancy. And in fact, on a CT follow-up 2 years later, a lot of these changes have resolved. So this was a case of acute pancreatitis that had a very mass-like appearance. And in here, again, chronic pancreatitis, because of the diffuse parenchymal heterogeneity, it can also mimic a mass. This one, you can see diffuse heterogeneity of the pancreas. You have dilated pancreatic duct. I would say what helps you with this case is you have the diffuse parenchymal calcifications. That's in a very classic pattern for chronic pancreatitis. Inflammatory soft tissue infiltration and parenchymal heterogeneity in the setting of pancreatitis can mimic PDAC. And the risk of PDAC is about 10 times higher in patients with a primary episode of acute pancreatitis, especially in patients who develop chronic pancreatitis. And keep in mind that acute pancreatitis can be the first presentation of an underlying PDAC. So even if there is truly acute pancreatitis by both imaging and lab values, look very carefully at the underlying pancreas to make sure there's no small mass that may be the cause of the pancreatitis. And clinical and imaging follow-up are important to exclude an underlying mass. The final mimicker I will show you is autoimmune pancreatitis. So this is a very classic example of autoimmune pancreatitis in which you have this diffuse sausage-like enlargement of the pancreatic body and tail and the characteristic hypoenhancing halo on the periphery. So this is a slam dunk diagnosis for autoimmune pancreatitis. But sometimes autoimmune pancreatitis can be a little trickier. In this case, you have a segmental version of autoimmune pancreatitis in which you have this hypoenhancement of mostly the body and tail with sparing of the most distal tail and sparing of the head. And you even have dilatation of the pancreatic duct, so this can certainly mimic the appearance of pancreatic cancer. Diffuse sausage-like enlargement and hypodense halo are typical findings for autoimmune pancreatitis, but a minority of autoimmune pancreatitis can be focal or segmental and mimic PDAC. If you're contemplating AIP as a potential diagnosis, we can always suggest for them to draw a serum IgG4. Serum IgG4 antibodies are elevated in most patients, and if it is elevated, is very helpful in confirming the diagnosis of AIP. But keep in mind that in some cases of AIP, serum IgG4 can be normal. So a normal serum IgG4 by itself does not exclude AIP. And it's important to consider this diagnosis because most patients with AIP will show excellent response to steroids, and you have just saved patient an unnecessary surgery. In conclusion, CT and MRI are the most commonly used imaging modalities for initial evaluation of suspected pancreatic cancer. Optimal imaging technique is key to the detection of subtle cases, and detection of PDAC can be challenging due to intrinsic tumor features and presence of coexisting pathology. Coexistence of PDAC with other pancreatic pathology can distract the radiologist from the more subtle lesion. Normal structures and non-neoplastic diseases can also mimic the imaging appearance of PDAC, and recognition and mitigation of these technical and interpretation errors can lead to earlier PDAC diagnosis and improved patient prognosis. Thank you very much for watching. I'll see you next time.
If you liked what you heard here today, please make sure to hit that subscribe button and visit our website ctisus.com for lectures, quizzes, pearls, and more. Also, be sure to check out our apps that are available for free on the Apple Store. All links are in the description box below.
Hello everyone, my name is Anne Kennedy. I'm a radiologist working at the University of Utah in Salt Lake City in the USA. I actually do women's imaging as a career, but I am part of the abdominal imaging section, and one of my colleagues asked me to put together a talk on pancreas ultrasound for a session on abdominal imaging at the SRU meeting in Chicago this November 2011. So I did that, and I will admit that I am not a great advocate of pancreatic imaging, but I think, like everything with ultrasound, if you apply yourself, there are many things that you can see and do to assist in triage of patients. Okay, so we're going to talk about ultrasound of the pancreas. If you think about imaging the pancreas, in many cases ultrasound doesn't come to your mind as the first modality. Most people think about CT and MRI first, but many patients come into the healthcare system via the ultrasound department, either from the emergency room or for their family practice doc, with things like vague abdominal pain, maybe abnormal liver function tests. When you think about ultrasound, there's a couple of different ways of approaching the pancreas. The standard one that we as radiologists use is the transabdominal approach, but our GI partners use endoscopic ultrasound, our surgical colleagues use intraoperative ultrasound, and our more imaginative colleagues are actually figuring out ways where you can use fiber optic technology to use intraductal ultrasound, whereby you're actually scanning the pancreas from inside the main pancreatic duct. There are also techniques like elastography and contrast-enhanced ultrasound that are not necessarily widely available but have potential to help us with differential diagnoses. And these are just some pictures that I have downloaded from the internet. This is elastography, and it shows the difference between a malignant and a benign lesion. Malignant lesions are very densely fibrotic and tend to be hard, and so they come out looking blue on the elastography. More benign masses, such as focal inflammation, tend to be less fibrous, less serous, and come out in the shades of yellow and green. Similarly, contrast enhancement of ultrasound is widely available in Europe and Asia. It is not FDA approved in the USA, unfortunately, but this is an example showing a swollen edematous pancreatic body and tail. Following contrast administration, the body enhances here, but the tip of the tail does not. And this indicates pancreatic necrosis, which is a very important complication of acute pancreatitis. And the beauty of this is that this exam can be performed at the patient's bedside in ICU. No need to transfer very sick ventilated patients down to the CT scanner. The other thing that we often do in the ultrasound department is do image-guided biopsies. And you can certainly use CT, but ultrasound allows you real-time visualization to look at your needle position at all times. We can do transabdominal ultrasound-guided biopsy. Similarly, our GI colleagues can do endoscopic biopsy, and this is an example of this with a lesion coming through the stomach wall into a pancreatic mass and the needle clearly in the lesion there. Our surgical partners use intraoperative ultrasound to localize masses. This is actually in the liver, but they can do the same in the pancreas, either to perform a biopsy for frozen section or to help them create their surgical planes for excision of a mass. As a prenatal imager, everything that I do revolves around embryology and anatomy, and the pancreas arises from two buds, a dorsal and a ventral. One arises near the stomach and the ventral arises near the liver. As the GI tube elongates and curves, these buds migrate and eventually fuse. The dorsal bud forms the pancreatic body and tail. The ventral bud forms part of the inferior portion of the head and the uncinate process. The normal arrangement is that the duct from the main body and tail unites with the duct from the ventral component to form the main pancreatic duct, and the distal portion of the dorsal duct atrophies or becomes the accessory duct of Santorini. If that doesn't happen, you have pancreas divisum, where the ventral portion drains into the major papilla, which is where most of the ducts should go, and the main portion of the pancreas actually drains to the minor papilla. This is not something that's easily seen on ultrasound, but it is an important developmental variant because it can predispose to acute pancreatitis. Other developmental variants to think about are migrational abnormalities, and you can have ectopic pancreas left where these little buds migrate down to their final location. Those are most common in the gastric mucosa or in Meckel's diverticulum. The annular pancreas occurs when the buds, instead of getting to one side of the duodenum and fusing, actually encircle the duodenum and obstruct it. And this is a radiograph of a fetus. Well, it was a fetus that I saw. This is the radiograph of the newborn infant. And you can see the double bubble sign with a dilated stomach, dilated duodenum. And we thought prenatally that this was not typical for a duodenal atresia, as might be seen in Down syndrome, because the degree of obstruction seemed to be too far into the second portion of the duodenum. And we actually raised the possibility of annular pancreas as part of the diagnosis. And the baby was delivered, had a nasogastric tube placed correctly, and was taken to the local pediatric hospital, which is across a walkway from our institution, and had surgery confirming an annular pancreas. There are many contour abnormalities that happen if the buds fuse in an unusual manner, and this is just an example from the literature showing the bifid pancreatic tail that you may see if the buds don't unite in the conventional manner. Anatomy is everything in terms of imaging diagnosis. If you don't understand your normal anatomy, you can't pick out pathology. So the pancreas is a retroperitoneal organ. It lives in the anterior pararenal space. It's deep to the stomach, the colon, the greater omentum, and the left lobe of the liver. The splenic vein is a structure that marks the dorsal or posterior border of the body and tail. The neck is marked by the confluence of the SMV and splenic vein to form the portal vein. The only parts of the pancreas that are actually behind vessels are the head and uncinate process, which wrap around the venous confluence, so that you actually have pancreatic tissue posterior to the SMV and SMA. The head itself is nestled into the curve of the duodenal loop, and the splenic tail, or the tail of the pancreas, goes up to the splenic hilum. And of course, although it's not in this image, the splenic flexure of the colon sits up here as well. The celiac axis marks the upper border of the pancreas, and the SMA travels behind the body of the pancreas, in between the body and the uncinate process. Here's an example of a CT scan with contrast. This is cropped down to show pancreatic anatomy, and I've put it side by side with the transverse ultrasound obtained in the epigastrium. And you can see that all of the anatomy that's displayed on the CT scan is also displayed on the ultrasound. This is the spine, as shown here. This is the right kidney. Here's the right kidney on ultrasound. Inferior vena cava and aorta, IVC and aorta on CT. Here is the pancreas running just superficial to or anterior to the splenic vein, body and tail of pancreas, and here's the portal vein confluence with the pancreatic head, the edge of which is slightly obscured by bile gas in the duodenum, and this is the bile gas in the duodenum on CT. If you think about the anatomy of the pancreas, the gland should be homogeneous in echogenicity and should resemble something like fine sandpaper. Overall, generally the echogenicity increases with age, and part of this is due to fat deposition or fibrosis, and it's usually more echogenic than the adjacent liver but might be isoechoic to it. Depending on what textbooks you read, the size of the pancreas is highly variable. In general, the head is slightly thicker than the body, which is slightly thicker than the tail, and equally the duct should be at maximum size in the head, slightly less in the body, and either invisible or very small in the tail. If all pancreases read the textbooks, they would all be shaped like a tadpole, like this pancreas, but they don't all, and they can come in dumbbell configurations or just unusual lumpy bumpy configurations. Equally, if you look in sagittal section, you can use the left lobe of the liver as an acoustic window, and here you see the aorta, the SMA, and the SMV. This is part of the pancreatic head seen in sagittal section, and some of the tissue wraps around in between the SMA, SMV, and the aorta to give you an echogenic focus here. Your technique transabdominally, it is vital that the patient be fasted. Everyone knows in the ultrasound world that bowel gas is the enemy. So you like to have your patients fasted, preferably overnight. You can use a variety of different transducers and a variety of different scan planes. And if you're unsuccessful with the patient just fasted, you can try a water bolus in the stomach as an acoustic window, And in countries where ultrasound contrast is available, you can give that. And that may be vitally important in differentiating between a hypovascular carcinoma and a hypervascular inflammatory mass. Also, surgeons do pancreatic transplants nowadays in the diabetic population. If you're going to evaluate a pancreatic transplant on ultrasound, it is vital that you know the surgical anatomy. You need to know where the surgeon placed the organ and what kind of anastomosis they made. There are two types. There's one that's called the systemic bladder type, in which the pancreatic venous drainage, which is via the splenic vein, is connected to this donor's iliac vein, and the exocrine function is directly attached to the bladder. This is technically easier for the surgeon, but is not physiologically very correct. The technically harder process is whereby the splenic vein drain from the transplant is connected to the recipient SMV, so it goes into the portal system as it does in the normal arrangement, and the pancreatic head exocrine function is connected to the recipient's GI tract, so that again the exocrine secretions go into the normal route rather than going into the bladder and being reabsorbed. Transducer selection. The curved 6 megahertz transducer is your workhorse in abdominal imaging, and as you can see in this picture, you can actually lay out the entire length of the pancreas with good transducer pressure. This is the spine, the aorta, this is the splenic vein coming along here. This is part of the SMA, and the SMV is actually obliterated by transducer pressure here. This is part of the splenic flexure of the colon, but it's been compressed so the air is not shadowing out the pancreatic tail. If you have a very slim patient, you can even bring out the linear transducers, and here you can see with a 9 megahertz linear transducer that you appreciate the marbleization of the normal pancreatic contour. What scan planes do we use? We start transverse in the epigastrium, and in that view you should see the neck, the body, and part of the head. Remember that the medial portion of the head is going to be partly obscured by gas in the duodenum. If you turn sagittal in the epigastrium, you can see the head and you can see the uncinate process tuck in behind the SMA and the SMV. An oblique left subcostal view will allow you to follow the tail out to the splenic hilum, and an oblique right subcostal view is essential to look at the gallbladder and biliary tree, because many processes that affect the gallbladder also affect the pancreas, such as stones, and if you have a pancreatic mass, you may inhibit biliary drainage. If you have limited views with the patient sitting or lying down fasted, you can then have the patient sit up. This shifts the diaphragm down somewhat and may reorient bowel gas and give you a better window. And you could also try the water bolus technique, in which you have the patient sip about 500 mils of still water, wait for approximately 10 minutes for any bubbles to settle, and then use the water-filled stomach as an acoustic window to the pancreas. After you have looked at the body and tail of the pancreas, you turn the patient right lateral decubitus, and the water will run into the duodenal loop, which then acts as an acoustic window to the pancreatic head. Here's some normal anatomy, transverse in the epigastrium, left lobe of liver. This is the body of the pancreas. This is going down into the head. This is the pancreatic duct, well seen where the beam is perpendicular. This is the pancreatic tail extending up into the left upper quadrant. Left renal vein is compressed between the aorta and the SMA as we apply transducer pressure to clear out all this anatomy. And here's the inferior vena cava and the spine. In the epigastrium, you turn longitudinal. Here's the liver. Patient's head is now at this end of the picture. Here's the transverse colon. The SMV is nicely elongated. Here's the aorta. You see the gastroduodenal artery and the common bile duct both in the pancreatic head, with that little lip of tissue from the uncinate process tucking in behind the vessels. Similarly here we have the SMA elongated in front of the aorta. The SMV is not so well seen in this image. This is pancreatic tissue. This is pancreatic tissue. Oblique left subcostal, as I showed you before, you can lay out the pancreatic tail very nicely. And oblique right subcostal, here is your common bile duct, paralleling the portal vein, gallbladder, no evidence of stones or biliary dilatation. Endoscopic ultrasound is in my institution performed by my GI colleagues. This is an example of the transducer within the stomach, and this shows this obvious inhomogeneous mass which is accessible to FNA. This is another example where you can see the dilated common bile duct and the dilated main pancreatic duct coming down to a mass in the head of the pancreas. And this, again, is a typical appearance for an adenocarcinoma of the pancreas, causing biliary and pancreatic ductal dilatation. And you can see how easy it would be to get a needle in here for an endoscopic biopsy. So when you think about what you can see in terms of pathology in the pancreas, after anatomic variants, you essentially have pathologies that are either inflammatory or neoplastic. And of course, we have to think about the pancreatic transplant population in whom we are looking for complications of transplant. This is utilizing the extended field of view or CSCAPE, and this is a newly placed pancreatic transplant. This is the associated renal transplant over here. There is echogenic fluid around the transplant, but the patient did very well initially, and I'll show you later pictures of his when we performed a biopsy to look for rejection. The different types of pancreatitis are listed here, and we'll discuss some of those in more detail, and we'll also review some of the findings of the various types of neoplasia. So in acute pancreatitis, we've all seen as radiologists the patient come in from the emergency room with right upper quadrant pain. You see some gallstones, the patient has an elevated amylase, and they go on to CT and have really quite marked inflammatory changes that were not that obvious on ultrasound. The findings can be extremely subtle, and the key to make the diagnosis is to actually look for ancillary signs of inflammation. So this is a patient with acute pancreatitis, and the pancreatic head, although the echogenicity is normal, it is slightly thickened. And if you look over here, there's fluid around the right kidney. There's quite marked gallbladder wall thickening. There were no gallstones and no sonographic Murphy's sign. Here's a list of all the features that you can look for signs of inflammation based on a study which was published in the Ultrasound Quarterly in 2005. This is a left pleural effusion and this is a right pleural effusion. And I'm going to show you more images of that same patient that I showed you earlier now to prove that you really can do this. Here's your mildly edematous, slightly thickened pancreatic head. Here is the pericholecystic edema and gallbladder wall thickening. I showed you fluid around the right kidney earlier. Here is fluid around the left kidney. And here again, right pleural effusion with atelectasis in the right lower lobe, left pleural effusion adjacent to the spleen. So all of these are indications of a diffuse inflammatory process in the abdomen. Complications of acute pancreatitis include necrosis, abscess, vascular complications. Later on, you may form a pseudocyst or develop chronic pancreatitis. And this is an example of chronic pancreatitis. This is the splenic vein which marks the dorsal border of the pancreas. So this is the dilated pancreatic duct which contains calculi. And these are the same calculi showing twinkle artifact on color Doppler. Pancreatic pseudocysts are commonest in the body of the tail, and you can see this nicely demonstrated in this graphic. They may be very circumscribed and smooth-walled, but they can, of course, be multilocular, and they contain internal echoes sometimes, particularly in the acute situation where they may be complicated by hemorrhage or infection. The utility of ultrasound in this circumstance is to be able to guide a needle into that fluid collection, because a pancreatic abscess is a surgical emergency, whereas isolated hemorrhage into a pseudocyst does not require a surgical procedure. And if pseudocysts become big enough, they can cause duct obstruction, which then increases the likelihood of more episodes of pancreatitis. Chronic pancreatitis eventually causes atrophy of the gland. The ducts will dilate, and that is a very common finding. And in fact, if you see calcifications within a dilated duct, it is virtually diagnostic of chronic pancreatitis. One thing to remember is that chronic pancreatitis does not have to involve the whole gland. It can actually be focal. And if so, it can be very difficult to differentiate focal pancreatitis from a focal mass such as pancreatic cancer. Elastography and contrast enhancement may help us with that, but oftentimes it comes down to needing a biopsy. Groove pancreatitis is a variant of pancreatitis that is relatively recently described, and it focally involves part of the pancreatic head tucked into the curve of the duodenal loop and is associated with cystic abnormalities in the duodenal wall. And this was a patient that came from the emergency room with right upper quadrant pain, looked for gallstones. One of my previous fellows noticed the irregularity of the pancreatic head and suggested groove pancreatitis, which was confirmed on this CT. This is an important diagnosis to be aware of because these are frequently misdiagnosed as pancreatic carcinomas. And given the location on the pancreatic head, these patients may be set up for Whipple's surgery. And that is a huge operation that is not necessary for a benign process. So be aware of groove pancreatitis. There's another condition called autoimmune pancreatitis, which is also relatively new in terms of ultrasound features. And what you see with autoimmune pancreatitis is diffuse thickening of the pancreas with ill-defined anterior margins, and you cannot identify the pancreatic duct anywhere within this mass of pancreatic tissue. It's a systemic disease caused by deposition of IgG4 antibodies and is associated with biliary changes, so very often you will see biliary dilatation in association with this thick, inhomogeneous pancreas. In fact, if you look at the biliary system carefully in patients, there's a characteristic appearance called the trilaminar appearance, and you will see this striped appearance to the dilated common bile duct wall or to the gallbladder wall. And if you see this in association with the thick, ugly, edematous-looking pancreas like this, you can suggest the diagnosis of autoimmune pancreatitis, which can be verified with a simple blood test. Pancreatic masses. Primarily, you're worried about pancreatic neoplasms. There are many mimics, though, and this is where it becomes complicated because just the developmental abnormalities we spoke about, where the buds don't fuse in the conventional manner, if there's a pseudocyst that's complicated, if there's something in the duodenum, if there's a lipoma, if there's either focal fatty replacement of the pancreas or focal fatty sparing, you can appear to have a mass, and focal inflammation, focal pancreatitis, as opposed to diffuse. Different type of neoplasms are mentioned here, and intraductal papillary mucinous neoplasia is also an issue because you may just see a dilated pancreatic duct on ultrasound, and these are low-grade malignancies with the potential to develop an adenocarcinoma over time. Pancreatic cancer is an unfortunate cancer. It tends to be quite advanced at the time of diagnosis, so that 90% of patients are unresectable. The long-term survival is very poor, and many patients already have vascular encasement and lymphadenopathy and metastases at the time they present. Here's an example. A lady came in, she had been traveling on a cruise ship earlier in the year and had developed diarrhea, as had many of the passengers, but her diarrhea did not settle and she had precipitous weight loss. As part of her workup in the infectious diseases lab, she had liver function tests obtained which were abnormal, and she was sent for an ultrasound to evaluate primarily the gallbladder and liver. What we saw was this irregular, inhomogeneous mass with chunks of calcification that was occupying most of the pancreatic head, abutting the portal vein. And here's part of the pancreatic tail with what appears to be a normal duct, but over here you have this hypoechoic area that is different to the texture of the rest of the pancreas. We were very concerned for the possibility of a pancreatic carcinoma here. We looked around. This again is the mass in the pancreatic head. The common bile duct was not dilated because remember, this lady presented with abnormal liver function tests. She had some cystic masses in the abdomen, but she also had masses that had papillary excrescences. One of these was biopsied and it confirmed pancreatic adenocarcinoma as a primary. Here's the CT scan that shows this mass in the pancreatic head actually encircling the portal vein confluence. And here along the pancreatic tail, you see the reason for that hypoechoic area. This, in fact, was an IPMN with subsequent development of an adenocarcinoma in the head. And here are correlative images from the MR and the PET-CT. Serous cyst adenomas are benign. They often present as a highly echogenic mass because there are multiple tiny cystic spaces which create multiple interfaces and look rather like the appearance we see in autosomal recessive polycystic kidneys in the fetus, where you don't resolve the cysts, you simply see the echogenicity from the interfaces. Mucinous cyst adenoma, on the other hand, has larger spaces and interstices, and here is an example of this, where you have this fairly benign-looking cystic lesion in the pancreatic tail. This is the splenic vein marking the dorsum of the pancreas, so this is pancreatic body and tail. And you note the small papillary excrescence in this mass, which turned out to be a mucinous cyst adenoma. Although these are malignant, they're generally low grade and they don't have as bad a prognosis as the conventional ductal adenocarcinoma. Islet cell tumors are either functional or non-functional. The functional ones, like insulinoma, present early because of their hormonal production, but they are small and hypervascular and can be very hard to see. Obviously, endoscopic ultrasound and contrast-enhanced ultrasound will be beneficial in looking for small lesions like this. The larger tumours are often necrotic with metastasis by the time they present, and they are easier to find. Other masses that affect the pancreas, metastatic disease is always a consideration. And I had never seen a pancreatic metastasis until just recently. And of all things, this mass in the tail of the pancreas here is a metastatic deposit from a carcinoid tumor of the cervix in a 26-year-old woman. So nothing is impossible. Lymphoma is the great pretender. Lymphoma can do anything, anywhere. It can cause diffuse peripancreatic infiltration, well, so can acute pancreatitis. But you look for lymph nodes in the region, you look for systemic symptoms, and you check the laboratory findings. Focal or groove pancreatitis, remember we mentioned, is always localized in the pancreatic head adjacent to the duodenum, not to be mistaken for an adenocarcinoma, so that you can protect a patient from having an unnecessary pancreatic resection. This is an example of focal fatty sparing. This is a diffusely fat-replaced pancreas, and so the area that was relatively normal in echogenicity stood out from the background and looked like a mass. In the converse to this, you can get focal fat deposition in an otherwise normal echogenicity pancreas, and many of these things will need a biopsy to definitively exclude malignancy. Pitfalls in pancreatic ultrasound include body habitus, bowel gas, and the examiner's unwillingness to try. With endoscopic ultrasound, it's hard to be clear reading the literature because different descriptors are used, and there's a big move to standardize nomenclature in the literature so that different users can get together and pool their data. And even with intraoperative ultrasound, the surgeons may experience trouble by using too much manual pressure occluding vessels and by having near-field reverberation. This is an example where we thought, oh, there's a mass in the pancreatic body and tail here. Look at this hypoechoic thing. It persists. It's hypovascular. This must be a pancreatic cancer. Doesn't look like it's invading any vessels. This is potentially a great save. But when the lady went on to CT, this is a completely normal pancreas. And this is an example of the dumbbell configuration of the pancreas with a much thicker pancreatic tail than one normally expects to see. For the last few minutes of the talk, we're going to talk briefly about pancreatic transplant evaluation. This is just to remind you of the two different surgical techniques and that you need to meet with your surgeon prior to performing the ultrasound so you know where the pancreas is in the patient's abdomen. You're looking for things like rejection, fluid collections, focal pancreatitis, leaks of fluid, and vascular problems. Here is an immediate post-operative study. There's some free fluid in the abdomen, which is not unusual post-op. Here are the iliac vessels, and you know that the vessels are going to be anastomosed to the iliac vessel in this type of pancreatic transplant. And here these parallel lines are actually the pancreatic duct in the transplanted pancreas. Here's another example where this is the pancreatic transplant, and even with the use of power Doppler, we were unable to demonstrate much in the way of any flow, and spectral Doppler was very abnormal, and this was a pancreatic transplant with vascular thrombosis of the veins. Here's another pancreatic transplant, very conventional looking pancreatic head in the right lower quadrant. Single vessel seen nicely on color Doppler. Spectral Doppler shows very, very abnormal waveform with reversed end diastolic flow. And again, this was a venous thrombosis of a pancreatic transplant. Lastly, this is the chap that I showed you up back at the beginning who had a pancreatic transplant surrounded by lots of echogenic fluid. He did well, went home, and he was back for a biopsy to look for rejection. This is the pancreatic head right beside the transplant kidney in the right lower quadrant. And as you can see, there are many small arterial branches all around this pancreatic head. That's the portal vein of the donor into the recipient's iliac vein. So a highly vascular structure. With ultrasound, we were able to line up with the short throw of the biopsy needle, look with color Doppler prior to taking the specimen, and see that each biopsy went through an area of the pancreas that would avoid those big surrounding vessels. So, in conclusion, I want to say, when you think about pancreas ultrasound, don't go, oh no! It is a retroperitoneal organ. It is often hidden behind fat and bowel, but with appropriate transducer selection and appropriate technique, you can see a lot of pathology and make a lot of diagnoses. Thank you.
What I would like to do during the next 30 minutes is the following. I'd like to review our pancreatic protocols at about a 10,000 foot view for both multi-detector CT and for MRI. I'd like to evaluate the use of CTA and MRA in the analysis of major peripancreatic arteries and veins, particularly as they relate to detection of resectability for pancreatic neoplasms, and finally talk about MRCP and CTCP in the evaluation of the pancreatic ducts. So we'll begin with MR, and this is more or less the menu of MR sequences which a patient who is referred for pancreatic imaging would undergo at our institution. We've added some, we've subtracted some of these have been tweaked, and during the workshops you can get the specifics of the pulse sequences that are involved. But suffice it to say, after the scout we get fat-suppressed stir sequence, which gives us T2 weighted information making pathology bright. We get axial and coronal haste images, which is also T2 type information, predominantly used for evaluation of the pancreatic and biliary ducts and to get an MRCP evaluation. We use an in and out of phase T1 weighted gradient recalled echo sequence, which gives us T1 information pre-contrast and also is useful for looking at pancreatic signal. We do a 3D MRCP, and I'll introduce that a little bit during the lecture, and Liz Hecht is going to give a workshop in this area. And finally, we use our contrast-enhanced gadolinium vibe sequences. So just to kind of show you what these images look like, here you see on a T2 weighted stir image the pancreas is relatively dark. Any kind of pathologic process, metastasis, et cetera, will generally stand out as bright signal. We supplement that with haste sequences, which are also T2, as you can tell by the CSF. You can see a nice depiction of a normal common duct in this particular individual. I'm not sure you can see the pancreatic duct here, but you get good anatomy with excellent contrast resolution in this particular sequence. The in and opposed phase non-contrast T1s help us evaluate the signal in the pancreas. On a opposed phase T1 weighted non-contrast image, the pancreas should have the brightest signal in the body. So here you can see a nice bright pancreas despite this extensive acute pancreatitis. Notice that you don't get that signal on the in-phase T1 examination, and this combination and analysis of signal is helpful. And then our major sequence is a fat-suppressed 3D T1 weighted gadolinium enhanced vibe, where we can create isotropic voxels, both non-contrast arterial phase and in the portal venous phase, with similar kinetics to contrast enhanced CT scan and the same types of contrast parameters for looking at different tissues. Now, in terms of CT, we utilize a biphasic acquisition, examining the pancreas during the parenchymal phase and in the portal venous phase, because we have several purposes, both on MR and CT, for evaluating these patients. This is a paper that was published in 2001 on a 4-slice scanner, but conceptually I still think it really highlights the rationale behind that biphasic acquisition. And so here you can see, just looking at the enhancement of the pancreas during a very early arterial phase, a parenchymal phase at 40 seconds, and a portal venous phase. Notice that the enhancement of the gland is highest at 40 seconds. You get excellent visualization of the arteries, somewhat less visualization of the veins, but it's still pretty good and obviously better than the arterial phase. If you combine that with a portal phase to look for liver metastases, you have a highly sensitive acquisition protocol. So what we do, and the way we translate that onto our machine for a 16 slice, we'll use a 40 to 50 second delay in phase 1, giving contrast at 3 to 4 ml per second. We create 3 millimeter slices out of that, which go to packs, and we'll scan from the diaphragm to the crests. Our phase 2 acquisition for the portal venous phase, 80 to 90 seconds, again thin sections. 4 millimeter sections are created here, and we'll scan the entire abdomen and pelvis. And for a 64 slice scanner, basically we just kind of delay the timing of the acquisition. We still use our narrowest collimator or detector configuration to create 3 and 4 millimeter slices at a similar time point for the portal venous phase, a little bit later because we're just scanning that much faster for the pancreatic phase. Now, notice these things in gold here mean that we send these acquisitions to a workstation, and these thin sections we use for our 3D planning and analysis, and we think that they're useful. We create selective images out of these data sets, send those to PACS as well, but we do not archive the thin sections. Okay, so just some basics here. During the pancreatic phase, you can see contrast in the corticomedullary phase in the kidneys. This is about 40 seconds. Pancreas is measuring here 157 Hounsfield units. During this parenchymal phase, good visualization of peripancreatic vessels. And then a little bit later, during the portal venous phase of acquisition, where you have nice smooth nephrographic phase, notice that the pancreas de-enhances down to about 113 Hounsfield units. So maximal organ brightness is here during the pancreatic phase. Maximal background brightness for the liver is going to be at the portal venous phase, and therefore a dual acquisition. As I indicated to you with MR, with our timing of arterial and portal venous phase, we achieve the same ends. We use neutral contrast for our studies. People have used water. We use Volumen, which is an EZM product now. It gives you excellent distension of proximal small bowel. Here's a nice example where you can see this duplication cyst in the duodenum. This way you don't confuse this for a pancreatic mass. You can see the duodenal sweep. You can see the pancreatic duct. And we have a very elegant demonstration and accurate depiction of the pathology in the region. Okay, applying this now specifically to pancreatic neoplasms. Obviously, when we're sent a patient to rule out a pancreatic neoplasm, we'll apply this particular protocol. And what are we trying to do? We're trying to find the tumor, and we're trying to determine if the tumor is found, if in fact that tumor is resectable. Who do we apply this protocol to? My feeling is that a referring clinician is not going to hand a patient a slip and say, rule out pancreatic cancer, go get yourself a CT scan. So we try and kind of look through what the referring physician is trying to send us. So if I get a request that says severe epigastric pain with weight loss, elevated alkaline phosphatase, any of these types of buzz phrases around pancreatic cancer, I'll just apply this protocol to the given patient. And we end up doing probably about 5% of our scans on any given day get this pancreatic protocol, at least on CT. Okay, just a few words now about the dual acquisition. Here is a patient who had lung cancer. Now, the clinician specified in his request lung cancer, pancreatic protocol, and I had no idea why, but being a dutiful person who does what he's told, we did a pancreatic protocol. So here is a perfectly timed scan, which this patient would have had he had lung cancer. Notice the kidneys are in the homogeneous phase of enhancement. There's a hemangioma here within the liver. Pancreas looks uniform. But because we did this as a pancreatic protocol, and here you can see the pancreatic phase of enhancement, we were able to detect this infiltrating lesion in the tail of the pancreas, which would have been invisible had we just scanned this patient on a lung cancer protocol. Here's the PET scan on the same patient done before the CT, and you can see why he asked for a pancreatic protocol, because there is unexplained activity here in the left upper quadrant, which we could now ascribe to infiltration of the pancreas by metastatic cancer, which would have been invisible on a traditional protocol done for the indication of lung cancer. Here's another example of why we get a dual phase acquisition. Here's a patient with a very small infiltrating tumor in the head of the pancreas. There's no extension out into the peripancreatic regions. The veins are fine. Here's the same patient during the portal venous phase of enhancement. The head of the pancreas appears totally normal. Here you can see the tumor. Anybody can see generally these big tumors, but if we're going to have any impact on the survival of patients, it's these little guys that we have to really find. Now, just parenthetically, this patient is 18 months after his Whipple resection. He's back at work. He's one of our colleagues at NYU. He's actually gaining weight. And, you know, maybe he'll be one of those individuals who may be, albeit rare, but this is the kind of lesion that we really need to detect. The same can be said of MR. Here's a patient two different patients on MR. Again, in the arterial phase, the tumors appear as low signal. They infiltrate in the region of the head of the pancreas. These are non-mass forming. Here, in a different patient, again, you can see this very small tumor up in the head of the pancreas. Both of these patients underwent Whipple resections, and we can at least tell that these tumors were resectable. But again, excellent technique, proper timing of intravenous contrast during a pancreatic phase of enhancement is essential if we're going to maximally detect these small pancreatic neoplasms. So once we detect the pancreatic neoplasm, we have to determine whether or not that tumor is in fact resectable. And we do that at least by imaging, by looking at arterial encasement, venous collateral pathways, and for distant metastases. And let me take you through this now. We do this by the ability, because we're collecting images in a volume, we can create angiographic images, ductographic images in virtually any plane, which is going to enable us to extend our analysis with a high degree of accuracy. I only want to look at, for CTA and MRA, these two particular applications. We could talk about the utility of CTA and MRA in pancreatitis, but I just don't have the time. So what's the technique of performing pancreatic CTA or pancreatic MRA? It's very simple. There is no technique, right? The proper acquisition protocol, which you apply to a patient, will have all of the information embedded within the acquisition. It's just your role as an imager now and taking care of this patient to extract that data in a clinically meaningful way. We have our arterial phase, parenchymal phase acquisition, which gives us CTA, and it's very easy to do on the workstation. MRA we can get from our 3D gradient echoes, or we can do a flash 2D sequence to look at the vessels as well. But really, there's no special technique for acquiring angiographic images. And this is just some work that we've done here in CT from 16 slice technology. You can get beautiful renderings. Here you can see the gastroduodenal artery. You can see the pancreaticoduodenal arcades with their collateralization to the first branch of the superior mesenteric artery. Here you can see those arcades very nicely. You can see small vessels like the pancreatica magna coming off of the splenic artery, and really get very elegant angiographic displays on these patients. With MR, here you can get excellent MRAs. Here's a visualization of the hepatic artery, a gastroduodenal artery. Here you can see a small tumor in the head of the pancreas, and you can see that it's separate from the superior mesenteric vein. These two images also just another example of pancreatic MRA acquired from 3D gradient vibe images with excellent depiction of the arterial and the venous anatomy. Not a special sequence, not an added sequence. The information is there and it's extractable from the workstation. What do we use to diagnose encasement of the pancreas? We look to see the interface of the vessel with of the tumor with the surrounding vessel. And here you can see in the axial plane, here's the superior mesenteric artery. There is a cuff of tissue which is actually surrounding the superior mesenteric artery at this level. Small little tumor, but nevertheless you can see this cuff of tissue. Now it turns out in a couple of articles from back in the late 90s that people have determined that CTA, these angiographic displays, are actually better than the axial displays alone. And if you use a basic premise that 50% circumferential involvement will give you a sensitivity, this is single slice data and a specificity which is clinically acceptable. Okay. Some other examples. Here you can see long, smooth encasement of the superior mesenteric artery. Here you can see encasement of the splenic artery at this level, and we're beginning now to be able to use the diagnostic signs that we learned in catheter angiography, which teach us what vascular encasement looks like. Obviously now we can get it non-invasively. Here's a small tumor in the head of the pancreas, in the body of the pancreas. There's a little pancreatic duct dilatation upstream from it. Is it resectable? Is it not resectable? Same patient, same acquisition, just applying a MIP rendering. Now you can see that there's clearly encasement of the proximal hepatic artery at this level, which tells you that despite the fact that this is a small tumor, in fact, it's non-resectable. You might get that from this image, but I think it's more clearly displayed on the 3D. Here's another example, small tumor in the body of the pancreas, upstream dilatation of the pancreatic duct. Here's the 3D image on that patient, and you can see encasement, again, of the proximal hepatic artery. This finding in and of itself, high degree of accuracy to say that this tumor, despite its small size, non-mass forming morphology, is in fact unresectable, which unfortunately this turned out to be. So this is let's play this as a case. This was a case that came to the department. It's a 54-year-old with a history of polycythemia vera. She has a big spleen. She has abdominal pain. She's got a finding in the tail of the pancreas. And here's the CT angio from this patient. So I'm going to just ask you, what's the diagnosis? How many think this is going to be a pancreatic adenocarcinoma? Just raise your hand. This is better with the audience thing because you can really see. Okay, so some people have kind of put their hands up to their shoulder level. Pancreatitis with a related collection, a mucinous cystic tumor, or serous cystadenoma. This caused some controversy within the department, but my contention was in this case that these arterial changes are characteristic of encasement of a vessel, which is really makes pancreatic adenocarcinoma the #1 diagnosis in this case, which this turned out to be. Venous encasement is seen in pancreatitis, but this form of arterial encasement is extremely unusual except in pancreatic adenocarcinoma. Looking at the veins, this is actually a 10-year-old paper now, but there was initially some difficulty in understanding the pattern and the findings of involvement of the superior mesenteric vein. Superior mesenteric venous involvement in and of itself is not an absolute criteria for non-resectability. However, it's highly dependent on the skill of the surgeon and the experience of the institution in terms of whether or not those patients will go to surgery. In a young patient who's otherwise okay with no other signs of arterial, hepatic, or nodal metastases, venous involvement will be resected with a vein patch. In other institutions, if venous involvement is in fact diagnosed and the patient is still a candidate for surgery, probably best that that individual patient be referred to a center that does a lot of pancreatic surgery. Anyway, back a couple of, almost 10 years ago now, this group from Seattle found that a bunch of patients had dilated superior mesenteric venous tributaries, 7 of whom had no other signs of non-resectability but became non-resectable at the time of surgery due to irreparable damage of the superior mesenteric vein. So how does this work? And people became very interested in the findings of superior mesenteric venous involvement with pancreatic cancer. So here are 2 examples of gross involvement where the vein has gone from its circular appearance to more of an oblong or teardrop appearance. This has been popularized by the Mass General group, the so-called teardrop SMV, where if you see this finding, you can say that that superior mesenteric vein is involved with tumor. Here's another example, upstream dilatation of the pancreatic duct, a small tumor in the head of the pancreas, but notice at this level the appearance of the superior mesenteric vein is oblong. It's actually been involved with the tumor right at this level, and it's a larger consideration as to whether or not this patient is going to be resected. We can get this on MR as well. Here in the coronal, here you can also see a teardrop SMV on this MRV. The other pattern of collateralization when the superior mesenteric vein is not involved refers to findings posteriorly. So here's a patient with dilatation of the pancreatic duct to this level. The vein itself was round throughout its course, but there was prominent posterior venous collaterals, which you can see right back here. The visualization of those veins is highly significant in patients with neoplasms in the head of the pancreas, because what this shows is when these posterior pancreaticoduodenal veins are involved, even if the main superior mesenteric vein does not appear to be involved, nor even if there's physical contiguity of that tumor with that vein, the visualization of those collaterals is highly predictive of significant superior mesenteric venous involvement, which would require resection of the vein or probably not a clear margin at the Whipple resection. Okay, we have to be reminded that distant metastases are a problem. Again, this is why we get our portal venous phase acquisition here on the arterial phase. Very small tumor in the head of the pancreas, for all the world, totally resectable. Here during the portal venous phase, same patient, same time, was this little guy, which is a proven metastasis. So, you know, we're dealing with a very bad disease, and we certainly don't want to make the patients worse by undergoing unnecessary surgery, and we require our top imaging techniques in order to detect all of these possibilities. Let me close by talking about visualization of the pancreatic and biliary duct systems. Two ways to do it, with MRCP in the traditional ways with HASTE and 2D, now with 3D, and then with CTCP. Our traditional ways of acquiring, and this has been around now for at least 10 years, probably longer, we use our HASTE sequence, which is T2 weighted, and you get nice visualization of a dilated pancreatic duct and a dilated common bile duct coming down to the ampulla. Here's the same patient with a 2D single shot long echo train MRCP. Again, a small periampullary tumor with a double duct sign. These types of MRCPs are constrained to the plane of acquisition, but provide elegant images for treatment planning. Now we have the ability to acquire 3D MRCP with respiratory triggering, with the ability to acquire 2 to 3 millimeter slices with isotropic voxels, even now 1 millimeter slices with higher field and parallel imaging capabilities. And we also have the ability now to look at secretin, which I'll talk about briefly in a second. So we are moving now from the 2D MRCP to the 3D MRCP. There were a number of exhibits about this at the RSNA, and let me just illustrate this to you. So here's an example of one of our 3D MRCPs. The images are robust. I hate that term, but I got to use it here. Nice pancreatic duct, common bile duct, excellent visualization of the bowel. Here's a different patient in 3D with a periampullary tumor with all of the findings of that you know for the double duct sign. Now, the advantage of these things is that because you acquire in 3D, you have your source images, and you can actually follow this very small pancreatic duct. Patient has extensive von Meyenberg complexes here. You can see the common bile duct. And once you have source image data like this, you can actually move this and constrain this to virtually any plane of imaging. The importance of this is that you need to remember that previously in 2D, the display was a projection technique, a MIP technique, and I'll talk more about this later this afternoon. But a MIP will project the brightest ray along the line of sight, and it's very difficult to determine in MIP the physical contiguity or lack thereof between a bright signal in a mass and a bright signal in a duct. Is this mass communicating with this duct? Is this mass communicating with this duct? It's a coin toss, very hard to tell. But now in 3D, we actually have the ability to take these images, to rotate them. Here's a patient with a pancreatic divisum, a Santorini seal, a tiny cystic mass, and you can actually see the communication right up there. Here's a patient that came in just last week with a large cystic mass in the head of the pancreas. On the source images, you're able to isolate the pancreatic duct, show that it does not communicate with this mass. This turns out to be metastatic ovarian cancer to the head of the pancreas. With secretin, there's a whole variety of things that you can do, and secretin, I think, hopefully in the next couple of years will be part of our armamentarium for looking at pancreatic diseases. It's extremely valuable. There's a company that's making a recombinant RNA form. Hopefully that'll be more widely available and more affordable. A variety of things that it can do, but nevertheless, in certain situations, it's invaluable. So here's the duct penetrating sign. These are two patients with MRCP, which shows a stricture of the pancreatic duct here, and in this patient, right up here. After secretin, you can see that this stricture fills out. This stricture remains tight. There's no visualization of the duct here. When you see filling out of a stricture, that's usually inflammatory, high degree of accuracy. When it doesn't fill out after secretin, that stricture is generally neoplastic. So let's take this case. This is another case. Here's a 63-year-old patient who came in with this MR, and he has an obstruction of the pancreatic duct at this level. He has a stricture right at this level. He was given secretin, and there was no change. So what would you expect this to be? What would you do with this case? No change after secretin and a focal stricture in the mid-pancreatic duct. Do we follow him for idiopathic chronic pancreatitis? Do we do a distal pancreatectomy, a Whipple resection, or do we stent this? So you can think about the answer. The correct answer is 3. He had a Whipple resection, no mass, just a tiny little stricture. And here's what happened. Here are the pathologic slices. Now you can see the duct is dilated. Where it stops, you hardly see a mass. But at pathology, here's the duct, and there's a tiny little neuroendocrine tumor distal and away from the duct in the pancreatic parenchyma that was causing the duct obstruction. Most places now, my friends in Verona will resect on cases like this, and it's a very powerful sign. Actually, I was told that this is probably a somatostatinoma. This is very typical. It produces a lot of fibrosis. We can do some duct imaging with CT. We can't do secretin analysis, but with thin section 3D CT, we can get some elegant pictures. Here you can see a normal pancreatic duct. You can see a persistent accessory duct. This is not a divisum. This is just a normal configuration. Most people do duct analysis on CT using the curved MPR, where you can trace a line of reconstruction along the plane of interest. And here's a curved MPR of a patient with chronic pancreatitis. This works very well. Here's a patient with acute pancreatitis, duct disruption at this level with exudation of pancreatic juice at this level of central cavitary necrosis. Occasionally you can get a nice visualization with the curved MPR in patients such as this. Curved MPR, though, is constrained to the plane of reconstruction. So even though we suspected divisum here in this patient with a small Santorini seal, when we do a 3D mini-MIP now, we're not using the volume render. We're looking at the minimum intensity projection. We can see the Santorini seal, the common duct, and the duct of Wirsung, and make a confident diagnosis of pancreas divisum in this case. Some other examples here. This was a patient who was sent to us with an enlarged head of the pancreas, rule out tumor. Clearly, when you can see the ducts going through there with this kind of accuracy, you know that there's no tumor present. We can see a persistent accessory duct. We can see the main duct coming into the ampulla with a common duct. The ducts that we see now, this was done with a 4-slice scanner. This is a 1.4 millimeter in diameter duct, and I think we can probably see smaller. How does this work with pancreatic cancers? Here's a patient with biliary obstruction, which we follow down. You can see a dilated common duct, and finally we get here, we see a stone, which I would have thought would have been in the distal common bile duct until we do the off-axis imaging. We can see that her duct is dilated, but that the stone is in fact in the pancreatic duct, not in the common bile duct. So that spared her an unnecessary ERCP to try and remove that stone. Here's a patient with a pancreatic cancer. You can see upstream dilatation, infiltrating mass in the body of the pancreas, nodes in the porta hepatis causing biliary obstruction. Here is a patient who was sent for abdominal pain, and really the only thing that kind of signaled us into this very vague area of low attenuation was the upstream dilatation of the pancreatic duct. Another example is this, a patient presented with small bowel obstruction. This was not diagnosed prospectively by me or anybody else who looked at this case. Here in the axial plane, things look pretty good. When you apply a mini-MIP and turn it, you can see, though, that there's upstream dilatation of the main pancreatic duct, and this body of the pancreas looks a little bit irregular. Unfortunately, this patient actually had an unresectable tumor at this level. Here's another patient with a pancreatic tumor at this level. There's no mass. All there is dilatation of the main pancreatic duct up to this level with a normal downstream duct. And again, I urge you to be particularly aware of the appearance of the pancreatic duct. Segmental duct obstruction, it's a very important finding. Here's a patient with a large mass in the region of the head of the pancreas presented with jaundice. If we turn our mini-MIP onto this same patient, you can see now that the pancreatic duct is totally normal. It's bypassing this mass. In fact, this mass is not even in the pancreas. It's extrapancreatic. The duct itself, we can follow it right around that mass. And this turns out to be a peripancreatic lymphoma in this particular individual. Another extremely useful analytic tool that you have with duct imaging is illustrated by this pair of cases. These are two patients with cystic masses in the head of the pancreas, patient A and patient B, and let's take a look at each of them. So first we'll look at patient A, and this is how we kind of work this on a workstation. You can see that we acquire our data, we put it on a workstation. This is me doing this, so it's a little bit twitchy, I apologize. You can see you used to be able to see the main pancreatic duct, and then the rest of this movie is not playing properly. But there's a little IPMT that's sticking off right there, if I can freeze it right. You can see this little IPMT that's actually coming off, accounting for the cystic mass in the first patient. This is the next patient with a similar appearing cystic mass, and here we can apply the same type of technique. Again, here the pancreatic duct is skirting the mass. There's no evidence of communication. This was biopsied under, this one was actually aspirated under EUS, and as expected, serous fluid was withdrawn. This turns out to be an oligocystic serous cystadenoma. So the duct imaging is extremely useful when you have a cystic pancreatic mass for differential diagnosis between an IPMT, which probably will get followed, versus a serous cystadenoma, which can be left alone, all other things considered. Let me just end here and just question, is this pretty pictures versus value? So we'll talk this afternoon about workflow in 3D. I think that unless you're really extracting information like this, you're not leveraging the volume capabilities of the scanners that you have purchased or the MRs. We can get clinically relevant images that help surgeons, that help radiation therapists, and we go beyond diagnosis to disease visualization. I think that's going to be an overarching theme throughout the morning. CTA and MRA, I hope I've shown you, improves the selection of patients. It's useful for preoperative planning. Duct imaging, again, I've touched on the ability to do functional imaging with secretin. Liz will talk more about this in her workshop. Detection of anomalies, I illustrated a pancreas divisum for you. Differentiating communicating versus non-communicating cystic lesions, and the earlier detection of cancer. This is a paper from Mayo Clinic where they found, going back in patients who were sent to Mayo Clinic, looking at old scans on those patients, the single earliest finding that they could detect before the patient presented with unresectable disease was abnormality of the pancreatic duct. So with that, welcome everybody. I hope we're off to a good start this morning. Thank you.
So good morning, ladies and gentlemen. I hope you enjoyed the dinner of yesterday evening. So this morning we will discuss this topic concerning dilated pancreatic duct. Before to talk about the dilation of the pancreatic duct, few words about the normal pancreatic ducts, which consist of the main pancreatic duct, the side branches, and eventually the anatomical variants. May be interesting to remember that the face description of the main pancreatic duct was made by Wilson, who was a German anatomist, but at that time he worked in Italy, in Padua, in the old University of Padua. The normal main pancreatic duct, the Wilson duct, has a diameter which depends on the site. In the head is 3.5 millimeter, in the body is 2.5 millimeter, in the tail 1.5 millimeter. Maybe that we are less interested in the length of the main pancreatic duct, but this varies from 9.5 centimeter to 25 centimeter. And how can we image the pancreatic duct? Well, today we have several possibilities with ultrasonography, of course, with multi-detector computed tomography, with MRI and magnetic resonance cholangiopancreatography, and of course with ERCP. However, today the most important modality has become magnetic resonance imaging with magnetic resonance cholangiopancreatography. The dilation of the pancreatic duct may be complete when the dilation involves most of the main pancreatic duct from the papilla to the tail of the pancreas, or partial dilation when the dilation involves only a part of the MPD, like a segment in the tail, in the body, or in the head, or eventually in the body tail, or in the head and the body. We can have also multiple segmental dilations. And the dilation, either complete or partial, can be associated with stenosis or occlusion, or without stenosis or occlusion. And we will try to cover all these different possibilities. All the pathologies involving the pancreas can produce dilation of the pancreatic duct. However, acute pancreatitis will rarely be associated with dilation of the pancreatic duct, while chronic pancreatitis and pancreatic tumor are usually associated with dilation of the main pancreatic duct. So we will start looking at these pathologies. We start with acute pancreatitis. I've already said that acute pancreatitis is rarely associated with dilation of the main pancreatic duct, and this is because of the compression of the pancreatic edematous parenchyma on the ductal system of the pancreas. Dilation can be seen in high-grade necrotizing acute pancreatitis, like grade C and D of Balthazar classification. Anyway, the degree of dilation will be mild, like in this example of extensive acute necrotizing pancreatitis of the head of the pancreas, where we see mild dilation of the main pancreatic duct and side branches, which is well demonstrated on this MR cholangiopancreatography. Another case of dilation of the main pancreatic duct, well seen at computed tomography, MRCP and ERCP, probably due to a major involvement of the head of the pancreas in this case, which produced some degree of compression of the proximal part of the main pancreatic duct. Another example of extensive acute pancreatitis involving the head and the surrounding structures, with dilation of the main pancreatic duct, which show irregularities, which are best demonstrated at the MRCP with these irregularities. This is because this patient had a history of recurrent pancreatitis with an acute episodes of acute necrotizing pancreatitis. Moving to chronic pancreatitis, in this disease we will see a frequent dilation of the main pancreatic duct associated with strictures, irregularities, and ectasia of the side branches. This is well known and is the basis of the Cambridge criteria. Cambridge criteria were based on previously ERCP, but this classification divides Cambridge 1, in which there are no abnormalities of the pancreatic ductal anatomy, Cambridge 2, in which there is dilation of less than 3 side branches, Cambridge 3, which is a mild disease where we have 3 side branches with a normal main pancreatic duct, 4, in which there are similar findings to category 3, plus stenosis and dilation, and Cambridge 5, where we have additional calculi, obstruction, cyst, and stenosis. These are examples of this classification based on MRCP, a normal pancreatic duct, a Cambridge 2, where we detect only 2 side branches and the borderline main pancreatic duct, a Cambridge 3, where we see still a borderline dilation of the main pancreatic duct together with multiple dilation of the side branches, a Cambridge 4, where we see a definitely dilated main pancreatic duct with irregularities and dilation of the side branches, and the Cambridge 5, where we see additional filling effects, which are best demonstrated on computed tomography, as computed tomography is the most sensitive technique to show the presence of stones. However, we have also to remember that chronic pancreatitis may be either diffuse or focal, and so we can have a similar appearance to the previous case with dilation of the main pancreatic duct, irregularities, cysts, and side branches dilated, or focal, where we see a stenosis of a segment of the main pancreatic duct with upstream dilation with dilated side branches. It is also important to note that these images has to be compared with the axial images, where we see the extensive involvement of the pancreatic parenchyma, which appears hypointense on this T1 weighted fat-sat image due to the fibrotic evolution of the pancreatic parenchyma. In this case of focal pancreatitis, chronic pancreatitis, we detect the diffuse hypointensity of the involved pancreas, and you can see the normal appearance of the head of the pancreas, which has its normal high signal intensity and normal vascularization following contrast administration. When considering chronic pancreatitis, we have to remember that it may be very useful to use secretin stimulation to study the duct and the function of the pancreas. Secretin gives a measurement of pancreatic secretion volume and enable to assess the exocrine function of the gland. But very important, it provides more detailed information about ductal changes. This is an example. Without secretin, we see irregularities at the level of the tail of the pancreas, one side branch dilated. Following secretin administration, we see the increase in size of the main pancreatic duct, but at least 1, 2, 3, 4 side branches dilated. At the end of the test, at 10 minutes, we see that the main pancreatic duct has the same caliber as the basal study. So this is a normal function of the pancreas with normal filling of the duodenal loop. Chronic pancreatitis usually classified, especially in the advanced stage, as obstructive pancreatitis and non-obstructive pancreatitis. Obstructive pancreatitis is generally due to inflammatory stenosis at the level of the major papilla or to malformations like pancreas divisum or scars as a result of episodes of acute necrotizing pancreatitis, or due to the duodenal wall dystrophy or paraduodenal pancreatitis, and in few cases to slow-growing tumors. Just an example, this is a patient in which we have a baseline study before secretin, in which we see some degree of dilation of the main pancreatic duct, but this becomes obvious following secretin administration. We see the dilation of the main pancreatic duct. We detect also a dilation of the Santorini duct. At the end of the test, at 10 minutes, we see that the duct is still dilated, and this is an indirect sign of an inflammation at the level of the papilla. You can notice, however, that in this case the function, the exocrine function, is still maintained with good filling of the duodenal loop. The non-obstructive pancreatitis are the autoimmune pancreatitis and gene mutation associated pancreatitis. It is interesting to remember, however, that autoimmune pancreatitis is not associated with dilation of the main pancreatic duct, since the duct is compressed by the cellular material, by the lymphoplasmocytic infiltrates around it. And so, in general, as in this case, we see diffuse and irregular narrowing of the main pancreatic duct and associated involvement of the biliary ducts, as in this case, and which can involve also the intrahepatic bile ducts in a form of autoimmune cholangitis, or whether, in some cases, autoimmune pancreatitis can be associated with dilation of the main pancreatic duct. This occurs in cases of focal pancreatitis, mainly located in the head of the pancreas, since this disease compresses the main pancreatic duct, so we have an upstream dilation of the main pancreatic duct in some cases of focal autoimmune pancreatitis. Moving to pancreatic tumor, in these cases we see frequent dilation, but also in the cases of pancreatic tumors, we can make a distinction between those tumors which are frequently associated with dilation of the main pancreatic duct, such as pancreatic adenocarcinoma, tumor of the papilla of Vater, IPMN of the main pancreatic duct, and those tumors which are rarely associated with the dilation of the main pancreatic duct. In few cases, we will see dilation with neuroendocrine tumors or with cystic tumors like serous and mucinous cystoadenomas and mucinous cystoadenocarcinomas. Rarely, there is dilation in cases of IPMN of the branch ducts also. Concerning pancreatic tumor and dilation of the main pancreatic duct, we see irregular ductal stenosis associated with dilation of the upstream main pancreatic duct and side branches because the tumor causes a chronic obstruction. So what we see is an upstream obstructive chronic pancreatitis in many of these cases. An additional sign, very important, is the double duct sign, which is seen in the lesion of the head of the pancreas and consists in the dilation of the main pancreatic duct and the common bile duct. In cases of lesion located in the body and tail, we will see usually an abrupt narrowing with upstream dilation of the main pancreatic duct. So this is the typical double duct signs, dilation of the common bile duct and the Wirsung duct caused by a pancreatic tumor, a pancreatic adenocarcinoma, which cause this type of obstruction. Alternatively, the same feature can be caused by a tumor located at the level of the papilla, as shown in this slide, where we see the dilation of the main pancreatic duct and the dilation of the common bile duct. Similar feature are seen in MR imaging. This is a typical appearance of the double duct sign with MR imaging, dilation of both ducts. And of course, we have also always to rely on the coronal and axial images where we see this mass at the level of the head of the pancreas with this necrotic appearance, a typical case of pancreatic adenocarcinoma. Another example of double duct signs, dilation of the two ducts with a filling defect at the distal common bile duct, which may resemble large stones, or whether we have always to refer to the axial or coronal images. And in this case, it is rather obvious that this lesion is enhancing following contrast administration, and this was a case of tumor of the papilla of Vater. The abrupt narrowing with the upstream dilation is seen in more distally located lesions, like in tumor of the body or tail of the pancreas, which infiltrates the main pancreatic duct and cause this type of dilation, or extensive lesion located in the head of the pancreas. In this case, we see the dilation of the main pancreatic duct at the level of the body and tail of the pancreas. However, the cases are not always so obvious because we can see dilation of the main pancreatic duct, two examples of different types of stenosis, but these two cases may resemble very similar if we compare the two images. And it has shown in the recent past that the injection of secretin may be of value in these cases, because after secretin injection, in the case you see the tract which was stenosed filling with the fluid, this will be a benign stricture, while if there is no filling of the segment which was involved previously to secretin injection, this is most likely to be a malignant lesion. So this is a case of obstructive chronic pancreatitis, and this is a case of adenocarcinoma of the pancreas, of the head of the pancreas, and this sign is called duct penetrating sign. It was described by Ishikawa in 2001, and it is of value when you have to differentiate some difficult stenosis of the pancreas. Another cause of dilation of the main pancreatic duct is, of course, IPMN. IPMN may be segmental or diffuse. They involve the main pancreatic duct. In other cases, when associated with branch ducts dilation, we call mixed IPMN. of course, IPMN, may involve only the branch ducts, the secondary or IPMN of the branch ducts. In cases of IPMN, we have ductal dilatation, which can be generalized or segmental. The ectasia is caused by a papillary tumor like this one that completely fills the duct, or by a tumor in the proximal portion of the main pancreatic duct mechanically blocking the entire duct because it is filled by mucus secretion. Here we have a series of examples of IPMN involving the main pancreatic duct. You see this feature of sharp margin. In general, the main pancreatic duct has sharp margin, and this is one of the differential criteria with the dilation we see in chronic pancreatitis. The involvement may be complete, as in this case, or partial, as in this case, where the major involvement is in the body tail of the pancreas. You can see that in some cases, the enlargement and the involvement of the main pancreatic duct is very, very large, very impressive. In other cases, we will see filling defects within the dilated pancreatic duct. These filling defects may be due either to mucus content or to papillary projection, as in this case where we see this papillary projection inside the dilated main pancreatic duct, with showing enhancement following contrast administration. Moving to the pancreatic tumors with rare dilation, in general, dilation with neuroendocrine tumor, like in this case, is not so common. This criteria is one of the criteria for the differential diagnosis between pancreatic adenocarcinoma, which is associated with dilation of the main pancreatic duct, and neuroendocrine tumor, which usually are not associated with dilation, or whether you can see, of course, some degree of dilation, like in these cases, also with large neuroendocrine tumor. An interesting example of neuroendocrine tumor, which involves the main pancreatic duct, can be seen in these two cases, in which we detect mild dilation of the main pancreatic duct at the level of the tail of the pancreas, caused by this small area of enhancement at the level of the initial dilation of the main pancreatic duct. Another example of dilation, and you may see in this area a small enhancement at the level of the initial dilation of the main pancreatic duct. Both these cases were operated, and you may see the lesion of this case located in this part of the anatomic specimen. This is the Wirsung duct, which was dilated. Both cases were classified as carcinoma, and there is an interesting study which dedicated to this type of lesion. A small carcinoid may produce dilation of the main pancreatic duct because they produce serotonin, and serotonin produces fibrosis around it, like the same we see at the level of the mesentery, and this is the explanation for this dilation of the main pancreatic duct. Rarely, but it is possible to see dilation of the main pancreatic duct also in cases of large cystic tumor, like in this example of large mucinous cystoadenocarcinomas of the tail of the pancreas with this dilated main pancreatic duct with sign of chronic obstructive pancreatitis. Finally, the IPMN of the branch ducts may be associated with dilation. They, in fact, are cystic dilation of the secondary ductal system, usually very small, may be unifocal and multifocal, and these are a series of examples of very small IPMN and IPMN isolated, IPMN at the level of the tail of the pancreas, multiple IPMN. The typical IPMN are these cases in which we see a definite communication with the main pancreatic duct. And you may notice that this main pancreatic duct has a mild dilation. The explanation of this mild dilation may be two causes. One is that it could be an associated mixed IPMN. That means that the IPMN involves these ducts, but also the main pancreatic duct. But an alternative is that the mucus produced by the IPMN go inside the main pancreatic duct, and the flow is obstructed by the mucus. So the main pancreatic duct is relatively dilated for a sort of sub-obstruction. Dilated pancreatic duct in case of IPMN raise the risk factor for the presence of carcinoma. This is a controversial topic, so I will be very short on this topic. There is the possibility of a neoplastic evolution. There is a wide range of reported data in the literature from 6 to 46%, but this afternoon there will be a lecture on this topic, so I will go very fast. Criteria for risk are the association dilation of the main pancreatic duct, mural nodules, cyst size greater than 3 centimeters. Cyst size greater than 3 centimeters is an important factor. So we have seen different examples of dilation of the main pancreatic duct and associated side branches in cases of acute pancreatitis, chronic pancreatitis, and different type of tumors. And we have seen cases of complete dilation, partial dilation, associated or not with stenosis or occlusion of the main pancreatic duct. I will go through few examples just to simplify the approach to the dilation of the main pancreatic duct, starting with some cases of complete dilation associated with the stenosis. When we see a dilation complete or almost complete of the main pancreatic duct, we have to think to common causes and rare causes. Among the common causes, pancreatic adenocarcinoma is the first possibility. And when we see a double duct sign, it is the most likely possibility, like in this example, which is of course confirmed by the other sections we obtained during the MR examination, which shows a relatively large tumor of the head of the pancreas. So this was a pancreatic adenocarcinoma. Another possibility, again, two double duct signs. Both the ducts are dilated, but we see filling defects both in the common bile ducts and the pancreatic duct. These represent stones. So we are with the case of pancreatic chronic pancreatitis as confirmed by computed tomography in this case. So this is rather obvious. This may be a more difficult case. We have dilation of the bile ducts and not too much, but also the main pancreatic duct is dilated. So we have again a double duct sign, and I have said that in general when we see a double duct sign we have to think to a neoplastic condition first. But in this case, if we look at the axial images, we see that there is a low signal intensity in the head of the pancreas, which is enlarged in the basal scan, but following contrast enhancement, we do not see the low signal intensity area we usually see with pancreatic adenocarcinoma. In the equilibrium phase, we see that there is a late enhancement, and we learn that this is one of the features of autoimmune pancreatitis. Additionally, if we look closely the main pancreatic duct, we see multiple strictures. And multiple strictures are another feature of autoimmune pancreatitis. So this case was effectively an autoimmune pancreatitis. Moving to dilation without stenosis, the most likely possibility is IPMN of the main pancreatic duct, and these are other cases of extensive IPMN of the main pancreatic duct. These are really mixed IPMN of the main pancreatic duct. But again, the diagnosis in these cases looks not very difficult. This can be demonstrated also with CT. I usually show cases of MR when concerning IPMN of the main pancreatic duct, but I want to point out that also CT can show dilation with uniform margin with associated dilation of the side branches, representing a case of mixed IPMN of the main pancreatic duct. Moving to the partial dilation with stenosis or occlusion, well, we have seen in the previous part that partial dilation of the main pancreatic duct with stenosis, among common causes, we will find pancreatic adenocarcinoma. And of course, this is the most likely possibility. And the axial section will confirm the presence of a low signal intensity area in the T1 FAT-SAT image with non-homogeneous enhancement following contrast administration and restriction in diffusion-weighted images and ADC, or whether there are also other causes. But this is the most common cause, and all cases like this will be first a pancreatic adenocarcinoma and then other possibilities. Alternatively, we can see rarely neuroendocrine tumor, other cystic lesion, autoimmune pancreatitis. But remember, when you see a lesion like this or a lesion like this will be most likely a pancreatic adenocarcinoma. You may use, as we have already seen, secretin administration. If you don't see the filling of this segment, of the stenotic segment, this will be a pancreatic adenocarcinoma, as shown in this example. Look at this case. We have dilation of the main pancreatic duct upstream this lesion, but of course we have the possibility to understand that this is not a case of pancreatic adenocarcinoma, because following contrast administration we see the enhancing lesion to a degree similar to that of the aorta, so this is a neuroendocrine tumor, while these are rare cases of cystic lesion, large cystic lesion. This is a serous cystoadenoma, which cause dilation of the upstream main pancreatic duct. Rare causes, but it has to be remembered, of dilation of the main pancreatic duct can occur following acute pancreatitis, acute necrotic pancreatitis. If we see this stenosis the first time, it may be difficult to characterize this type of stenosis, but the clinical histories, and especially previous imaging, will explain the reason for this stenosis. This patient had an extensive acute necrotizing pancreatitis, which evolved positively with regression, with the solution of this fluid collection, but a scar developed at this level. 1 year before, the patient had already some degree of dilation of the main pancreatic duct, and 1 year later there was a dilation, a definite dilation, and so this was a case of scar post-acute pancreatitis. And also autoimmune pancreatitis sometimes has to be considered in the differential diagnosis. Remember, multiple stenosis of the main pancreatic duct at MRCP. Think the possibility of this relatively rare condition. Of course, you will rely also on this other imaging feature, the enlargement of the gland, the late enhancement in the equilibrium phase typical of this disease, and eventually you have also the follow-up for after steroid therapy, which will show the decreasing size of the gland and the almost normal appearance of the main pancreatic duct following steroid therapy. We have also the possibility of dilation without stenosis of occlusion. This occurs in cases of IPMN of the main pancreatic duct. We have already seen this example. You see dilation, but you don't see stenosis. So although this case may be difficult, when you see a dilation of the main pancreatic duct without stenosis, think to the possibility of IPMN of the main pancreatic duct. This is another example with computed tomography. We have this dilation, isolated dilation, but there is no stenosis. We see the dilation till the papilla without a definite stenosis. So we have to think to the possibility of an IPMN of the main pancreatic duct. So we have seen different cases in different pathologies of dilation of the pancreatic duct system. This is there is a controversy in the literature about the significance of slight dilation of the main pancreatic duct associated or not to the presence of pancreatic cyst. If you go to the literature, you may find different papers on these topics. First of all, this paper from Tanaka, which published in the Japanese literature in 2002, a paper concerning main pancreatic duct dilation, a sign of high risk for pancreatic cancer. There are a number of papers concerning the significance of cyst in the pancreas. I refer to this by Fernandez del Castillo, incidental pancreatic cyst, clinical pathological characteristics. More recently, in Radiology 2010, the same Japanese author presented a paper on slight dilation of the main pancreatic duct and presence of pancreatic cyst as predictive signs of pancreatic cancer. This was a prospective study based on large population, and in the same number of radiology, there is a commentary, an extensive commentary by Megibov on the paper from Tanaka. So this is another important feature on the significance of the dilation of the pancreatic duct, which is rather different from the cases we have seen. But the important thing coming from this paper is that this author, by monitoring this group of patients for a long period of time, they demonstrated that there is an increased risk to develop pancreatic cancer in the patient with dilation of the main pancreatic duct greater than 2.5 millimeter measured at ultrasound, and similar features were found concerning cyst. If patient had both main pancreatic duct dilation and cyst, the pancreatic cancer development was more likely, and they predicted that the incidence could be about 1,000 per 100,000 versus 37.5 cases per 100,000 in the normal population matched for same age. So these are data which are important. We can understand that these data are important, and at the end of the paper they recommend periodic checkup at least once a year for people with slight dilation of the main pancreatic duct and pancreatic simple cyst. And in fact, we agree partially with this conclusion. We also make follow-up for cyst in the pancreas. So this is an example of probably many of those cysts in the paper of Tanaka were IPMN of the branch duct. This is one of our cases in which 2 years later we see a mild increase in size of this IPMN located at the level of the head of the pancreas. In our experience on a series of more than 150 patients, or whether we see very mild changes over time in the mean follow-up of these lesions. In the head, there was a very mild increase in the size of the cyst. This was something, there was a greater increase in the size of the cyst in the body tail of the pancreas. But anyway, in the mean of 2 years, but we have patients with a longer follow-up of 5 years and more, this change in size was minimal. And similarly, in the same paper, we could observe a very mild increase in the size of the main pancreatic duct, no change in the size in the head of the pancreas, a mild change in the size in the main pancreatic duct in the body tail of the pancreas. So there we recognize that there is a predictive value to the development of a risk of pancreatic adenocarcinoma in the presence of slight dilation and cyst, or whether, as pointed out by Megibov, in the same number of radiology, we have to think about the risk of overdiagnosis, over-testing, and of course, increased cost when evaluating these mild changes at the level of the pancreas. So to conclude my presentation, dilation of the main pancreatic duct is an important sign, as we have seen in my presentation, but it has to be evaluated together with other imaging features to reach a correct diagnosis of the pancreatic diseases. So I thank you for your kind attention. Thank you very much.